I would like to call this meeting of the Ophthalmic Devices Panel of the Medical Devices Advisory Committee on March 21, 2024 to order. It is now 9 a.m. I am Dr. Jane Weiss, the chairperson of this panel. I'm chair of the Department of Ophthalmology and Associate Dean of Clinical Affairs at LSU Health Science Center in New Orleans and Chief Medical Officer of the LSU Healthcare Network. I note for the record that the voting members present constitute a quorum as required by 21 CFR Part 14. I would also like to add that the panel members participating in today's meeting have received training in FDA device law and regulations, including training on the de novo classification request pathway. Please be aware that this meeting is being recorded and will be accessible to the public, including the Zoom chat. For today's agenda, the committee will discuss, make recommendations on information related to the de novo request by Balance Ophthalmics Incorporated for the safety and effectiveness of the FSYX Ocular Pressure Adjusting Pump, or the FSYX OPAP System. The FSYX OPAP System is indicated as adjunctive therapy for the reduction of intraocular pressure during use in adult patients with open-angle glaucoma and intraocular pressure equal or less than 21 millimeters of mercury. Please advise that all participants should show their videos and mute themselves until acknowledged by the chair, which each participant can use the icon, the raise hand icon at the bottom of the screen, and they may unmute themselves when acknowledged by the chair. Please use the reaction button to lower the hand after done speaking and mute yourselves again. Before we begin, I would like to ask our distinguished committee members and FDA representatives attending virtually to introduce themselves. Committee members, please turn on your video monitors if you have not already done so and unmute your phone before you speak. I will call your name, and then please state your area of expertise, your position, and your affiliation. Elijah Ray. And Mr. Ray, if you could unmute yourselves, thank you.
Yep. Good morning, everyone. I'm Elijah Ray, and I'm on this panel for the industry. I work for Boston Scientific as Senior Regulatory Affairs Manager.
Thank you. Dr. Edwards Loftspring.
Good morning. I am a consumer representative on the FDA consumer panel.
Barbara Burney.
Good morning. I am your patient representative. I have lots of experience with eyeball stuff. That's about the best I can tell you. I know Jane and I know Dr. Edelman well.
Thank you. Dr. Carla Ballman.
Hi, I am a professor of biostatistics at Mayo Clinic, and I have expertise in clinical trial and study design.
Dr. Eve Higginbotham.
Good morning. My name is Eve Higginbotham. I'm a glaucoma specialist. I'm a professor of ophthalmology, as well as a senior fellow at the Leonard Davis Institute for Health Economics and a vice dean at the University of Pennsylvania.
Dr. Joel Schuman.
Hi, Jane. Hi, everybody. I'm Joel Schuman. I'm a glaucoma specialist at Wills Eye Hospital, vice chair for research innovation, and look forward to participating on this panel.
Dr. Richard Parrish.
Good morning, Dr. Richard Parrish. I'm the Edward W.D. Norton Chair in Ophthalmology. I'm a specialist in glaucoma at University of Miami Miller School of Medicine, the Ann Bates Leach Eye Center, Bascom Palmer Eye Institute, Miami, Florida.
Dr. Greg Skuda.
Good morning, Greg Skuda. I'm a professor and past chair of ophthalmology, Dean McGee Eye Institute in Oklahoma City, and a glaucoma specialist.
Dr. Donald Budens.
Hi, Don Budens, chair of ophthalmology at the University of North Carolina at Chapel Hill and a glaucoma subspecialist.
Dr. David Glasser.
Good morning, David Glasser. I'm a cornea and external disease specialist. I'm the emeritus faculty at Hopkins.
Dr. Andrew Wong.
Good morning. I'm Andrew Huang. I'm a professor of ophthalmology at Washington University in St. Louis, and I'm a cornea specialist.
Dr. Grace Levy-Clark.
Good morning. I'm Dr. Grace Levy-Clark. I'm an associate professor at the West Virginia University Eye Institute, and I am a uveitis specialist.
Dr. Michael Repka.
Good morning. I'm Michael Repka. I'm a pediatric ophthalmologist at Johns Hopkins University in Baltimore and vice chair for clinical practice of the Wilmer Institute.
Dr. TV Wen.
Hi, good morning, everyone. My name is Tuvi Wen. I'm the director of the Division of Ophthalmic Devices at FDA.
Dr. Malvina Edelman.
Good morning and welcome, everyone. My name is Malvina Edelman. I'm Director of Office of Health Technology 1 here at FDA. And I want to thank all of you for joining us today and look forward to a very productive discussion.
I want to remind all attendees to please mute their microphone until they have been called on to speak. If you have a question, you may use the Zoom hand raise function. Dr. Akinola Awajopi, the designated federal officer for the Ophthalmic Devices panel, will now read the conflict of interest statement.
Good morning, everyone. I will now read the conflict of interest statement. The Food and Drug Administration is convening today's meeting of Ophthalmic Device panel of the Medical Device Advisory Committee under the authority of the Federal Advisory Committee Act, FACA, of 1972, with the exception of the industry representative. All members and consultants of the panel are special government employees or regular federal employees from other agencies and are subject to federal conflict of interest laws and regulation. The following information on the status of this panel's compliance with the federal ethics and conflict of interest laws covered by, but not limited to, those found at 18 U.S.C. Section 208 are being provided to participants in today's meeting and to the public. The FDA has determined that members and consultants of this panel are in compliance with the federal ethics and conflict of interest laws under 18 U.S.C. Section 208. Congress has authorized the FDA to grant waivers to special government employees and regular federal employees who have a financial conflict when it is determined that the agency's need for a particular individual's services outweigh his or her potential financial conflict of interest. Related to the discussion of today's meeting, members and consultants of this panel who are special government employees or regular federal employees have been screened for potential financial conflict of interest of their own as well as those input to them, including those of their spouses or minor children, and for purpose of 18 U.S.C. Section 208, their employers. These interests may include investment, consulting, expert witness testimony, contract, grants, credits, teaching, speaking, writing, patents, royalties, and primary employment. For today's agenda, the panel will discuss and make recommendations on information related to the de novo request by Balance Ophthalmics, Inc. for the safety and effectiveness of the FSYX Ocular Pressure Adjusting Pump FSYX OPAP System. The FSYX OPAP system is indicated as adjunctive therapy for the reduction of intraocular pressure IOP during the use in adult patients with open angle glaucoma and IOP less than or equal to 21 mmHg. Based on agenda for today's meeting and all financial interests reported by the panel members and the consultant. No conflict of interest waiver has been issued in accordance with the 18 U.S.C. Section 208. Mr. Elijah Ray is serving as the industry representative acting on the behalf of all related industry. Mr. Ray is employed by the Boston Scientific Corporation, and for the record, the agency notes that Dr. Jane Wise has consented to serve as the chairperson for the duration of this meeting. We would like to remind members and consultants that if the discussion involves any other product or firms not already on the agendas for which an FDA participant has a personal or imputed financial interest, the participant needs to exclude themselves from such involvement, and the exclusion will be noted for record. FDA encourages all other participants to advise the panel of any financial relationship they may have with any firm at issues. A copy of the statement will be available for review and will be included as a part of the official transcript. In order to help the transcribers identify who is speaking, please be sure to identify yourself each and every time that you speak. The press contact for today's meeting is Eldred Harrison. Thank you very much. I'll hand it over back to Dr. White.
Sorry, you're muted.
We would now proceed to the sponsor's presentation. I would like to invite the sponsor to begin. I will remind public observers at this meeting that while the meeting is open for public observation, public attendees may not participate except at the specific request of the panel chair. The sponsor will have 90 minutes to present. You may now begin your presentation.
Good morning. Thank you for allowing us to introduce the FSYX Ocular Pressure Adjusting Pump, or OPAP, as an adjunctive therapy for lowering intraocular pressure during nightly use in patients with open-angle glaucoma whose intraocular pressure is 21 or less. My name is John Berdahl. I'm a practicing ophthalmologist and the founder of Balance Ophthalmics. We are grateful to share the compelling data regarding safety, effectiveness, and unmet need to help you determine if the benefits outweigh the risks of the OPAP in this difficult-to-treat population. As many of you know, glaucoma is one of the most difficult problems we ophthalmologists face, and there is a whole subspecialty dedicated to this single disease. Glaucoma is an optic neuropathy that leads to visual field loss and the death of retinal ganglion cells. It is the second leading cause of blindness globally and the leading cause of irreversible blindness. In the US, there are between 3 and 5 million people with glaucoma and 120,000 who are blind. The only way to slow progression in every type of glaucoma, including normal tension glaucoma, is by lowering intraocular pressure, or IOP. Although 60 to 70% of open-angle glaucoma patients have a high IOP, that is, greater than 21 millimeters of mercury, we are targeting the 30 to 40% of US glaucoma patients with an IOP at or below 21, also referred to as normal tension glaucoma. This population is more difficult to manage because most treatments are less effective in patients whose IOP is less than 21. And the treatments are less effective at lowering nocturnal IOP elevations, which are common in these patients and associated with glaucomatous progression. Patients with an IOP of 21 or less is the population we studied, and it is also the population with the greatest need. The unmet need in this group was recently highlighted in a joint paper by the American Glaucoma Society and the American Society of Cataract and Refractive Surgery. This paper emphasized the importance of the 24-hour IOP profile and the need for non-invasive therapeutics to lower IOP, especially in challenging patients who do not adequately respond to current therapies or those in whom IOP is already within the normal range. Let me tell you about one of my patients in this category, Jerry. He and patients like him are the reason we developed this technology. Jerry is blind in his left eye from a complication of a surgery I performed because there were no better options. His right eye is 2400, or the big E at the top of the eye chart. His IOP is what we would consider well controlled, ranging between 11 and 16, but he is still going blind despite the 9 eye surgeries I performed on his only seeing eye. Jerry and patients like him deserve better options, ones that will give them hope that they won't go blind. That is why we created this non-surgical, non-invasive, removable device, the Ocular Pressure Adjusting Pump, or OPAP. It's a pair of lightweight goggles that applies negative pressure over the anterior eye. It is attached to a quiet, programmable pump that with one button holds negative pressure within the goggles at a steady state. If vacuum is lost, an audible beep notifies the patient. The OPAP lowers IOP during nightly use, when most IOP elevations occur, and provides the negative pressure application to each individual goggle and can apply it bilaterally. It can be used adjunctively alongside other treatments. The OPAP also provides clinicians with data on patient compliance and device use. Let me provide a simplified example of how the device works. Our entire body, including our eyes, are pressurized by the weight of the atmosphere, which is pressing down on us. Think about the atmospheric weight like my thumb. If I pressed on your eye, the eye pressure would have to go up. Then if I stop pressing on your eye, the eye pressure would have to go down. The OPAP works similarly, based on physics. The weight of the atmosphere pressing over the eye is reduced by applying negative pressure within the goggles, and thus the IOP goes down. This reduction is not one-to-one. The OPAP reduces IOP by approximately 40 to 60% of the negative pressure applied because a new pressure-volume relationship is established. As discussed, our proposed indication for use is as adjunctive therapy for the reduction of intraocular pressure during nightly use in adult patients with open-angle glaucoma and intraocular pressure of 21 millimeters of mercury or less. It's important to note that we are proposing an adjunctive treatment modality and not a replacement for existing therapies. Now, here are the key questions the FDA is asking the panel to discuss today regarding clinical benefit, effectiveness, safety, labeling, and the benefit risk. Throughout this presentation, we will address each question to provide relevant information and perspective. Fundamental to many of these questions is this: does the OPAP device actually lower intraocular pressure? Now keep in mind, IOP is defined as the fluid pressure within the eye relative to the atmospheric pressure. To answer the question around whether the OPAP is reducing IOP, I will show you a series of data starting with the CONFIRM study. The CONFIRM study directly measured IOP via manometry in 17 patients prepped and about to undergo cataract surgery. The eye was cannulated with a manometer to continuously measure IOP every half second for 5 intervals. First, a baseline was established, then 10 millimeters of mercury of negative pressure was applied. NP was released, followed by negative pressure of -20, and then negative pressure was released again. Each interval was about 30 seconds. After this sequence was complete, patients immediately underwent cataract surgery. I will show you a video momentarily, but first, let me describe what you will see. The left image shows a titratable lab-based version of the pump, where we adjust and measure the negative pressure within the goggles. On the right, you will see a real-time IOP tracing. The spikes show a pinch test of the tubing done to ensure that IOP is being properly read, and a seal test to ensure the goggle seal is maintained. Once the baseline is obtained, -10 of negative pressure is applied and the IOP decreases from 14 to 9. Applying -20 of negative pressure drops the IOP from 14 to 7 millimeters of mercury. Now, here it is in real time.
start negative pressure here to -10. Oh, got a good seal, 30 seconds.
Holding it about -9, -10. And you can see the pressure tracing inside the eye corresponding down to around 8 to 9 millimeters of mercury from a baseline of around 13.
3, 2, 1.
Now the goggles, the pressure is being released down to 0. It's tracking down, and you'll see that the pressure should come back up in the eye, which it does, and now it's back at 0, and it returns to baseline. There's no pressure being applied right now. Hold that for a total of 30 seconds. You can see the anterior chamber maintainer inside the eye.
3, 2,
Now here comes
1.
down to -20. Pressure in the goggles falls almost exactly. It overshot momentarily, and you can see the pressure change inside the eye that corresponds. This is what the setup looks like here. The goggles holding seal and the negative pressure.
5, 4, 3, 2.
And if you watch the tracing, we'll release that negative pressure. Take a second for the pressure to go down in the goggles. It's coming down, and you can see that the pressure returns to baseline. Experiment complete.
This graph represents the mean IOP from all 17 patients and clearly demonstrates that the OPAP reduces IOP in a dose-response fashion. Negative pressure of -10, shown in light blue, lowered mean IOP 5.6 millimeters of mercury, a 33% reduction. Negative pressure of -20, shown in dark blue, lowered mean IOP 8 millimeters of mercury, a 51% reduction. These manometrically measured IOP lowering results are consistent with the measurements we will show you from our clinical studies and confirm that we are addressing FDA's question and actually lowering intraocular pressure, or IOP. Before I move on, I'd like to quickly draw your attention to the bottom footnote. FDA asked us to note on the slide, as well as verbally, any data not yet reviewed. These confirmed data were provided to FDA in our January 3rd response to their questions, but may not yet have been reviewed. In addition to the confirmed study, we also measured IOP directly in implanted IOP sensors, living donors, and cadavers, all showing similar results. Let me show you the cadaver data. The cadaver study allowed for direct IOP and retrobulbar pressure measurements via manometry during negative pressure application with the OPAP. As negative pressure was applied, IOP decreased. And when negative pressure was removed, there was a return to baseline, but not beyond. The retrobulbar pressure remained constant throughout. The spikes at the end of the graph represent a pinch test of the tubing to confirm that the system was accurately measuring pressure. The results we found with direct manometric IOP measurements are consistent with the results we found in our clinical trial. Now, let me describe how we measured IOP in the clinical trials. The most widely used method for measuring IOP is Goldmann applanation tonometry. However, because Goldman is not possible supine or in a sealed negative pressure environment, we developed excursion goggles to measure IOP while maintaining the sealed negative pressure environment during OPAP wear. A Reichert Model 30 pneumatonometer probe is brought into contact with the corneal surface across a tonal pen cover within a sealed cartridge and objectively displays the IOP dynamically. This methodology, again known as excursion tonometry, has been rigorously validated, and the FDA acknowledged it to be appropriate for the measurement of IOP while wearing OPAP. Manometry is the gold standard for IOP measurement and is performed by placing a needle in the eye to directly measure IOP, like we did in the CONFIRM study, and is always referenced to atmospheric pressure surrounding the body. Importantly, atmospheric pressure is the reference point for all physiologic pressures throughout medicine: cardiology, pulmonology, urology, etc. Now clearly, putting a needle in someone's eye is impractical for clinical use. And that's why the transcorneal pressure difference, like Goldman and the Model 30 pneumatonometer that we used in our studies, was developed as a surrogate measure for IOP. The transcorneal pressure difference in orange is the difference between the pressure inside the eye and atmospheric pressure outside the eye as measured across the cornea. All of these non-invasive approaches measure the transcorneal pressure difference referenced to atmospheric pressure. As you can see, the excursion methodology used in our studies measures the transcorneal pressure difference directly across the cornea and referenced to atmospheric pressure, which very closely approximates how Goldman tonometry is performed. However, our methodology does not measure the transcorneal pressure difference relative to the newly created intra-goggle space. The transcorneal pressure difference relative to the intra-goggle space does go up by an average of about 4 to 5 millimeters of mercury. And this is clearly described in our label, and as you will see later, there is no evidence of safety concerns regarding the cornea. A question has been raised as to whether the intragoggle space might be the most appropriate reference point as opposed to the atmospheric pressure surrounding the body. Referencing to the intragoggle space does not have supportive evidence and contradicts how intraocular pressure is defined and is inconsistent with how all physiologic pressures are measured in the body. It would also ignore the pressure decrease occurring at the optic nerve head where glaucoma actually occurs. To address the question, what is the proper reference point for IOP? The proper reference point is atmospheric pressure, and this is consistent with the white paper provided in your panel pack, written by experts in the field. Additional studies we performed demonstrate the physiologic response of the eye is what we would expect when IOP is lowered. Although I don't want to overstate these relatively small studies, this exploratory work shows that with negative pressure application, we see an increase in blood flow, an increase in the percent area perfused and capillary density, improvements in the pattern ERG, and improvements in metabolic function. These results are consistent with the effects we would expect to see when IOP is lowered, and indeed we do. Lastly, a peer-reviewed manuscript published by Ross Ethier used a finite element model to demonstrate that when IOP is reduced from 15.8 to 11.5 millimeters of mercury with the goggles, there's a resulting 54% decrease in tissue strain at the optic nerve head. The OPAP has been investigated in 12 clinical and 11 non-clinical studies with remarkably consistent results. 15 peer-reviewed publications have been generated, and as discussed in the panel pack, we have evaluated a total of 634 study and control eyes of 378 patients. As for the regulatory history, we initiated conversations with the agency in September of 2017, including a formal pre-submission meeting. Key alignment was achieved regarding study size, duration, and the appropriate effectiveness endpoints. After completion of the 3-month pivotal study, we filed a de novo application in May of 2020. The agency declined the application in September of 2021 Despite meeting the study endpoints, the agency recommended that we provide longer-term data. As part of our ongoing commitment to generating additional data, we had already initiated a second long-term study in normal tension glaucoma in January of 2020, at the start of the COVID pandemic. This is the Artemis study which we are reviewing today. In August of 2023, we submitted a new de novo application that included complete 12-month data from the Artemis trial, as well as a narrowed indication, and requested that this panel meeting be convened to determine if the likely benefits outweigh the likely risks of OPAP for this indication. The confirmed study was recently conducted in December of 2023 in response to an additional information request from FDA. FDA has agreed that the de novo pathway is the most appropriate pathway. This pathway is used for lower risk devices such as the OPAP, where there is no available predicate device. Granting of a de novo request requires that the probable benefit to health outweigh any probable injury or illness from such use. The unmet need in glaucoma is clear because it remains the leading cause of irreversible blindness, and lowering IOP is the only way to slow glaucomatous progression. We need tools in our toolkit that can lower nocturnal IOP, a major predictor of disease progression, and especially in patients with an IOP of 21 or less, where lowering IOP is more difficult. Our 12-month pivotal Artemis trial met every endpoint with statistically and clinically significant IOP reductions. IOP reductions were observed in every patient and across all populations. The OPAP lowered nocturnal IOP in patients whose daytime IOP is 21 or less, and as an effective adjunct to existing medications and prior surgery. The OPAP is very safe. There were no device-related serious adverse events, and all device-related AEs resolved without sequelae. There was no observed damage to the structure or function of the optic nerve, visual field, cornea, or anterior segment. Importantly, the patient can remove the device at any time, or physicians can adjust the pressure settings to address for any potential adverse effects. Here's the remaining agenda for today. Dr. Leon Herndon will describe the unmet need for glaucoma patients with an IOP of 21 or less. Ms. Ginger Clasby will present the design of the pivotal Artemis study. Dr. Tom Samuelson will present both the effectiveness and safety results from the study. And finally, Dr. Herndon will return to provide his clinical perspective on the assessment of the benefit risk. We have invited these additional experts to assist with answering questions from the panel today. All experts have been compensated for their time and travel to today's meeting. Thank you. And now Dr. Herndon. Good morning. My name is Leon Herndon. I am professor of ophthalmology and the glaucoma division chief at the Duke Eye Center, where I've cared for patients and taught students for the past 28 years. As Dr. Berdahl mentioned, there is a significant unmet need for additional and adjunctive treatments to lower IOP in patients who have open-angle glaucoma with an IOP of 21 mmHg or less. Despite daytime controlled pressures, these patients continue to get worse. Lowering IOP is the mainstay for all glaucoma treatment. There are three major theories on why lowering IOP protects the optic nerve in glaucoma. The first is that it decreases mechanical strain experienced by the optic nerve. The second is that it improves blood flow to the optic nerve. And the last is that it improves metabolic function, the axonal transport of the optic nerve head. Dr. Berdahl shared data from the OPAP showing improvement in all three of these areas. Regardless of the theory, we know that lowering IOP is the only treatment strategy for slowing glaucoma progression, including for patients with controlled daytime IOP. The landmark early manifest glaucoma trial evaluated the effectiveness of reducing IOP over 6 years. Notably, the median baseline IOP was only 20 mmHg. This study showed that a mere 1 mmHg decrease in IOP resulting in a 10% decrease in glaucoma progression. Multiple studies have shown that IOP reductions of 20 to 30% slow the loss of vision significantly. In fact, in one study, a 20 to 30% reduction in IOP conferred a greater than 90% chance of stability. Another study looked at relative risk reduction. It still showed that achieving a 30% reduction or greater in IOP was associated with a 50% reduction in the risk of progression. Clearly, when it comes to reducing IOP, every millimeter of mercury matters. These findings were confirmed by the NEI-sponsored collaborative normal tension glaucoma study. It compared visual field progression in treated patients to untreated patients. The treated patients achieved a 30% IOP reduction. At 3 years, 80% of treated patients had no visual field progression compared to 60% of untreated patients. Beyond 3 years, the treated group remained stable, but the untreated group continued to decline dramatically. Only 20% of untreated patients remained stable at 8 years. This reinforces the fact that lowering IOP significantly reduces visual field progression in patients with normal tension glaucoma. This compelling evidence is why the American Academy of Ophthalmology states that lowering IOP in these patients is beneficial. And this is why all FDA-approved glaucoma treatments have been approved on the basis of lowering IOP and not visual field preservation. The current methods we have to reduce IOP include ocular hypotensives or eye drops, laser trabeculoplasty, and surgical treatments. Although we need all of these options, a key limitation is that most are less effective at night and in patients whose IOP is lower than 21. Additional data from the early manifest glaucoma trial show that treatment with laser trabeculoplasty or beta blockers was considerably less effective when IOP was less than 21. Patients with an IOP of 21 or greater achieved a reduction of 29% from baseline, compared to those with an IOP below 21 who achieved an 18% reduction from baseline. Similar findings were seen with minimally invasive glaucoma surgery. The surgery is more effective when IOP is greater than 21. In fact, a 2016 study found that when eye pressure was 16 or lower, there was almost no IOP lowering effect from a trabecular bypass stent. As a result, there remains a large unmet need for adjunctive therapy to treat patients with glaucoma and control daytime IOP. When you look at the normal tension glaucoma literature, only 50% of treated eyes achieve a 30% IOP lowering. 34% of patients show progression even with treatment. And almost 10% of these patients go blind in one eye, and 1.5% go blind in both eyes. So, while these patients with glaucoma have normal eye pressures, they still experience progressive vision loss. The only way to prevent progression is by lowering IOP further. So, all of the data I just presented support the fact that lowering IOP with the OPAP will slow glaucoma progression. But let's go even deeper to address the FDA's question about the clinical benefit of lowering IOP on a nightly basis. In patients with glaucoma, the acrophase, or the highest IOPs, typically occur at night. These data from a sleep lab study illustrate this 24-hour IOP cycle: normal daytime IOP, but elevated nighttime IOP. And this study showed that 79% of eyes with glaucoma progression had IOP peaks at night. Furthermore, 65% of patients with peak IOP at night ended up being progressors. Clinical treatment decisions are made based on daytime IOP measurements, which miss the nocturnal elevations that occur in 60% of patients. Additional studies have shown that nocturnal mean peak ratio, that is the ratio of nocturnal IOP to daytime IOP, and diurnal nocturnal IOP elevations were correlated with visual field progression. Another recent study found an association between increased rate of glaucoma progression and higher and more prolonged increases in nocturnal IOP. Collectively, these studies highlight the clear relationship between nocturnal IOP elevations and glaucoma progression. And yet, despite the importance of nocturnal IOP, most medications do not fully address this issue. This classic chart shows that at baseline, and with timolol in gray or latanoprostene bunod in black, IOP still goes up dramatically for about 6 hours at night. And we see the same pattern with most topical IOP lowering agents. This limitation is not just with medications. In the large light trial, selective laser trabeculoplasty, or SOT, performed very well, but it did not impact the 24-hour rhythm, and it did not eliminate nocturnal IOP peaks. There are no data available on the effect of minimally invasive glaucoma surgery, or MIGS, effect on nocturnal IOP. Trabeculectomy is the only procedure that's been demonstrated to consistently flatten the nocturnal IOP curve and slow glaucoma progression. However, it is associated with significant surgical morbidity. In summary, there is a significant unmet need for additional and adjunctive treatments to lower IOP in patients who have open-angle glaucoma and an IOP of 21 millimeters mercury or less. IOP increases at night in most glaucoma patients, especially those with normal daytime pressure. And that nocturnal elevation is associated with progressive vision loss. Most therapies have minimal impact on the nocturnal IOP elevations and limited effect in patients with IOP less than 21 millimeters of mercury. We need treatment options that can be used adjunctively to reduce patients' pressure with normal daytime IOP, and that can specifically reduce their IOP at night when these patients are most at risk of a peak in pressure. Thank you. Junior Class B will now present the results from the sponsor's 3-month study, Apollo, and then introduce the 12-month pivotal Artemis study.
Thank you, Dr. Herndon. I'm Ginger Clasby, and I'm a clinical and regulatory affairs consultant to Balance Ophthalmics. It's my pleasure to be here with you today. As you saw in the regulatory timeline, the Apollo study was the pivotal trial that was submitted in support of the initial de novo application. I'd like to give you a brief overview of this study. Apollo was a prospective, multi-center, randomized, controlled mass study of the OPAP device. 64 patients used the device nightly for 90 days. Each patient's treatment was randomized such that one eye received negative pressure, while the other eye served as control, receiving no negative pressure. The study's primary effectiveness endpoint was the proportion of eyes at day 90 with IOP reduction of 20% or more during application of negative pressure as compared to baseline that day. Patients returned monthly for safety assessments at 3 follow-up visits. Apollo included adult patients with open-angle glaucoma, ocular hypertension, or glaucoma suspect with IOP between 13 and 32 millimeters of mercury, and best-corrected distance visual acuity better than 2200. Patients' orbital anatomy had to allow for a proper seal of the OPAP goggles. Patients were excluded if they had retinal pathology, prior trabeculectomy or tube shunt surgery, narrow angles, conjunctival chemosis, active inflammation, or a history of any other ocular condition that could compromise patient safety or study results. As previously described, the IOP was measured with the excursion goggles during negative pressure application. 2 masked observers collected the IOP measurements. One applied the pneumatinometry probe, while the other read the monitor. For each IOP assessment, 2 measurements were taken, and if they were within 2 millimeters of mercury of each other, The IOP reported was the average of the two. If the two measurements were greater than 2 millimeters of mercury apart, a third measurement was taken, and the IOP reported was the median of the three. The primary effectiveness endpoint was the proportion of eyes in the modified intent to treat population with 20% or more reduction in IOP during negative pressure application as compared to the pre-negative pressure IOP that day. Eyes achieving this endpoint were considered responders, and eyes where the endpoint was not achieved were considered to be non-responders. The primary endpoint was achieved with a 78% difference in success between treatment and control eyes, and this outcome was highly statistically significant with a p-value of less than 0.001. No device-related serious adverse events were reported during the 3-month study follow-up period. All ocular and periorbital adverse events were mild to moderate in nature, and the most frequently reported device-related events were transient, intermittent, lid or periorbital edema. Post hoc independent masked reviewers at the University of Iowa Visual Field Reading Center evaluated visual fields and OCT imaging for study patients. And out of 116 eyes evaluated, they identified 2 eyes with visual field changes indicative of glaucoma progression, the study eye in one patient and the control eye in the other. However, when OCT assessments were factored in, the reading center concluded that neither of these eyes had confirmed glaucomatous progression. Let's move on from Apollo and review the design of the pivotal 12-month Artemis study. The duration of Artemis was intended to address FDA's concern that Apollo followed patients through only 3 months of nightly use. Artemis also measured IOP overnight and evaluated normal tension glaucoma patients, and thus is intended to support a narrower indication for use for the product. Patients in Artemis were required to have unmedicated IOP in both eyes between 12 and 21 millimeters of mercury at baseline. If needed, patients using ocular hypertensive medications underwent a minimum 30-day washout before their unmedicated IOP assessment. And after this, patients resumed use of their glaucoma medications for the duration of the study. Eligible patients were given an OPAP kit that contained goggles, the pre-programmed negative pressure pump, and accessories for home use. They were instructed to use the device each day over the following week and then return for a safety evaluation on day -7. Over the next week, they were asked to use the OPAP each night while sleeping. At their next visit, which was day 0, patients were evaluated for their ability to successfully use the OPAP for at least 3 hours per night during at least 3 of the previous 7 nights. Patients who weren't successful were exited from the study, and those who continued to qualify were randomized to treatment, with one eye receiving negative pressure and the other acting as a control receiving no negative pressure. They were asked to use the OPAP approximately 6 hours per night, at least 5 nights per week for the duration of the study. Within 21 days after randomization, patients attended a sleep lab where IOP was measured during OPAP wear at approximately 11 p.m., 2 a.m., and 5 a.m. After the sleep lab, patients continued to wear the device at home each night. They returned for regular in-clinic assessments at approximately 1, 3, 6, and 9 months after day 0, where they were evaluated for safety, their IOP was measured, and OPAP usage data was downloaded. At week 52, another sleep lab was conducted with IOP measurements at the same time points as the initial lab. Afterward, during the final in-clinic visit, patients' IOP was measured while using the OPAP before and during negative pressure application. In the clinic, at the time of randomization, each patient's negative pressure setting was programmed for the study eye based on the difference between IOP measured that day and a reference of 6 millimeters of mercury. This reference was to minimize the risk of hypotony during OPAP use. Since nocturnal IOP usually goes up, it was anticipated that IOP measurements from the initial sleep lab might be higher than the in-clinic IOP. When this was the case, the negative pressure setting was adjusted based on the sleep lab IOP, and the patient used this updated setting during home use going forward. Investigators also had the discretion to reduce the negative pressure setting for at-home use based on patient comfort and wear time. Trained personnel at each investigational site were designated to program the negative pressure setting and monitor compliance data downloaded from the pump. Separate personnel masked to treatment assignment performed effectiveness evaluations. And as with the Apollo study, a post hoc evaluation of visual field and OCT images was independently performed by 3 mask readers at the University of Iowa Visual Field Reading Center. The eligibility criteria for Artemis were similar to those for Apollo, with the exception of the criteria that are highlighted here. This study was conducted in patients 40 years of age or older with a confirmed diagnosis of normal tension glaucoma and unmedicated IOP between 12 and 21 millimeters of mercury inclusive. IOP reduction to diminish progressive loss of vision is fundamental to all current glaucoma therapies, including normal tension glaucoma, and is the standard effectiveness endpoint for surgical and pharmacologic glaucoma therapies. FDA's guidance for studies of minimally invasive glaucoma surgical devices recommends the primary effectiveness endpoint as the percentage of subjects with a reduction of at least 20% in mean diurnal IOP. Since the effect of OPAP is only present when worn, the Artemis endpoint was adapted to reflect the percentage of eyes with at least a 20% reduction in IOP during device use, which reflects the proposed indication. And of note, this guidance also recommends a minimum 12-month follow-up, which is consistent with our study design. With FDA guidance in mind, the primary effectiveness endpoint was defined as the proportion of study eyes with week 52 IOP reduction of 20% or more as compared to the pre-negative pressure IOP that day. These measurements were taken through the excursion goggles both before and during negative pressure application in the clinic. The secondary endpoint was the proportion of study eyes with week 52 mean IOP reduction of 20% or more during the sleep lab as compared to the mean corresponding pre-negative pressures that evening. And again, these IOP measurements were also taken through the excursion goggles before and during negative pressure application at the 11 p.m., 2 a.m., and 5 a.m. time points while the patient was supine. It's important to note that for the primary analysis of these endpoints, we took a conservative approach, and any case with missing 52-week IOP data, even if the patient had discontinued the study, was considered to be a non-responder. We evaluated several safety outcomes. The rate of occurrence for ocular and periorbital adverse events was summarized based on the number of eyes. The rate of occurrence for non-ocular adverse events was summarized based on the number of patients. At each follow-up visit, we assessed changes in visual acuity, and slit lamp and fundus exams allowed for assessment of clinically significant changes in each eye. Visual field perimetry and OCT imaging performed at baseline, week 26, and week 52 allowed for assessment of possible glaucoma's progression. For Artemis, the sample size calculation was based on the primary effectiveness endpoint and adjusted for the secondary effectiveness endpoint. Based on McNemar's exact conditional test with a two-sided significance level of 0.05, it was determined that a minimum of 50 patients evaluated at week 52 would provide statistical power of at least 92% to determine superiority for the primary endpoint. This sample size also provided greater than 80% power for the secondary endpoint. The 4 analysis populations used for this study included the intent to treat population, which was all randomized patients, The safety population, which included all randomized patients who had at least one application of negative pressure of any duration. The modified intent to treat population, which included all randomized patients with at least one full application of negative pressure after randomization. And the per protocol population, which included modified intent to treat patients who met all entry criteria, completed their week 52 sleep lab and in-clinic visits, and had no major protocol deviations. Thank you. Now Dr. Samuelson will present the trial results.
Thank you, Ginger. My name is Tom Samuelson. I'm a glaucoma specialist and a founding partner of Minnesota Eye Consultants in Minneapolis, where I have an active clinical practice and am co-director of the Glaucoma Fellowship Program. I'm also adjunct professor of ophthalmology at the University of Minnesota in Minneapolis. I'm happy to be here today to present the results of the Artemis clinical trial. Let's start with who we enrolled. 165 patients signed the consent and were enrolled in the study. 106 patients met the eligibility criteria and returned for day 0. During the day 0 visit, 8 patients declined further participation, and 4 had concerns about participating in a sleep study lab during COVID. The remaining 94 patients were randomized, constituting the intent to treat or ITT population. 1 patient who had a past unmedicated IOP greater than 21 was mistakenly randomized, but was exited from the study before post-randomization treatment. Therefore, the modified intent to treat population consisted of 93 patients. Between randomization and week 52, 31 patients discontinued the study. Recall, much of this trial was conducted during the COVID pandemic. 62 patients, or 2/3 of the MITT population, completed the study through week 52. 2 patients had a major protocol deviation, and thus 60 patients comprised the per protocol population. The median age was 61, and the majority of those enrolled were female. The racial and ethnic demographics were generally representative of the U.S. population. The study group was almost evenly split between left and right eyes. Characteristic of the normal tension glaucoma population, the mean baseline Goldman IOP was 14.7 millimeters of mercury in study eyes and 14.8 in control eyes. At least one ocular hypotensive medication was used in 56% of study eyes and 54% of control eyes, and a similar proportion of patients in both arms had prior IOP lowering surgical procedures. Please note the prior surgical history information may have not been reviewed by FDA. Baseline visual field deficits were similar between groups. FDA has asked, does the available data support the proposed range of programmable negative pressure and wear time? The programmed negative pressure was based on the supine sleep lab IOP, and the mean programmed negative pressure remained steady at around -12 over the course of the trial. Patients were generally compliant, with OPAP use ranging from 78% to 87% of nights. This translates to an average of more than 5 nights per week. Recall, patients were instructed to wear the OPAP device at least 5 nights per week. Average nightly wear was consistently around 5.5 hours per night worn. This table shows the average nightly wear time in greater detail. It is evident that most patients wore the OPAP device in the range of either 4 to 6 hours or 6 to 8 hours. Keep in mind that data shows that over 50% of glaucoma patients sleep less than 7 hours per night. Upon approval, the sponsor's goal would be to provide clear guidance to clinicians on the appropriate use of the device. The device allows negative pressure settings independent for each eye of 0 or no negative pressure to negative pressure ranging from -5 to -20 in 1 millimeter increments for a duration between 1 and 8 hours. These ranges are reflective of what was studied. Now, turning to the results. For the primary effectiveness analysis in the modified intent to treat population, any missing data for either eye was counted as a failure. This includes missing data due to study discontinuation. It's noteworthy that the vast majority of non-responders in the treatment group resulted from study discontinuation. This analysis preserves the value of the randomized comparison by including all randomized eyes, and it provides a worst-case estimate by counting missing data as failure. The primary effectiveness endpoint was met. At week 52, 58% of study eyes had a 20% or greater reduction in IOP during the negative pressure application in the clinic, as compared to 1% of control eyes. The difference between groups, or the treatment effect, was 57%, which was highly statistically significant. A similar conservative approach was used for the MITT analysis of the secondary effectiveness endpoint. And this endpoint was also met, with 63% of study eyes achieving at least a 20% reduction in mean nocturnal IOP as compared to 3% of control eyes. The difference between groups was 60%. This measurement was performed with the patient in the supine position and best reflects the conditions the eye experiences each night while the device is in use. As a sensitivity analysis, we looked at the achievement of the primary and secondary endpoints in the per protocol population. Eyes with missing data are excluded from the per protocol analysis, so this analysis represents the population that was using the device at week 52. The endpoints were met again with statistically significant treatment differences between the study and control eyes of 87% for in-clinic and 92% for sleep lab. We also looked at the results over time. As shown here, there is a significant treatment effect at all time points. As a reminder, eyes with missing data and discontinuations were treated as non-responders. Nevertheless, the treatment effect was clinically relevant and remained statistically significant as the study progressed. Likewise, the treatment effect was similar for the sleep lab. Now, looking at the same analysis for the per protocol population, note some of this data may not yet have been reviewed by FDA. We see even greater differences in the responder rate at all time points, which indicates there is no decay in the effectiveness of pressure reduction over time. In other words, when patients use the OPAP device, the intraocular pressure is reduced and sustained over the time when worn. On this graph, I'll show the percent IOP change on an individual patient level. Note that this data was provided to FDA but may not have been reviewed yet. In each study eye, represented by a blue circle, is paired vertically with the patient's contralateral control eye, represented by a white square. Now here's the remainder of the patients. As you can see, all study eyes showed IOP reduction, with many more study eyes achieving the primary endpoint of at least 20% reduction in IOP as compared to control eyes. And the blue circles in the yellow shaded area represent the 2/3 of the study eyes that achieved a 30% or greater reduction in IOP. As clinicians, we are interested in both the percent IOP reduction and the numeric IOP reduction. Here you can see the consistent numeric IOP reduction in study eyes compared to the paired control eye in the sleep lab. Note this figure may not have been reviewed by FDA at this time. This data represents what we would expect to see when patients wear the device in the real world. This amounts to a mean IOP reduction from 20.4 to 12.4 at night. Covariant analyses performed to investigate the heterogeneity of the primary endpoint demonstrated consistent IOP reduction across all covariants. Note that the results by race and ethnicity shown here and on my next slide were not previously reviewed by FDA. In the Asian population, although we do see a difference between study and control eyes, the difference isn't as pronounced as for other subgroups. So I'll provide some additional detail for this group of patients. In the Asian subgroup, 8 of the 15 patients discontinued before the week 52 assessment and thus were counted as failures. The reasons for discontinuation were voluntary withdrawal, site closure due to COVID, one patient who had a reaction to goggle materials, and one who exited due to unrelated SAE of pancreatic cancer. Of the 7 Asian patients who did complete the study, 4 met the threshold for the primary effectiveness endpoint, achieving IOP reductions greater than 20%. The other 3 achieved favorable IOP reductions ranging from 17 to 19%, yet by protocol were considered non-responders. It's important to note that all of these patients did meet the 20% IOP lowering threshold at night. When assessing covariant analyses based on ocular characteristics, we see consistent IOP reduction across all subgroups. Note that certain subgroup analyses, as denoted here with an asterisk, were not previously reviewed by FDA. Importantly, eyes with cup-to-dis ratio of greater than 0.8, indicative of a more advanced glaucoma, in those patients we see significant IOP reduction for the study eye. As expected from the primary analysis, we see very little changes across subgroups in control eyes. FDA has asked the panel to weigh in on effectiveness. The Artemis trial showed statistically significant, consistent, and clinically meaningful reductions of IOP during use of the OPAP device. The OPAP showed a mean in-clinic IOP reduction of 36%, or 6.6 millimeters of mercury, from 18.0 down to 11.4. In the sleep lab, with IOP measured in the supine position, the IOP was reduced by 39%, or 8 millimeters of mercury. Every single study eye at every time point measured showed IOP lowering. Additionally, all study populations and imputation analyses support the effectiveness of treatment and the consistency of the results. To reiterate, the primary and secondary effectiveness endpoints were met. And notably, the difference in IOP during device wear between the study and control eyes was even larger in the per protocol population, which is more representative of the real world results, because these are the patients who routinely wear the device. I am unaware of any glaucoma treatment with such impressive and consistent effectiveness. Similar treatment effect was also seen earlier in the Apollo study. When we look across these studies, effectiveness is clearly demonstrated. Now let's turn to safety. During the 52-week Artemis study, there is no evidence for device-related serious adverse events and no AEs suggestive of damage to the structure and function of the optic nerve, the cornea, or the anterior segment. None of these safety assessments reflected a worsening in clinical outcomes or unanticipated adverse device effects. All device-related AEs resolved without sequelae. Importantly, there was no hypotony and no elevations in mean IOP after removing the OPAP device. Now let me review in greater detail the events that were reported. Beginning with ocular AEs. A total of 39 events were reported in 25 study eyes compared to 17 events in 13 control eyes. The most frequent AEs in study eyes were intermittent transient lid edema, mild dry eye, conjunctival hyperemia, and transient eye pain. all cases resolved without sequelae. There was one report of lid edema in a study eye that the patient considered to be severe. While lid appearance returned to baseline within a week, the patient elected to discontinue study participation. 2 eyes in each group had temporary decrease in vision of 2 lines, which was unrelated to the device. Both study eyes had anterior basement membrane dystrophy, which was believed to cause the vision fluctuation, since vision returned to baseline without intervention in both eyes. 2 cases of study eye had posterior vitreous detachment, but there are no cases of retinal detachment or retinal tear. 20 periorbital AEs were reported for 17 study eyes, and 7 AEs were reported for 7 control eyes. All AEs resolved, and 80% were mild, none were severe. The most frequent events were intermittent transient periorbital edema and periorbital contact dermatitis. All of these cases resolved with the use of cool compresses or over-the-counter medication, a reduction in negative pressure, and in some cases, without any intervention at all. Importantly, there were no SAEs related to the OPAP device. As expected, per the study protocol, ocular hypotensive medications remained stable throughout the study, with 95% of eyes having no change in the number of medications used at any visit. Additional assessments revealed no instances of corneal edema, no changes in anterior chamber angle or synechia. One patient had 1+ endothelial guttata in both eyes at the week 52 visit that had not been reported at baseline. There were no clinically significant fundoscopic differences between study and control eyes. Mild lattice degeneration was present in one study eye. There was no difference in cup to disc ratio between study and control eyes. Similar to the Apollo study, all data from week 26 and week 52 were evaluated retrospectively by the University of Iowa Visual Field Reading Center to characterize potential differences in glaucomatous progression in study eye versus control eyes. Visual field and OCT examinations were evaluated by 3 masked expert readers, Dr. Michael Wall, Dr. Chris Johnson, and Dr. Michael Patella. 2 readers were assigned to review each visual field, seeking to identify any cases of progression. The visual fields were analyzed in a masked fashion to determine whether the visual field had improved, stayed the same, or had worsened. Following this, a second analysis was done in the same manner as before, but with the addition of OCT data. Any discrepancies were adjudicated by a third reader. While this methodology was designed retrospectively, the methodology is the standard approach by this reading center. Let me walk you through the data that the reading center reviewed. As you'll recall, the MITT population included 93 patients. All had baseline visual fields and OCT data. All 68 patients who reported at week 26 had data available, and all 62 patients who reported at week 52 had data. In total, 418 visual fields and 392 OCTs were evaluated in a masked fashion. 86% of the visual fields were deemed adequate quality. At week 52, 6 eyes, specifically 3 study eyes and 3 control eyes of 4 patients, had a mean deviation decrease of 2.5 decibels or more compared with their baseline. Repeat visual fields were performed for each of these eyes, and the reading center determined that there was no evidence of progression in any of these 6 eyes. The reading center did identify one patient with evidence of visual field progression in both eyes, but with a mean deviation decrease less than 2.5 decibels. However, when evaluating supplemental OCT data, glaucomatous progression could not be confirmed. The reading center concluded that none of the eyes had confirmed glaucomatous progression. In summary, the 12-month data from the Artemis trial were consistent with the safety data from Apollo and further support the positive safety profile for this device. No device-related SAEs were observed in any eye in the Artemis study, nor in any of the other studies of OPAP. Moreover, there was no evidence of damage to the optic nerve head, cornea, or anterior segment in any patient. Remember, this is a non-invasive, removable device, removable by the patient themselves at any time they choose. Now, moving to address FDA's question around whether there's a reasonable assurance of safety. Based on Artemis alone, but even more evident with consideration of the other clinical studies, it is clear that safety at 1 year has been demonstrated. In the de novo setting, with a removable wearable device indicated for adjunctive use, I would consider 1 year to be adequate study duration and consistent with the FDA mmHg guidance, as well as the 2014 FDA task force that many of us participated in. This is especially true based on the physical mechanism of action of the device and the fact that thorough and robust assessments provided no indication of a safety issue that might worsen over time. As with all devices on the market, Balance will monitor all event reports to look for potential safety concerns in the commercial setting. Like many of you on the panel, I've been treating glaucoma over 30 years. Severe glaucoma, bad glaucoma, and as you know, glaucoma is all about risk mitigation. Trying to mitigate disease risk versus the risk of our next potential intervention. And I'm constantly trying to pick between procedures that have really good efficacy but marginal safety, or procedures that maybe the efficacy is marginal but the safety is terrific. It's really encouraging to see an opportunity to treat patients that has really, really high efficacy and really high safety. Thank you. Dr. Herndon will now conclude with the benefit risk of OPAP.
Thank you. I'd like to conclude with my candid perspective on the OPAP. Glaucoma patients with an IOP of 21 or less need additional options. Earlier, Dr. Berdahl mentioned his patient Jerry. Unfortunately, I bet most ophthalmologists have similar patients that they could not help. I myself have many of them. And further IOP reduction remains the only way to slow progression in these vulnerable patients. As part of my concluding remarks, I would like to address the two remaining questions that the FDA is asking the panel to discuss. Namely, does the proposed indication statement use the appropriate nomenclature and language with respect to IOP? And most importantly, whether the probable benefits of OPAP outweigh the probable risk for the indicated patients. The IOP nomenclature in the proposed indication is both accurate and appropriate, and can easily be understood by both physicians and patients. And it clearly points out that OPAP is an adjunctive therapy. When discussing the broader issue of overall benefit risk, it is important again to look at the unmet need. I'll remind you that despite having daytime controlled pressures, and despite available treatments today, and despite having surgery, some of these patients continue to worsen, with many of them losing their sight altogether. And since IOP peaks at night, decreasing nocturnal IOP is key in slowing glaucoma disease progression. We need this option because most treatments are less effective at reducing nocturnal elevations that put patients at risk of disease progression. Again, the effectiveness of the device has been clearly demonstrated. Of patients who wore the goggles, 97% achieved a 20% IOP lowering at nighttime, and 76% achieved a 30% IOP reduction, with an average overall IOP of 39% lowering. Results like this simply don't exist with other treatments, especially as adjunctive care in this difficult to treat population. To put these results in further context, recall that a 20 to 30% reduction in IOP confers a 93 to 96% chance of stability. So we know that lowering IOP is beneficial to our patients. And I'm very comforted by the inherent safety of the device. With OPAP, there have been no device-related SAEs, no AEs that did not resolve, and no evidence of damage to the optic nerve, cornea, or anterior segment. Furthermore, using OPAP may delay or negate the need for more invasive surgical treatments that can pose serious risk. And it is important to keep in mind that these results were achieved with a non-invasive, removable device that can be safely used to reduce IOP in patients overnight while they sleep. With 23 studies, including 15 published in the peer-reviewed literature, for a low-risk device, I'm impressed by the scientific rigor used to understand the physiology and establish the safety and effectiveness of this device. So yes, I do believe the evidence clearly demonstrates that the benefit-risk profile of OPAP is favorable, and I hope you share my perspective in support of the device. Thanks very much for your time. Dr. Berdahl will now return to take your questions.
Thank you very much, and thank you for your timeliness of presentation. So I'm going to ask the panel if anyone has any questions. If you do, please raise your hand. While we are doing that, I will ask some just logistical questions. In terms of deciding how long a patient was using this per night, was that just self-reported or was there any monitoring of that?
Yeah, the device use at night was monitored directly on the pump itself and was downloaded when it was brought into the clinic at the investigator's office. So it was objective data.
And just another quick question is, if someone got up in the middle of the night to go to the bathroom, were they then taking off the goggles, or could you walk around with the goggles? What did people typically do?
I don't know that we know what people typically did, but they could wear the goggles if they got up to go to the bathroom. The goggles, the lenses themselves are clear, so you can move around with them, and we would be able to determine if they stopped that.
Great, thank you. We'll start with Dr. Repka.
Thank you, Michael Repka. Two simple questions. I wanted to understand the decay of the treatment effect. For instance, essentially, if you turn the machine off, the pressure goes back to baseline. And in the sleep lab study, which is as analogous or connected question, I assume those patients were wearing this continuously, and those interval measurements, you didn't show any data showing was there a difference at each of the time points, suggesting that this was a constant effect, or could the effect go up and down over that time course?
Yeah, thank you. So regarding the decay question, I think if I understood that properly, you're saying how quickly did it start working and how quickly did it stop working?
Yes.
So the data indicates, and probably it's the confirmed data that shows this most, that tracing, that it is basically an immediate lowering of intraocular pressure, and it's an immediate return to baseline with intraocular pressure. Here's a representative tracing from the confirmed study, and that's what we saw in other studies. So basically, you apply negative pressure, the IOP goes down, you take it off, it goes back to baseline. I think that addressed the first question. The second question around the sleep lab data, I can show you here. So here's the week 52 sleep lab data, and we had the hours between 11 and 2 and between 2 and 5, and you can see that the baseline IOP, keep in mind we measured the baseline IOP without negative pressure immediately before applying negative pressure. And so you can see that the pressure went down in each of those time frames. I think those answered your questions. Is that true, Dr. Repka?
Yes, thanks.
Dr. Higginbotham.
Hi, I'm Dr. Higginbotham. I have two questions. I know this was on the spectrum of glaucoma, a rather younger population. Your average age was in, I think, 61. Systemic medications certainly can come into play as it relates to nocturnal IOP. And so I wondered if any of these patients were on any systemic meds that might have actually lowered intraocular pressure or impacted it differently compared to others who had not been on systemic meds. I also like to know if you actually stratified the population to see if the older people in this cohort actually responded differently. And then finally, if there are any patient-centered outcomes that would predict whether or not this will be a sustainable intervention, given the fact that devices such as the CPAP has one of the lowest adherence rates, and as one example, I just wondered if the patients will actually continue this intervention past the protocol. Those are just a few questions. Thank you.
All right, I think I got them. I'll do my best. The first one on systemic medications, I don't have that at our fingertips. I will try to see if I can get that for you after the break. Just to clarify, I am surmising that perhaps you specifically mean blood pressure medications. Okay,
Yes.
I saw the nod, yes.
Such as a systemic beta blocker, yes.
Yeah, great. Beta blocker in particular. I'll see what we can find for after the break. Second question on older patient stratification. We do have data available on that. And here you can see the effectiveness in different subgroups. And so if you look at the patients that were above the average age versus those that were below the average age, there was still a great responder rate and no change between the two groups. This is the per protocol population, those that finished the study. If you look at it in terms of the modified intent to treat protocol, again here at the top of this slide, there was no difference between those two groups. Moving on to patient-reported outcomes. This study, the Artemis study, did not have patient-reported outcomes. The Apollo study did, and we have some other loose patient feedback that I can share with you. So from the Apollo study, what we saw was that, that patients generally tolerated it well. We used the SHPC18 as per recommended by the FDA in that patient population in the Apollo study. We found that there was an increase in skin sensitivity up to 22.4% in the study eyes and 20.7% in the control eyes. And we also saw that there was an increase in droopy eyelid reported by patients on that questionnaire to 19% of the study eyes and 12% of the control eyes. We think that what that probably represents is the lid edema and the periorbital edema that we reported in the study as AEs, because there wasn't a specific question regarding lid edema from that. Now, importantly, visual function stayed the same over time. And in that same PRO, and I'm not trying to overstate this, it showed that patients had less eye irritation. And so there were some very modest improvements in that PRO as well. Then again, loosely, the Ranger study, this was our very short study in patients that had severe glaucoma. We asked patients at two different pressure settings, one at 50% of their baseline and one at 75% of that baseline, so between maybe 10 and 15 millimeters of mercury negative pressure. The likelihood that they would wear the device nightly on a scale of 1 to 10, with 10 being the highest, and the response was 7.9 in the lower pressure group and 7.8 out of 10 in the higher pressure group. And then when we did our formative human factors study, the formative human factors asked a similar question after patients had worn the goggles, and we got a 7.9 out of 10 on that question as well. Lastly, as maybe not actually a patient-reported outcome, there was one AE of difficulty sleeping in the Apollo study that was reported, and we didn't have any reports of that in the Artemis study. Let me ask Dr. Samuelson to add an additional comment he'd like to make.
Tom Samuelson, Minneapolis. I just wanted to comment on Dr. Higginbotham's great question about systemic medications. And for the non-glaucoma specialists on the panel, it's a really important question because one of the concerns is that blood pressure medications can lower blood pressure at a time when the intraocular pressure is increased during sleep and when patients are recumbent. And so the perfusion pressure is altered. So if we can lower intraocular pressure during that time, it's really important. The second maybe component of Dr. Higginbotham's question, is it possible that some of those very systemic medications also affect intraocular pressure? And maybe that was part of the question, but that's the beauty of the control group, because you saw the clear difference in IOP from the study eye and the control eye. Recall only one eye received negative pressure and the other eye served as control, and the treatment difference was pretty remarkable.
Dr. Ballman.
Hi, Carla Ballman. Just a quick question. So AEs were not collected during the run-in period. It was only collected on patients that were randomized and after the randomization?
AEs were collected during the run-in period, and I do believe that we have some slides to clarify that more here in just a moment.
Okay, thank you.
Dr. Wong?
Yeah, I noticed that our first population, the Apollo study, is intended for the patient with ocular hypertension, open-angle glaucoma, and glaucoma suspect. And the second population is for the normal tension glaucoma, and so those pressure has to be below 21. And however, your results, show that the people with greater than 20% reduction is actually better in the Apollo group than the Artemis group. So I'm just wondering if there's any evidence suggesting that the reduction or the spike of the nocturnal IOP spike is a little bit more pronounced in the people with high intraocular pressure versus those with the normal tension glaucoma.
Okay, I think that I got two questions in there. One was, do patients that have high eye pressure glaucoma have a higher likelihood of the pressure going up at night? And then I think the second question, or the first question, was in the Apollo study, you saw some differing results, and can you explain that? We did break down the Apollo data by less than 21 or greater than 21. This analysis may not have been reviewed by FDA yet, but we anticipated the question and thought about it. And so what you can see here is those in the Apollo study who had a pressure of greater than 21 had a 32% IOP reduction, and those that had an IOP of less than 21 had a 35% IOP reduction, taking their IOP from 17.3 down to 11. And note on the bottom that there actually were more patients in the Apollo study whose eye pressure was less than 21 millimeters of mercury than those who had a pressure greater than 21. These patients were also on treatment, or at least most of them were. Regarding your second question, both normal tension and glaucoma and regular open-angle glaucoma patients have a high preponderance of IOP elevations at nighttime. It is true that, at least from this study anyway, that 90% of open-angle glaucoma versus 80% of normal tension glaucoma patients have their highest IOP at night. And I think that addresses the second question.
Then, I have a follow-up question regarding your response is that since your IFU, the indication for use initially was for the glaucoma patient in general, you didn't really specify. And I'm just a little bit confused, it's good for the patient with higher pressure in the open-angle glaucoma. Why did the sponsor decided to go for the normal tension glaucoma?
Yeah, so let me just put up the proposed indication as a reminder for everybody. We're proposing that it's used as adjunctive therapy to reduce IOP at night in patients with open-angle glaucoma and intraocular pressure of 21 or less. The first reason is because this is the largest population of data that we have. We've studied over 500 eyes of patients that have had less than 21 millimeters of mercury across all of our studies, albeit some of those are shorter studies. So that's reason number one. Reason number two is because we believe that this is the hard to treat population. These are the patients that worry us as clinicians. They come in and their pressure's less than 21 and they need additional IOP lowering therapy. And we don't have as good of safe options for those patients. And then the third is, frankly, that our prior de novo got denied or declined. And so we narrowed that indication and provided a relatively large data set to help support it.
Thank you. Dr. Skuda?
Thanks for your presentation. Greg Skuda from Oklahoma City. I recognize in the Artemis protocol that the physicians had discretion at assigning the negative pressure. And I think that ended up being about a -12, as I recall. So what proportion of the patients in the study were actually treated with what would have been the programmed negative pressure had that been carried through? And what would that average have been if people had been treated at their programmed pressures? Does that make sense?
Yeah, I think that I got it.
Yeah.
So let me just remind everybody on the panel how we program negative pressure. And what we did initially is we took the negative pressure and or we took the measured pressure and we subtracted 6 from it. Now, we didn't expect that patients would have hypotony, but we did that out of an abundance of caution. And so that way the pressure wouldn't go below 6 millimeters of mercury. Then what we did is applied that negative pressure from the clinic. And then at the first sleep lab, we made an adjustment. And as you would expect at night when eye pressure goes up, that happened in our patient population as well. And so there were a number of adjustments. And by memory, I believe that it was maybe 59 adjustments that were made at the initial sleep lab by the protocol. And then at the second sleep lab, when we still had that at the 26 weeks, and we stopped that because it was really difficult to do that 26-week sleep lab in the middle of the COVID pandemic, there were another significant number of additional adjustments. There were, and then from that, I believe that the number was 20 patients that had an investigator discretion adjustment that was made primarily on if the patient was non-compliant or felt like it wasn't comfortable enough. I believe that the average change was 1.4 millimeters of mercury of negative pressure. Let me look at Ms. Clasby to make sure that that all sounds accurate. She tells me that it sounds pretty accurate. Go ahead. Would you like to comment?
Hi, Ginger Clasby, regulatory and clinical consultant. So of the 59 subjects or the 59 patients that Dr. Berdahl referred to who had changes at the initial sleep lab may have had additional adjustments over the course of the remainder of the study. And what we identified was that there were 45 patients in total who had an adjustment after that initial sleep lab. About 40% of those adjustments occurred at the week 26 sleep lab, which is something that I didn't talk about when we talked about the study design, but that was something that was required in an earlier version of the protocol and removed as the protocol as the study was progressed. So there were about 40% of patients had these adjustments at the week 26 sleep lab. And then thereafter, things were really very stable. I think the other thing that I would want to mention is that we believe something on the order of 14 patients who had an adverse event, a device-related adverse event that we believe might have been associated with a complaint about pressure because the pressure was then reduced.
Thank you.
Okay, thank you.
Dr. Boudens.
Don Boudens, Chapel Hill, North Carolina. 2 questions, and I'll give you the opportunity to answer the first one before I spring the second one on you.
Thank you.
Yes, hopefully much easier. The indication statement includes that this would be used adjunctive to current therapies for normal tension glaucoma. Yet, if I'm not mistaken, about 44% of patients were not on any medications for glaucoma during the study. This group of patients, had they already received SLT or MIGS, or were they intolerant to medications? I'm just curious about who those large group of patients were.
Yeah, the majority of patients that that were not on medications had some sort of prior surgical IOP lowering intervention. So we think that of the MITT population that initiated the study, I believe that it was 24 and 25, 24 in the study group and 25 in the control group that initiated the study and didn't have, that were treatment naive.
Thank
So
you.
the majority, I think that 75%-ish, give me a little wiggle room on that, had some sort of prior treatment or was on current medicine.
Thank you. And my second question is around compliance with the device. You mentioned that 78 to 87% of patients use the device every night throughout Artemis. And if you average the amount of use, it's somewhere around 5 to 6 days per night. And that the number of hours per night use average was 5.5 hours per night. I'm interested to know the actual reasons why the study group wasn't compliant, the rest of the time and the rest of the days.
I don't know that we've broken out or were able to capture specific reasons for non-compliance. I'm going to look over to Ginger again and say that we don't have specific reasons for why they maybe didn't wear the goggles that particular day or wore it shorter that night. I can try to see if we can get that for you after the break. I just don't know for sure that we'll be able to. I have one further comment on your first question. If you have anything, if I answered didn't answer your second question.
Well, I'm just curious, is this interrupting with people's sleep? Are they not using it because they don't get a good night's rest, and so they don't use it as long as perhaps they were instructed to, or skip nights? I guess that's my question.
Yeah, good question. We wonder that too, and we had one patient that was reported as an AE with difficulty of sleep in the Apollo. We didn't have any patients that reported difficulty of sleep that was recorded as an AE in the Artemis trial. I gotta believe that there are some patients that had some difficulty with this, but keep in mind that when you wear this, let's just compare it to CPAP for a moment. It's significantly quieter, and there's not a change in pressure as you go. So if you maintain a good seal, the pumps are hardly working at all, and there's not there's just a vacuum chamber that's created over the eyes. Hopefully now I answered the second part of the question. Okay.
Yes, thanks.
And then going back to your first question, one last thing to say there is there was no difference in treatment effect, whether they were on medications or not, or whether they had had a prior IOP lowering procedure or not, or if they had had nothing at all or not. All of those treatment effects were similar, nor did we see any change in adverse events in those groups either.
Thank you.
Dr. Schumann?
Hi, it's Joel Schumann. I'm at Wills Eye Hospital in Philadelphia, Pennsylvania. My question has to do with translaminar pressure difference. You mentioned a study with Ross Ethier. There were a couple of modeling studies, one of which you had talked about. And I'm wondering about effects of the device on translaminar pressure, and whether or not that's something that you have thought about or calculated, and if there is a benefit given any effect on translaminar pressure to the lamina curvosa and the optic nerve.
Yes, this is something that I've thought a lot about. Cerebral spinal fluid pressure is one of the areas of deep interest for me scientifically. And so just to level set for everybody on the panel, the cerebral spinal fluid pressure bathes the optic nerve as it enters the back of the eye. The translaminar pressure difference is the pressure difference between the intraocular pressure and the retrobulbar pressure, or the CSF pressure behind the eye. In our cadaver study, which I showed you some results of in the core, but here's another tracing from it. What you'll see there is that we did measure retroorbital pressure in those cadavers directly manometrically with the goggles on, and you'll see that the intraocular pressure decreased with negative pressure, but the retrobulbar pressure did not, indicating that we're lowering the intraocular pressure relative to the retrobulbar pressure and improving the translaminar pressure difference. Now with that, let me ask Dr. Ethier to come up and talk a little bit more about his analysis of what that means in terms of stress and strain of the optic nerve head.
Thank you, Dr. Berdal. Ross Ethier. I'm the Gellerstadt Chair and a Georgia Research Alliance Eminent Scholar in Biomedical Engineering at Georgia Tech and Emory University, and have worked in the area of ocular biomechanics for approximately 40 years. Joel, your question, as ever, is incredibly insightful. I wonder if we could bring up slide SA4, please. I believe it is. If you just bear with me for 1 second, which I think, excuse me, it's SA5. That would be helpful to answer Dr. Schumann's question. So Dr. Berdal has already shown some of this information on the right-hand side. This is the result of our finite element model. And just to put it in simplest terms, what we're doing here is determining how much stretching the cells and tissues of the optic nerve head tissues are experiencing as pressures are changed. In this case, we're going from the baseline case in the upper panel down to the situation in which OPAP is being worn. And what we're plotting here is the amount of stretching that those fragile cells experience. Red is high, blue is low. And I think everything we know about glaucomatous optic neuropathy suggests that having lower stretch being delivered to those fragile cells is beneficial. So in other words, blue is good. And we are in fact seeing a reduction in that stretching. Now, Joel, I think at the end of the day, we can talk about the finite element modeling, but let's bring it back to kind of a simpler way of thinking about it, which is shown in the left. We have very compelling data in my mind from the confirmed study, from the excursion tonometry, that the intraocular pressure is lowered during OPAP wear. We also have very compelling data that the retrobulbar pressure is not changed, the pressure in that purple zone there. And so, simply put, what's happening here when the OPAP device is being worn is that transmural pressure is being reduced, and also the translaminar pressure is being reduced. And that is going to reduce that mechanical insult that's being delivered to the tissues of the optic nerve head. I'll just tell you that we also asked the same question: what would happen, just hypothetically, and I think it's extremely unlikely, if there were to be some change, some reduction in the retrolaminar tissue pressure. And I say I believe that's very unlikely. And the good news is the benefit is still preserved. So I think the net effect is that this is very, very robust. It's actually quite remarkable. And I think that really speaks to the physics-based nature of this device.
Thank you. And we have approximately 10 minutes left, and I want to get everyone's questions answered. So brevity will be helpful here. Barbara Burning.
Yeah, this is from the patient point of view. I'm the patient representative, and I've read everything, and I still don't really understand. What do you do with the device that connects? Where does that go on the patient when they're using it?
Got it.
Wait, and what happens when you're somebody like me who doesn't sleep very calmly?
Yeah, good questions. So the goggles, get put on over the eye, and the pump is battery powered, so it's not plugged in. So people would lay with that next to them or slide it under their pillow while they're sleeping. So that's kind of where it goes. For those patients that are maybe a bit more restless at night, we weren't able to study that directly, but we do know that we can maintain a seal while patients are lying on their back, lying on their sides, or even lying on their face. If a suction break does occur, an audible beep will let patients know so that they can readjust the goggles if necessary.
Thank you.
Welcome.
Dr. Lofspring?
Yes, Dr. Edward Lofspring. I practiced dentistry for 40 years, so I'm a consumer representative. And my question is, I understand the CPAP machine from dentistry, and what I don't understand with this device, you studied it for 1 year. Do you stop it then, or what happens after that 1 year? Is there any studies on, do you continue using the device after that 1 year?
Thank you. We don't have any data beyond 1 year. As Dr. Samuelson mentioned, we used some of the guidance for the minimally invasive glaucoma surgeries that have been performed to guide some of our approach to designing this trial, which felt that 1 year was adequate to characterize the safety of the device over a longer period of time.
Dr. Parrish?
Thank you. A reference was made to the collaborative initial glaucoma treatment study as being funded by the National Eye Institute. In fact, it was not. In that study, to demonstrate either stability or progressions, I believe it took 5 visual fields at baseline and 5 subsequently, and the criteria were precisely defined. In reading through the information with respect to OCT, I didn't see whether this was RNFL, GCIPL measurements, how often they were done, what the reproducibility was, and also the visual fields are described as mean deviation change. I assume those are with standard automated perimetry, but I didn't see specific criteria defining what would constitute either a change or a stability. Just to address those questions. Thank you.
Yeah, I will try to address them briefly, and we can discuss them more later after the break if you'd like to try and stay brief. On the OCT side, just high level, the endpoint for this study was, the study was designed to meet the efficacy endpoint, not to demonstrate visual field progression or prevention of visual field progression, or with the OCT. The OCT analysis that we have, we did not have a standardized OCT in terms of every site had to have the same OCT. There was no change in baseline of the mean RNFL between study eye and control eye throughout the study. There was one instance in a control eye of one eye that had more than 10 microns of loss, but keep in mind that was a control eye and the signal strength was poor. The FDA, I don't believe, has seen this, but over the last week and a half, we looked a little bit more carefully at the OCTs to see how many had thinning of more than 5 microns. There were 5 in the study eye and 7 in the control eye that had more than 5 microns of loss. That was chosen for the test-retest variability. As far as the visual fields go, what we did is we focused on the reading center's analysis at the University of Iowa. And they went in and looked at those that had a mean deviation change of greater than 2.5 decibels, and they looked at all of the visual fields. And when they looked at all of them, they couldn't say that any of them actually progressed when you combined OCT and visual field. And they felt that many of the visual fields that were indeterminable were due to the measurement variability that comes with visual fields or unreliable tests. And so we certainly did not do the 5 visual fields at the beginning, at the end that are done in these major clinical trials.
Dr. Glasser.
Thanks, David Glasser, Baltimore. John, I want to go back to the question about the adjustments during the trial. It appears that sometimes the adjustments went up if the nocturnal study showed less than desirable response, or the numbers were turned down if patients were complaining of discomfort or adverse events. The clinicians are not going to have access to nocturnal data. What do you think the response is going to be? How are clinicians going to deal with that?
Yeah, I'll give my perspective, then I'll ask Leon Herndon to give his perspective on how he would treat patients as a clinician. One just quick clarification. The investigators did not increase the negative pressure in an effort to get a more impressive response rate. That was per protocol. So if the nocturnal IOP was elevated, then the eye pressure was the negative pressure was increased. So that was not discretionary. What was discretionary is if a patient was complaining about it or didn't tolerate it very well, the investigators were able to turn it down. So what I believe we as clinicians will do in the clinical setting is we'll say, here's your pressure measured in the clinic, subtract 6 from that. So if they were 18, you subtract 6, we dial in 12 of negative pressure. And then we would use it like we use other therapies, where you pay attention to if the patient is getting worse or how they're tolerating the therapy. And if they aren't tolerating it, perhaps we would dial back the negative pressure. And if they need additional treatment because we're worried that they're going to progress or they are progressing, then perhaps we would escalate the dose. Dr. Herndon, do you have anything to add to that? He says he has nothing to add to that.
Thank you.
Dr. Repka?
Michael Repke, Baltimore. One quick question. It has to do, John, with or Dr. Berdahl, with the labeling. And I'm curious to hear the glaucoma experts on your group and even on this panel talk about the labeling that goes beyond reducing intraocular pressure while the device is being used to actually having a beneficial effect on protecting that patient from progression of glaucoma. Certainly, the sample you have today is not going to be large enough, I suspect, to show that, and it doesn't, it almost certainly can't. So I was hoping for some guidance there from your perspective on that labeling indication.
Sure, I'll ask Dr. Samuelson to comment too, but keep in mind that IOP lowering is why every glaucoma drug or device is on the market. Visual field progression has not been a criteria of approval for any past glaucoma device or drug. Dr. Samuelson?
Tom Samuelson, Minneapolis. And Dr. Repka, is the question, will it help to lower pressure during that finite period of time? Is that the gist of it?
No, actually, I think it's saying the device can lower the pressure while it's being worn, but it's being worn for 4 to 6 to 8 hours a day. Does that actually prevent the progression of glaucoma, which is what the label is arguing?
Right. So during the trial, we asked patients to wear the goggles for 5 nights. And so they wore actually more than that. So the earlier question, I think it was Don Boudin's, we actually asked them per protocol to use it for 5 nights. And they did a bit better than that. I believe that lowering pressure during this period will be quite helpful. Anything you can do to lower the pressure, improve the area of control under the curve, better. This is all adjunctive therapy. Patients are already maximized with their best treatment you have available for them, but for whatever reason they're worsening. Anything you can do to lower pressure during this vulnerable time frame, and we can get into some theoretical things when you're recumbent, your pressure goes up, and for reasons we said earlier, this is an important period when none of our other therapeutics, other than say trabeculectomy and maybe a little bit of prostaglandin use, lowers pressure during the evening. Many things don't at all. Beta blockers, alpha-2 agonists, most of our treatments don't lower pressure during this time. So yes, I do think it will help. And one other comment I was going to make about the goggle wear is we've learned that when you have both eyes under negative pressure, it's a little more evenly distributed and probably a bit more comfortable. Patients in the Artemis trial only had one, so that could also improve wear time. Thank you.
And the last thing that I would say around that is that keep in mind that the label does not suggest that we slow the progression of glaucoma. The label only says that we do in fact lower IOP.
And I think that will be the last word. So I thank the sponsor for their answers to the questions, and we're going to now take a 15-minute break. Panel members, please do not discuss the meeting topic during the break amongst yourselves or with anyone attending virtually, and we will resume at 11:15. Thank you. So it is now 11:16 a.m. and I would like to call this meeting back to order. The FDA will now give their presentation. I would like to remind public observers at this meeting that while the meeting is open for public observation, public attendees may not participate except at the specific request of the panel chair. FDA will also have 90 minutes to present. FDA, you can now begin your presentation.
Good morning. My name is Mira Sethi, and I'm the lead reviewer for the subject de novo for the Balance Ophthalmics FSYX Ocular Pressure Adjusting Pump, otherwise known as the FSYX OPAP. This slide depicts the FDA review team for the subject de novo. The FSYX OPAP is eligible for evaluation under a de novo as the device, based on its intended use and technological characteristics, does not fit under any existing Class 1, 2, or 3 regulation, and there is currently no approved pre-market applications for the same device. To grant a de novo request, FDA assesses the scientific validity of the supporting non-clinical and/or clinical testing to establish reasonable assurance of safety and effectiveness. This is based on whether the probable benefits of the device outweigh the risk to health and whether all risk can be mitigated through application of general and special controls. In particular, special controls can include clinical testing, non-clinical testing, information and labeling, and other requirements as FDA determines as necessary. The FSYX OPAP consists of the following components. One of the main components of the FSYX OPAP is a set of eye goggles. The goggles are meant to be worn overnight by the user. They come in 3 different sizes, small, medium, and large, and are intended to create an airtight chamber in which negative pressure can be created and maintained in front of each eye. The patients can adjust the head strap to make sure that the goggles are affixed properly. Each eyepiece is attached to a tube to create and sense negative pressure for independent treatment of each individual eye. At the end of the 2 tubes is the connector, which is what contains the pressure sensors for constant monitoring and control of the pressure in each eyepiece. The next component is the programmable pressure modulating pump. The pump housing includes 2 mini diaphragm pumps for creation of negative pressure for each eye. The pump housing also includes a touchscreen or display, which allows for physician programming of the negative pressure. The pumps are connected to a manifold that pneumatically interfaces with the connector integral to the tubing system of the goggles. The overall concept is that to create negative pressure for each goggle lens, the pump extracts air from the cavity created by the goggle and the patient's face. For each individual eyepiece of the goggle set, there is a separate pump and negative pressure line, which is what allows for independent negative pressure application treatments for each eye. The overall mechanism of action, as described by the sponsor, is based on Pascal's law, which states that when there is a change in pressure at any point in a confined fluid, there is an equal change throughout the fluid. With the goggles properly situated over the eyes and negative pressure applied via the programmable pump, there is a decrease in pressure applied locally to the eye, which results in a corresponding change to the pressure inside the eye. The application of negative pressure increases the intraocular volume with no change in the amount of intraocular fluid, resulting in reduced intraocular pressure, or IOP, relative to atmospheric pressure. To allow for the measurement of IOP during the application of negative pressure during the clinical trials, the sponsor developed the excursion goggles. These goggles are a modification of the eye goggle component of their device. These goggles include an access port which allows for a probe to go through the goggle, which allows access to the eye while maintaining a seal during negative pressure application for measurement of IOP using a Riker Model 30 pneumotonometer. Please note that the measurement of IOP obtained using the excursion goggles is the pressure inside the eye relative to atmospheric pressure. The sponsor currently proposes the following indications for use. The FSYX Ocular Pressure Adjusting Pump, or FSYX OPAP, is indicated as adjunctive therapy for the reduction of intraocular pressure during nightly use in adult patients with open-angle glaucoma and intraocular pressure less than or equal to 21 millimeters of mercury. The target condition that the device aims to treat is glaucoma. Glaucoma is a group of diseases that damage the eye's optic nerve and can result in vision loss and blindness. The device more specifically aims to treat open-angle glaucoma, in which the angle of the eye, that is, the space formed by the meeting of the iris and the cornea, is not narrowed or closed. In the United States, open-angle glaucoma is the most prevalent form. Glaucoma is often, but not always, associated with elevated IOP. Currently legally approved medical products in the U.S. to lower IOP include topical and oral medications, drug-eluting implants, laser and surgical treatments, and permanent implants. Today we wish to solicit the panel's opinion on whether the probable benefits of the device for the proposed indications for use outweigh the risk to health. The sponsor initially introduced their device as the Equinox Balance Goggle System, or BGS, in a pre-submission in 2017. It was in this pre-submission that the sponsor was notified that the de novo pathway would be the most suitable regulatory pathway for this device. The sponsor requested feedback on their proposed clinical study design and non-clinical test plan. In 2018, the sponsor submitted a supplement to this pre-submission to discuss the proposed bench testing for the excursion goggles, which, as I previously discussed, were a modification of the sponsor's device that allowed for IOP measurements while the device was in use. The sponsor also sought feedback from the FDA regarding the revised clinical study protocol and human factors test plan. In response, FDA communicated concerns related to the validity of the sponsor's bench testing to validate the excursion goggles and concerns related to the human factors test plan. The agency also provided recommendations on the clinical study design, such as the enrollment of subjects on medication, the appropriateness of endpoints, and the calculation of the sample size. In addition, it was recommended that the sponsor include a patient-reported outcome questionnaire to evaluate the tolerability of their device and to evaluate device safety. After obtaining FDA feedback and prior pre-submissions, the sponsor officially submitted their first de novo proposing classification into Class 2 with a number of special controls identified. The device name was changed from the Balance Goggle System to the Mercury Multi-Pressure Dial, or MPD system. However, the technology remained the same. In support of this de novo, the sponsor provided the results of a 90-day clinical study, CP10, also known as the Apollo study. Apollo was a prospective multi-center study on adults aged 22 or older with either ocular hypertension, a diagnosis of glaucoma suspect, or open-angle glaucoma. Participants underwent a 2-week run-in phase, which was used to acclimate participants to device use at home. Those who were randomized were required to meet the device use adherence criterion of successfully achieving at least 3 hours of device use averaged across a minimum of 3 nights within a consecutive 7-day period. One eye was randomized to receive negative pressure application with the device, and the fellow eye was the control eye. The trial duration was 90 days, excluding the run-in phase. The primary effectiveness endpoint was the proportion of eyes at day 90 with intraocular pressure reduction of 20% or more during device use compared to the intraocular pressure measured at the same visit before device use. Please note that this IOP endpoint was measured by pneumotonometry through excursion goggles during negative pressure application. A superiority test was performed using a 2-sided significance level of 0.05. Safety outcomes included best corrected distance visual acuity loss of 10 letters or more, rates of ocular and periocular adverse events, slit lamp biomicroscopy and dilated fundus examination findings, mean deviation and pattern standard deviation parameters on automated visual field testing, and intraocular pressure by Goldman applanation tonometry. There were, however, no formal safety endpoints pre-specified for this study. 91 participants were enrolled and 64 were successfully randomized into the trial and completed the 90-day visit. These 64 participants comprised the primary analysis population for effectiveness. Of these 64, approximately 2/3 had open-angle glaucoma, a quarter had ocular hypertension, and about 9% were glaucoma suspects. At day 90, participants averaged 4.4 hours of nightly use during the trial interval preceding day 90. Across 30-day visit intervals throughout the trial, the average number of days with device use ranged from 24.8 to 27.3 days. Of those who completed the 90-day visit, 81.3% of the study eyes and 3.1% of the control eyes achieved the primary effectiveness endpoint. The mean percent change in intraocular pressure by Global applanation tonometry before versus after device use was reported as an exploratory endpoint. The results at day 90 demonstrated a change of negative 5.7% in study eyes and negative 4.8% in control eyes. Key adverse events are summarized in this table. These include eyelid edema, signs and symptoms of dry eye, conjunctival hyperemia, and eye pain. None of these were considered serious. The ocular adverse events were considered mild or moderate and self-limited. The cumulative rate of visual field mean deviation loss of 2.5 decibels or more was 17.2% in study and control eyes. At day 90, this was reported in 6 of 58, or 10.3% of study eyes, and 4 of 58, or 6.9% of control eyes. Please note that this visual field change was not reported as an adverse event in the trial. Visual fields with unreliable testing metrics or with changes indicative of possible worsening were not repeated in this trial. The most common non-ocular adverse event was a headache, reported in 10.9% of participants. Note that all of these reports were from participants with open-angle glaucoma. One participant also reported difficulty sleeping. FDA sent a letter requesting additional information on August 14, 2020. The agency noted several concerns, including insufficient clinical data to support the proposed IFU. Specifically, the data did not support use across the intended patient populations, specifically for glaucoma suspects and those with ocular hypertension, and the data from the 90-day study was not adequate to demonstrate a sustained lowering of IOP. With regard to safety, there was inadequate reporting of clinical assessments used for determining glaucoma progression. There was also inadequate information on the reported non-ocular adverse events, in particular headaches and difficulty sleeping. The agency also noted uncertainty regarding the benefit of temporarily lowering IOP for a few hours nightly in light of the chronicity of glaucoma. Lastly, questions were raised regarding the dose-response relationship. That is, the program negative pressure did not result in an equivalent decrease in the measured IOP during device use. Non-clinical concerns were also raised, including questions regarding the validation of the excursion goggles used to measure pressure during the study. As a part of their response to the deficiency letter, the sponsor modified the indications for use to specify that the device reduces IOP during use, that is, only during negative pressure application. The sponsor also provided additional bench testing to support the validity of the excursion goggles for measurement of IOP at office visits, and they responded to our safety and other non-clinical concerns. Regarding the bench testing, FDA had no additional concerns regarding the validity of the excursion goggles for providing a measurement of the pressure inside the eye. However, during the review of the supplement, concerns were raised regarding the definition of IOP used by the sponsor during their study, and safety and effectiveness concerns associated with the pressure changes experienced by the eye, which I will explain in the next few slides. Intraocular pressure is defined as the difference between the pressure inside the eye and the pressure directly outside of the eye, or the transcorneal pressure difference. This slide illustrates the excursion tonometry method used by the sponsor to measure pressure inside the eye during their pivotal trial. The most widely accepted IOP measuring technique is Goldmann applanation tonometry, which assesses the difference between the pressure inside the eye and the atmospheric pressure directly outside the eye. When the eye is under negative pressure inside the goggle space, the difference between the pressure inside the eye and the lowered pressure inside the goggle space cannot be directly measured. The excursion method provides IOP as the pressure inside the eye relative to atmospheric pressure, but it does not account for the negative pressure environment immediately outside of the eye. So while the device causes a decrease to the pressure inside the eye relative to atmospheric pressure as measured by excursion tonometry, the transcorneal pressure difference between the inside of the eye and the negative pressure environment is actually increased. It should be noted that due to this novel approach of lowering pressure inside the eye, it is unclear what effect the potential stresses caused by the application of negative pressure would have on the anterior segment of the eye and other ocular structures, such as the retina and optic nerve head. These questions regarding the definition of IOP and the effects of the increases in transcorneal pressure caused by the use of the device have also been discussed in published articles about the subject device. In light of the concerns just discussed, FDA issued a second deficiency letter on January 6, 2021. In this letter, concerns were raised regarding potential glaucoma worsening in some of the participants, absence of data demonstrating safety and effectiveness of long-term use of the device, meaning beyond 90 days, and the inadequate discussion of the benefit of temporary reduction of IOP during the nightly use of the device for all of the populations included in the indications for use. In addition, we communicated concerns that the pressure inside the eye relative to the pressure directly outside the eye is increasing, and that the effects on the eye that accompanies this pressure increase, for example, the increase in ocular volume, could cause distension of ocular tissues that may lead to lamina cribrosa distension, causing increased stress on the optic nerve, thereby potentially worsening glaucoma. Therefore, we requested non-clinical testing to establish whether the device raises or lowers pressure differences across the cornea and across the posterior sclera during use. The sponsor submitted a Q-submission following receipt of the second deficiency letter to discuss the safety concerns related to the concern that application of negative pressure may cause an increase in IOP. To address these concerns, the sponsor proposed different terminology to clarify the definition of IOP and summarize preliminary data from several studies conducted using the device to demonstrate that the pressure inside the eye decreases during application of negative pressure. The sponsor also requested feedback to address safety concerns that an increase in transcorneal pressure difference, or TCPD, may result in increased tension of the optic nerve that may result in worsening of glaucoma. Those studies will be discussed further on the next slide. As a part of our feedback, we recommended that the sponsor recalculate the IOP data collected in the study based on the TCPD definition of IOP to validate that the device is supportive of the proposed IFU. We noted that if the calculations demonstrated the TCPD during application of negative pressure is less than the pre-negative pressure TCPD, then no additional testing would be needed to verify that their device lowered IOP. However, if the TCPD was greater than the pre-negative pressure TCPD, then further clinical data would be needed to support the effectiveness of the device and to address safety concerns such as the possible effects to the optic nerve head and anterior chamber. In the sponsor's response to our second request for additional information, they proposed modifications to their IFU which narrowed the patient population to patients with open-angle glaucoma. The sponsor acknowledged that the transcorneal pressure difference increased between 21.7 to 26.9% across all visits in the clinical study during negative pressure application. However, the sponsor maintained that the internal eye pressure is decreased overall with application of negative pressure and provided preliminary results of several studies to support their position. One of the ancillary studies were results from a living donor model. The study evaluated the relationship between negative pressure application and absolute IOP. Direct IOP measurements during negative pressure application were collected on brain-dead organ donors via a pressure transducer. Baseline pressures were set at 10, 20, and 30 millimeters of mercury. 15 millimeters of mercury of negative pressure was then applied, and direct IOP measurements were recorded at the 1 and 2 minute marks. While FDA agreed that the data demonstrated reduction of the pressure inside the eye during negative pressure application, FDA did not believe that the data collected based on only 1 to 2 minutes of pressure application was adequately reflective of the device use as indicated. Additionally, the sample size of 2 limits the generalizability of the study. The sponsor also investigated the impact of external negative pressure on the retrobulbar pressure in a full body cadaver model. The objective was to obtain direct measurements of pressures via manometry within the goggle space, inside the eye, and in the retrobulbar space behind the globe prior to, during, and after negative pressure application. IOP and retrobulbar pressure measurements were obtained from 2 eyes of 2 full body cadavers through a fluid catheter connected to a sensor. The results demonstrated essentially no change to the retrobulbar pressure during negative pressure application. The study also demonstrated a reduction in the pressure inside the eye during negative pressure application. However, FDA identified concerns that the interpretability of the data is limited due to the small sample size. Next, the sponsor provided evaluation of intraocular blood flow and vascular resistance prior to, during, and following negative pressure application in normal and glaucoma subjects using laser specklography. IOP measurements were taken immediately before and after wearing the goggles. Data was collected from 7 glaucoma eyes and 22 healthy eyes. Analyses included % change in blood flow in the optic nerve head rim, in the peripapillary retinal arterioles, and in the areas inside and outside the choroidal hypoperfusion zone. The sponsor concludes that in the setting of an unchanging blood pressure, increased intraocular blood flow occurs via reduction in IOP relative to atmospheric and retrobulbar environments surrounding the eye. FDA's perspective was that although the data demonstrated increased blood flow at the optic nerve head during application of negative pressure, the sponsor did not provide data to support the vascular resistance change measured by laser specklography was an adequate biomarker for IOP change. In addition, the study failed to demonstrate whether optic nerve head blood flow would remain increased during extended periods of applied negative pressure, given that the study only provided measurements of optic nerve head blood flow for 5 minutes of applied negative pressure. Lastly, OCT and OCTA imaging on glaucoma patients was evaluated for the physical effects of negative pressure on various structural and vascular parameters. The sponsor reported on an ongoing prospective randomized clinical trial in adults diagnosed with mild to moderate open-angle glaucoma. Images were captured during device use at different applied negative pressure levels ranging from 0 to 20 millimeters of mercury, held for 2-minute increments. FDA identified several limitations to the study, including the limited sample size, study enrollment which excluded severe glaucoma patients, the limited time of negative pressure application that was not consistent with the proposed use of the device, and uncertainty about the methodology given the limited details provided. After review of Supplement 2 of the first de novo, questions remain related to the safety and effectiveness of the device, and the de novo was declined on September 10, 2021. Regarding device effectiveness, an increase in transcorneal pressure difference raises concern regarding the uncertainty in the clinical benefit, which was not adequately addressed with the ancillary data provided given the limitations discussed. Regarding safety, the pivotal trial and ancillary studies submitted were not designed to adequately collect the types of assessments needed to evaluate safety risks related to the novel IOP lowering approach of the subject device. Based on the significant uncertainty regarding the totality of evidence provided, We did not believe that the data supported a decision that the benefits of the device outweigh the risks for the proposed IFU. Following the decline letter, the sponsor submitted a pre-submission in 2022. In this pre-submission, the sponsor requested feedback on the evidence needed to address concerns raised in the decline letter and whether data being currently collected from their 12-month clinical study, CP19, would be acceptable in support of their de novo. The sponsor also requested input from external experts. At the sponsor's request, the agency sought feedback from 4 special government employees, or SGEs, through an agency-directed assignment. SGEs consisted of 3 glaucoma specialists and 1 ocular imaging expert. These SGEs are not participating today as panelists for this advisory committee meeting. The SGEs were not asked to respond directly to each of the sponsor's questions in this pre-submission. The questions posed to the SGEs were drafted with careful consideration of issues for which FDA perceived SGE input would assist FDA in providing recommendations to the sponsor's specific questions. The SGEs were asked to provide input on what appropriate assessments for both safety and effectiveness would be needed, whether any additional safety concerns exist that were not identified in relation to the 90-day Apollo pivotal trial, safety concerns for the sponsor's newly proposed 12-month trial, and whether there were concerns related to the dose-response relationship. Regarding effectiveness, concerns were raised that the device reduces periorbital pressure, not IOP, therefore the causal physiological mechanism between the periorbital pressure reduction and changes in IOP should be established. It was also recommended that the additional data is needed to better define the dose-response relationship and durability of the treatment to assess the IOP lowering. All SGEs recommended additional assessments to adequately address safety concerns, including visual fields or perimetry, OCT imaging of the optic nerve head morphology during and after use, and that adherence of device use should be assessed. There was also an emphasis by the majority of the SGEs that safety assessments should be performed following a full 1 year of use for the labeled 8 hours per night. There was also a recommendation to include health-related quality of life evaluations, such as sleep disturbance, to evaluate device safety. The majority of the SGEs also expressed that the potential for optic nerve damage is a concern that has not been adequately addressed in the sponsor's prior studies. Lastly, all SGEs identified potential corneal concerns related to device use, including potential aggravation of ocular surface disease, or OSD, dry eye syndrome, hypotony, corneal endothelial damage, potential impact to functioning filtration blebs, and potential impact to corneal graft. A full copy of the FDA questions to the SGEs and their complete responses were provided to the sponsor. The sponsor submitted a follow-up pre-submission in which they proposed a 12-month clinical study called the Discovery Study and modifications to their IFU to specify that the device is intended to serve as adjunctive therapy for patients with open-angle glaucoma. To ensure consistency of the feedback provided, FDA again requested input from 3 of the 4 previous SGEs. Recommendations were provided to the sponsor regarding the study design, such as the appropriate assessments to evaluate for a progression of glaucoma, adequate sample size, evaluation of dose-response relationship, and other measures for the adequate evaluation of safety, including the inclusion of a patient-reported outcome questionnaire based on reports of events such as sleep disturbance, headaches, and difficulty with device use reported in the Apollo study. As was done previously, the agency provided a complete copy of the SGE feedback to the sponsor. It should be noted that the clinical study discussed during this pre-submission was never submitted to the FDA in support of the current de novo request. In August 2023, the sponsor officially submitted their second de novo for the FSYX Ocular Pressure Adjusting Pump. The device is identical to the mercury multi-pressure dial system described in the first de novo. The currently proposed IFU states that the device is indicated as adjunctive therapy specifically for open-angle glaucoma patients with an IOP less than or equal to 21 millimeters of mercury and is intended for reduction of IOP during use. Non-clinical studies for the FSYX OPAP included biocompatibility, sterilization, software, cybersecurity, electromagnetic compatibility or EMC, electrical safety bench testing, and human factors. The review of all studies except for software have been completed and were found to be satisfactory by FDA reviewers. The software review is currently ongoing. The panel will not be asked to discuss the non-clinical testing. FDA's presentation today will focus on the discussion of the clinical studies, which will be discussed by Dr. Carol Lin.
Hello, my name is Carol Lin. I am a medical officer and glaucoma specialist in the Office of Health Technology 1 and the clinical reviewer for this de novo classification request. I will be presenting key information from the pivotal clinical study presented by the sponsor in support of this de novo. The clinical data submitted in support of the subject de novo are summarized on this slide. The sponsor proposed that data collected from the Artemis study serve as the primary basis for the establishment of the safety and effectiveness of the OPAP device. As a reminder, the Artemis study had already been initiated prior to the sponsor receiving feedback from the agency in pre-submission Q4. Additionally, data from the Apollo study presented in the first de novo and information from 10 other pilot and feasibility studies were provided to supplement the information from the Artemis study. These pilot and feasibility studies will be briefly discussed after presentation of the Artemis results. Lastly, I will discuss Protocol CP24, or the CONFIRM study, which was a prospective, basic physiological study in which IOP was measured manometrically in patients undergoing routine cataract surgery. The objective of the Artemis study was to evaluate the safety and IOP-lowering effectiveness of the subject device with negative pressure application as an adjunct treatment for patients with normal tension glaucoma. The Artemis study, as summarized on this slide and described in our executive summary, has been summarized in the sponsor's presentation. In the next few slides, I will only highlight some of the pertinent points. The primary effectiveness endpoint was the proportion of eyes with intraocular pressure reduction of 20% or more at week 52. This was defined by the difference between the IOP measured immediately before negative pressure application and the IOP measured immediately after negative pressure application during the same visit. The secondary effectiveness endpoint was similar to the primary one, except for nocturnal IOP instead of in-clinic IOP. Nocturnal IOP was calculated by averaging IOP measured in the supine position at 11 p.m., 2 a.m., and 5 a.m. in a sleep lab setting. Both effectiveness endpoints were based on IOP as measured by pneumotonometry through excursion goggles while the device was in use, that is, during the application of negative pressure. The superiority hypothesis between the study eye and the control eye was pre-specified to be tested at a two-sided alpha level of 0.05 for both the primary and secondary effectiveness endpoints. There were no formal safety endpoints pre-specified for this study. Safety outcomes or clinical assessments of interest included best corrected visual acuity loss of 10 letters or more, rates of ocular and periocular adverse events, slit lamp biomicroscopy and dilated fundus examination findings, and intraocular pressure by Goldmann applanation tonometry. This slide summarizes the visit schedule. Eligible participants underwent a 2-week run-in to get acclimated to device use at home. Those who were randomized at the end of the run-in phase were required to meet the device use adherence criterion of successfully achieving an average of at least 3 hours of device use averaged across a minimum of 3 nights within a consecutive 7-day period. After randomization, there were 2 scheduled sleep lab visits, the first within 3 weeks of randomization, the second at week 52 to measure intraocular pressure during overnight device use for 6 to 8 hours. There were also 5 scheduled in-office visits after randomization. As previously presented by the sponsor, 165 participants were enrolled and 94 were randomized in the Artemis study. 1 participant was found ineligible after randomization. Therefore, primary analyses are based on data from 93 participants. 62 completed both week 52 in-office and sleep lab visits. The other 31 exited the study early. The majority of these early exits were due to withdrawal of consent or non-adherence to home device use. Key inclusion and exclusion criteria are shown here. Please note that participants were allowed to continue taking their topical IOP-lowering medications during the study. The study eye negative pressure level was programmed by subtracting a reference IOP of 6 from the IOP as measured by pneumotonometry with goggles off. Participants were instructed to use the device for 6 hours per night, 5 or more nights per week. Please note that under revision 5 of the protocol, negative pressure programming after randomization would be at the investigator's discretion, according to the investigator's assessment of participants' comfort, complaints, adverse events, or decreased sleep-wear time. As previously presented by the sponsor, the following analysis cohorts were defined. To recap, the primary effectiveness endpoint was the proportion of eyes with IOP reduction of 20% or greater at 52 weeks, as measured via pneumotonometry with excursion goggles worn from before to during application of negative pressure during in-clinic visit. For the modified intent to treat cohort of 93 participants, 58.1% of study eyes versus 1.1% of control eyes achieved the primary effectiveness endpoint. The between group difference was 57%. This difference was found to be statistically significant. For the secondary effectiveness endpoint, 63.4% of study eyes versus 3.2% of control eyes achieved an IOP reduction of 20% or greater at the week 52 sleep visit. The between group difference was 60.2%. This difference was found to be statistically significant. For both endpoints, eyes with missing values were imputed as failures. Based on these results, the primary and secondary effectiveness endpoints were considered met. As previously presented by the sponsor, participants averaged 5.4 to 5.6 hours of daily or nightly device use. 4.3% of participants used a device for more than 7.5 hours nightly during the majority of the study intervals. 8.6% of participants used negative pressure levels at the highest end of the labeled range. During the run-in phase of the study, periorbital adverse events were reported in about 5% of the 122 participants who initiated the run-in phase. Headache was reported in about 3%. These events were considered device-related and mild. Please note that these adverse events are not included in the adverse events rates reported on the safety cohort. The most frequently reported ocular adverse events are shown in this table. None of these were considered serious. As shown here, these include eyelid edema, signs and symptoms of dry eye, conjunctival hyperemia, and eye pain. The adverse events marked with an asterisk denote those events for which some or all such reports in the study eye were considered device-related. The reported periorbital adverse events are shown in this table. The most frequently reported periorbital adverse events are periorbital edema, periorbital contact dermatitis, and periorbital pain. Device-related headache was reported in 2.2% of participants. These events resolved after decreasing the negative pressure level. All participants were scheduled to undergo visual field testing using the Humphrey Field Analyzer at 3 time points: day -14, week 26, and week 52. Mean deviation worsening of 2.5 decibels or more was reported in 10.9% of participants at week 26 and 6.5% of participants at week 52. Please note that the requirement to report mean deviation loss of 2.5 decibels or more compared to visit 1 as an adverse event was not added to the protocol until approximately 23 months after the study was initiated. Please also note that additional testing specifications were added at that time. This included specification of the testing algorithm, the size of the stimulus target, and the use of the appropriate study lens as defined by the perimeter. The extent to which visual field testing varied without these additional stipulations in place remains unclear. Optical coherence tomography, or OCT imaging of the optic nerve head, was performed at baseline, week 26, and week 52 of the Artemis study, according to the OCT manufacturer's instructions for use. Please note that no formal quantitative analysis of OCT data was performed as part of the Artemis analysis plan. The mean retinal nerve fiber layer thickness in the 62 participants who completed the week 52 visit was 77.9 micrometers in the study eyes at both baseline and at week 52. In the control eyes, RNFL thickness was 77.3 micrometers at baseline and 77.5 micrometers at week 52. One control eye was reported with retinal nerve fiber layer thinning of greater than 10 micrometers at week 52. It was noted that the signal strength of the week 52 scan was 4 out of 10, while the baseline scan signal strength was 8 out of 10. Regarding the assessment of glaucoma in the Artemis study, investigators regularly evaluated the optic nerve head during the study. However, the sponsor notes that the Artemis study was not designed to assess glaucoma progression. Visual field and OCT data from week 26 and 52 were assessed post hoc by a third-party reading center, the Iowa Visual Field Reading Center, or VFRC. The VFRC also performed the same post hoc assessment for visual field and OCT data collected in the Apollo study. Two readers first analyzed visual fields only to determine if visual fields worsened. Then they performed a second analysis of the visual fields, but with addition of OCT data. A third reader served as an adjudicator when there was disagreement. 73.1% of participants had visual field examinations collected at glaucoma progression time points. According to the sponsor's original Artemis study report, of the 62 participants who completed the week 52 visit, 79% of the study eyes and 72.6% of the control eyes had visual field results of sufficient quality for analysis. Progression by visual field results alone was reported for both eyes of a single participant. When analyzing OCT data in addition to the visual fields, no progression in any participant was reported. Two control eyes and two participants were deemed indeterminable by the combined analysis of visual field and OCT. Indeterminable means that the VFRC readers considered the images sufficient in quality, but nevertheless were unable to determine if progression was present. 9 eyes and 7 participants were reported with mean deviation worsening of 2.5 decibels or more at week 26. Of these 7 participants, 4 had visual fields that were deemed insufficient for analysis. For the other 3 participants, no progression was determined for either eye. At the week 52 time point, 6 eyes of 4 participants were reported with mean deviation worsening of 2.5 decibels or more. Of these 4 participants, visual fields were deemed insufficient for analysis in 2 study eyes and 3 control eyes of 3 participants. In 1 participant, progression was not found in the study eye, and progression was indeterminable in the control eye. As part of the current de novo, the sponsor also submitted a post hoc analysis performed by the Reading Center on the visual field and OCT data from the Apollo study. Progression by visual fields alone were found in 1 study eye of 1 participant and 1 control eye of another participant. 2 participants were deemed indeterminable by visual fields alone. 2 participants were deemed indeterminable by visual fields and OCT. Mean deviation worsening of 2.5 decibels or more were reported in 10 eyes of 6 participants at day 90. The visual fields for half of these 6 participants were insufficient for analysis. One participant was reported with progression in one eye, but not the fellow eye. Of note, available visual field and/or OCT information collected outside of the study window were also assessed by the reading center in 4 of the 6 participants. However, pre- and post-study visual field and/or OCT information was not assessed for all participants in this study. The protocol numbers for the 10 supplemental pilot and feasibility studies are listed here. Studies marked with an asterisk indicate a study in which at least one adverse event was reported. Please note that most of these early studies investigated previous and different versions of the device. Only the protocol numbers highlighted in red here denote those studies in which the current version of the device, Generation 2B, was investigated. Some of these studies enrolled patient populations that are different from the currently intended patient population. Furthermore, most of them were designed to investigate the use of the device in a single session of use in a clinic environment and with different negative pressure programming. Only those protocol numbers highlighted in green here denote those studies in which multiple session device use in the home environment was investigated. Therefore, the data from these studies may not be directly poolable. Furthermore, the applicability of the data from these studies to the current device version and the current indications for use may be limited. Please note that FDA has not provided any direct input on any of these prior studies. The sponsor provided the results of their confirmed study, which was intended to evaluate the physiological change in IOP with application of negative pressure from the FSYX Ocular Pressure Adjusting Pump using mmHg. Please note that FDA has not provided any direct input on the confirmed study. The study enrolled 20 participants who were undergoing routine cataract surgery. 3 were excluded due to facial anatomy precluding a stable seal with the OPAP goggles. A diagnosis of glaucoma was not required. Only 3 of the 17 participants had glaucoma. Participants received negative pressure application with the OPAP device immediately prior to cataract surgery, and IOP was measured manometrically while NP was applied. Manometric IOP was continuously measured every 500 milliseconds for approximately 30-second intervals during 30 to 90 seconds of negative pressure application at -10 millimeters of mercury. Manometric IOP was then continuously measured at the same frequency during 30 to 90 seconds of negative pressure application at -20 millimeters of mercury. The anterior chamber was cannulated with an AC maintainer prior to initiation of the sequence. Manometric IOP measurements were collected on 14 of the 17 participants. In 3 participants, manometric measurements were not obtained due to poor seals around the cannula of the AC maintainer. The results from the confirmed study demonstrate a mean % decrease in IOP from baseline of 33.1% during -10 millimeters of mercury of negative pressure application and 51.2% during -20 millimeters of mercury of negative pressure application. However, when evaluating the dose-response relationship, that is, the mean reduction in IOP as a function of the change in the applied negative pressure, the mean reduction at a dose of -10 was 56%, with a range between 35 to 78%. The mean reduction at a dose of -20 was 40%, with a range between 22.5 to 53.5%. The summary of the benefit-risk assessment will be presented in the next few slides. As a reminder, the proposed indications for use is the FSYX Ocular Pressure Adjusting Pump is indicated as adjunctive therapy for the reduction of intraocular pressure during use in adult patients with open-angle glaucoma and IOP of 21 millimeters of mercury or less. The sponsor defines the alternative IOP parameter as TCPD relative to atmospheric pressure without accounting for the MP microenvironment. Although the data demonstrated that this alternative IOP parameter is lower temporarily when the device is in use, TCPD relative to the applied MP in front of the eye actually increases by approximately 21.7% to 26.9% with device use. Therefore, IOP defined in one way increases, while IOP defined in another way decreases. Data from the Artemis study form the primary basis for the establishment of effectiveness of the OPAP device. In CP19, the pre-specified primary and secondary effectiveness endpoints were met. At the week 52 clinic visit, 58.1% of study eyes and 1.1% of control eyes achieved a reduction of IOP by excursion tonometry of 20% or more while the device was in use. At the week 52 sleep lab visit, 63.4% of study eyes and 3.2% of control eyes achieved a reduction of IOP of 20% or more while the device was in use. While the effectiveness endpoints were met, there is uncertainty to the benefit of these observed outcomes. The impact of lowering gold-bond applanation tonometry-based IOP has been well studied. However, it is uncertain whether lowering excursion IOP while raising the transcorneal pressure difference between the inside of the eye and the negative pressure environment outside of the eye has the same assumed benefit of slowing glaucoma progression as lowering IOP with other alternative treatments. Next, excursion IOP is lowered only when the device is in use, that is, when negative pressure is being applied to the eye. When the device is not used, whether due to adverse effects, poor tolerability, or lack of patient adherence, it is unclear whether there is benefit. Also, the way the negative pressure level was programmed for the majority of the Artemis study duration was not standardized. While the negative pressure level can be adjusted based on patient feedback, on discomfort, or on adverse effects, it remains unclear whether discretionary adjustments to MP level retains benefit. This is particularly relevant since a physician would not be able to measure IOP in patients to confirm pressure-lowering effects during real-world use without excursion goggles. It is also unclear whether there is benefit to using the device for a short period of time. In addition, the sponsor has not provided information on the variability of the dose-response effect for the Apollo and Artemis studies. The most frequently reported adverse events in the Artemis study were related to redness and swelling of the eyelid and periorbital areas, and signs and symptoms of dry eye. Eye pain and headache were also reported. Most of these events were not considered serious and resolved after cessation of device use or by adjustment of the negative pressure level. Posterior vitreous detachment was reported in a small percentage of participants, but PVD is not a totally benign event, as it can lead to retinal tears and/or retinal detachment. Of note, no retinal tears or retinal detachments were reported in the Artemis study. There are several sources of uncertainty with the safety information obtained in the Artemis study. Harmful effects on the optic nerve head, as manifested by glaucoma progression, were neither definitively detected nor ruled out due to a variety of study design limitations. This includes the limited duration of the study, the small sample size, the methodology behind the relevant clinical assessments, and the post hoc nature of the analysis for detecting glaucoma progression. Thus, the impact of the device on glaucoma progression is uncertain. The sponsor studies did not incorporate the use of a validated quality of life assessment to evaluate measures relevant to device use. Therefore, the impact of the device on the relevant aspects of the patient's health-related quality of life, such as sleep disturbance, is uncertain. The average device wear time in the Artemis study was about 5.5 hours per day. The tolerability of device use for the recommended duration of 8 hours per night is uncertain. Only 9% of participants used a device at a negative pressure level of -17 or more for at least 26 weeks. The tolerability of device use at the highest allowable negative pressure level is uncertain. Additionally, long-term effects of chronic biomechanical strain on the eye under negative pressure remains unknown. Thank you very much for your attention.
This concludes FDA presentation.
Thank you very much. I would like to thank the FDA speakers for their presentation. Does anyone on the panel have any clarifying questions for the FDA? While we're waiting for some hands to raise, I have a question on the visual field that had potential worsening, those at week 26 and those at week 52. Were some of those the same patients or they were different patients?
I'm going to ask Carol to turn on her camera. Carol, please introduce yourself and answer the question.
Hi, everyone. This is Carol Lynn, Medical Officer in OHT1. I do not know whether they're the same patients or not.
Thank you. Dr. Schumann?
Are the results of the visual fields, whether better or worse, or indeterminate, and the results of the OCT measurements relevant to our decision making in this event?
So, it is up to the panel's discretion and we'll look for your recommendation as to the impact of OCT and visual fields on the assessment of safety and benefit of this device.
Thanks, Malvina.
Dr. Wong?
Sorry. This is Andrew Huang from Washington University. My question is directed to Dr. Lin and Dr. Edelman. In the 2021, the response after the SG outside SG evaluation, and there was some concern raised about the ocular surface well-being as well as the corneal endothelial well-being. That because the device is putting the eye under the negative pressure and may cause corneal distress, and also clinically that we know that when the patient in the high altitude with the reduction of the atmosphere pressure, they can also have some corneal decompensation and then induce visual change or sometimes corneal edema. So I was wondering, has the sponsor subsequently addressed those issues, or if the FDA think the response was sufficient? Thank you.
So I'm going to ask Dr. Lin to come on camera. Also, I just want to clarify for the sponsor that these are FDA. This is a time for clarifying questions for FDA, and the sponsor will have a chance to come back after lunch break.
So in the Artemis study, I'm sorry, this is Carol Lynn, Medical Officer. In the Artemis study, there were no reports of corneal decompensation or signs of corneal decompensation. Corneal edema was not a pre-specified or anticipated AE that was listed in the protocol.
And one thing I had a question on this, but this seems like a good time to bring it up, is in the material provided to us from the sponsor, there was one patient they reported on slit lamp exam that at 1 year out had 1+ gutata, but they didn't notice any gutata on entry. I didn't have a chance to ask the sponsor about that, but that might relate to what you're asking, Andrew.
Yes. Mm-hmm. Also, they had pachymetry data, but it's unclear was the pachymetry data was all the participants or some of the patients after they have a better response under the negative pressure.
Cornea people think alike. Dr. Skuda.
Thank you. So regarding the Apollo and Artemis studies, had the FDA recommended formal safety endpoints? I mean, did they have some recommendations in that regard or suggest that they be submitted to you in advance? I'm not quite sure how the process works, but just would appreciate your response.
So as was summarized, I'll start and then I'll ask Tui to finish, but as we were trying to convey in a couple of slides, the clinical study, the 12 months clinical study that you are reviewing has been conducted without incorporating any of FDA's input. FDA has been communicating for quite a long time back and forth, as was summarized in our slide deck, and we have communicated to the sponsor all of the recommendations that my team provided, as well as all of the special government employees' feedback on both safety and effectiveness.
And regarding visual fields, I mean, in the sponsor's presentation earlier, there was a subset of patients in the Artemis study. I don't have my notes in front of me right now, but 6 patients, as I recall, who had more than 2.5 decibels of change, who ended up having repeat visual fields that the Iowa Reading Center did not feel showed progression. Were those repeat visual fields available to the FDA, or was that something done beyond the study, so to speak?
Carol, are you ready to answer that now?
We were not provided with repeat visual fields.
And is that routine, not routine? I'm not quite sure again what protocol usually is here.
So in the Artemis protocol, visual fields were supposed to be repeated if they were deemed unreliable.
Thank you.
Dr. Repka?
Could Dr. Higginbotham has had her hand up for a while, Jan. You may not be seeing it.
Thank you. You know what? I couldn't see it on the corner, so I appreciate that. Dr. Higginbotham.
I also sent you a direct message, Jane. So
it's not showing up on my chat. So, but in any case, yes. And actually, for the future, if by oversight I am not seeing someone on my screen, feel free to make me aware of it.
Yeah, I did. I sent you a DM.
Yeah, it didn't go through on my thing.
Okay. All right. Just a quick question for the FDA as you reviewed the data. You know, I certainly appreciated your comment regarding the biomechanical strain potential on the eye with these repeated changes in the pressure to which the eye is exposed. I'm still concerned about the age-related issues because in my experience, patients that we may ultimately deem to be in this category of normal tension glaucoma or low tension glaucoma are usually older. And so this is a somewhat younger population on average, and just wanted to get a sense from the FDA in terms of their analysis of the data related to age and the impact.
So Dr. Higginbotham, thank you very much for this very important comment. As we pointed out, the study was started and conducted without our input. However, I want to highlight the importance of health equity in all of our clinical studies, and we have been spending quite a significant amount of time, especially in the last couple of years, to make sure that the inclusion and exclusion criteria parallels the ultimate indication for use. So thank you for that important comment.
Dr. Repka.
So I have 2 questions for FDA. One, the issue of the silicone or whatever the seal is made of is not a subject for this panel, or is it an approved product that can be used in any way? Would be my first. Is there any discussion of that sealing material in terms of contact dermatitis, which was observed rarely here?
I'm going to ask Tuvi to answer that.
Hi, yeah, this is Tuvi Win with FDA. So as you stated, there are, certain types of assessments that are taken as part of the study in the clinical protocol. We also evaluate other non-clinical assessments such as biocompatibility, which was also part of our assessment as well.
Okay, then thanks. Then I'll follow up with my next question, which is In the consideration of labeling, I was thinking about this, and since the pump is portable, that means a patient could decide they want to walk around with it. And I don't know if they can see or whether that actually would be a guidance that you should not walk around with the gadget in play. And I certainly didn't hear the sponsor speak about that, but I'll just bring it up here to FDA staff and maybe come back to it when they're back on.
So perhaps, yeah, you can ask the sponsor, Dr. Repka, but also there is a question about labeling, and perhaps you can bring it up in your recommendations.
Thank you.
One thing I had just asked them briefly if they got up in the middle of the night and walked to the bathroom. They said they could see through the lenses, but I don't know if it would be unsafe to walk around for a prolonged period of time, as you're asking. Dr. Lofspring?
Yeah, I just have a quick question for the FDA, and I brought it up earlier. As a consumer representative, are we just voting on lowering the IOP or the long-term effectiveness of the IOP? Lowering of it.
So first of all, this is a non-voting panel. So we're just getting panel input on the questions that we pose in front of the panel. So what the goal for today is to get comprehensive input from every member of our panel member for the specific questions that we will be discussing in the afternoon.
Okay, thank you.
Dr. Wong?
This is Andrew Huang again. I just want to echo the sentiments by Dr. Higginbotham and Dr. Repka, as well as Dr. Weiss. I think, this is a device, and I think, patient-reported outcome measures is very important, because we need to know, especially this is going to involve some elder populations, so how they, how comfortable they are, how confident they can use it, how safe they can use this. Yeah, so I do think, the patient outcome measures should be included in the evaluation.
So I just wanted to mention that we do have our PRO expert on the line. So if during your discussion you have any specific PRO related questions, we're happy to answer them.
Dr. Parrish?
Yes, I was wondering, as this is neither a drug or a drop, nor is it a surgical device, it doesn't really fit into either one of those. But with respect to safety of drugs and devices, from the FDA's perspective, what would be a reasonable length of time to assure the user that there was not an adverse event? I mean, we have 1-year data here. I anticipate if this comes to commercial use or is accepted, it would be for many years, 5, 10, or as long as the patient is alive. So with respect to drugs and devices, is there some FDA criteria that would be used to demonstrate longer-term safety than 12 months?
Thank you, Dr. Parrish. So first I want to clarify, it is definitely a device, hence de novo, hence the de novo is the appropriate way to evaluate the information. And as far as the duration, that is the key question that we hope you will provide recommendations to us.
Dr. Boudens?
Just a clarification on the indication, the Artemis study focused on what appears to be normal tension glaucoma patients, those with untreated intraocular pressures less than 21 millimeters of mercury. In the indication statement, though, there's some room for interpretation with open-angle glaucoma with intraocular pressures less than or equal to 21 millimeters of mercury. My question is, could that include patients who started as primary open-angle glaucoma patients and were treated to the level maximally with medication and laser, let's say, and were less than 21, but then could benefit from the device?
So Dr. Boudens, thank you for that excellent question. This how specific IFU language is extremely important, and we want to make sure that there's an enormous transparency to the public and the users. So as you are deliberating the IFU, we would appreciate any recommendation that you have for us to consider.
Thank you.
Dr. Glasser?
Thank you, David Glasser. Question for the FDA. Has the FDA required for other devices or drugs to treat glaucoma demonstration of improved outcomes, reduced evidence of progression over time, or have these always been related to a % reduction in IOP? And if there have been examples of devices or drugs where demonstration of reduced progression has been required, could you give an example?
So thank you, Dr. Glasser. So unfortunately, drugs and devices have different regulations and not necessarily always consistent as far as evaluation endpoints. We do have a leapfrog MIGS guidance, and we also have a recognized standard for implantable glaucoma devices. And I would say those are the two public consensus documents that are currently available for the glaucoma devices.
Do they include demonstration of reduced progression, or do they address reduction of IOP?
I'm going to ask Carol to jump in, but to my knowledge, we usually ask for IOP as an endpoint. We also evaluate visual fields. Carol, is there anything you wanted to add?
This is Carolyn. I don't. I am not aware of an approved or clear device showing reduced progression of glaucoma.
Thank you.
Hi, this is 2B1 with FDA. I just wanted to add to that, FDA evaluates a device for the indications for use. So if a company were to come in and within their indication was to reduce intraocular pressure, that is what we would look at. Now, when we look at the benefit risk of any device, we need to consider it for de novos and for PMAs for its intended use and the novelty of the device itself. So the types of assessments that you may need for one device may not always apply to another. I think we have to see it within the context of the device and the technological aspects.
Are there particular concerns with the different physiology here? I mean, I've heard some speculation about effect on the lamina corrosa, but I'm not aware of any either theoretical or mechanistic or clinical evidence that is an actual concern. Can you point to any evidence that is something that we should be concerned about?
So I believe we presented the data as objectively as we can. And at this point, we're looking for panel's recommendations on your assessment of the impact.
Thank you.
So Melvina, sort of as a follow-up to that in labeling, the panel could say for labeling, we could include that information about long-term effects on the choroid, the retina, the optic nerve, the cornea are not known.
Definitely. You can definitely recommend that.
I don't see any other raised hands, although we know that I'm not very good at that at this point. So does anyone have any, does the FDA want to add anything, or do any of the panelists want to ask anything? I guess I'm going to go back to the FDA. Is the critical...
I believe Barbara has...
see, thank you. Consistent, 2 for 2. I may need to be tested. I may need to be getting a visual field after this panel meeting and just check myself out. Barbara, please.
Barbara Burney, patient representative. Very recently, I've had a number of engagements with PROs, and I just want to concur with Dr. Huang. It is extremely important to have feedback from the patients that you're treating as to how comfortable, how wearable this would be, how useful it would be if you do have to get up. Some of us have to get up all night long to go to the bathroom. And those are considerations, you know, if it were me, I wouldn't use something like this because I'd be afraid that I would do something to myself or to the device, whatever, without knowing more about that. So I concur. I think there needs to be, well, for any device actually, but this one too, some sort of patient-reported outcome device, something that will measure that. That's all.
Melvina, are we allowed in this such a device to say we want post-market studies to
Yes.
Ask for this?
Yes, and I'm going to ask Toby to give you a little more about it.
Okay.
Hi, yes, 2V1 here with the FDA. Yes, for de novo submissions, you know, if we are to grant a de novo, we do create what we call special controls in addition to general controls that all devices have to meet. And as part of the special controls, we can include the need for post-market evaluation. So the reasons for post-market surveillance as a special control could be, for example, that you believe that longer-term follow-up or evaluation of rare or late-breaking events could occur. There may be more uncertainty of the clinical data for devices. For example, those for home use may present a lot more uncertainty than those that are used by physicians only. So once we, if we do include that as a special control for a de novo, what that would mean is any device that would subsequently be approved or cleared in this regulation would require that same post-market data surveillance.
Dr. Scooter.
Yeah, Jane, there were some quality of life parameters for the Apollo study, correct? And was there anything that was seen as out of the ordinary there? Again, it's only 3 months versus a year. I get that, but just remind us if there was anything that was out of the ordinary in that regard.
Fraser, can I ask you to come on camera, please, and introduce yourself?
Hi, yes, my name is Fraser Bosell. I'm a psychometrician and PRO reviewer with the Division of Patient-Centered Development at FDA. And in general, so the symptoms and health problems checklist covers local eye symptoms and visual function. And in general, I would concur with what the sponsor said earlier. There weren't significant differences between the treatment eye and the control eye in terms of localized symptoms. And there was some indications of worsening and improving in the visual function, but overall, there wasn't much change. We do have a backup slide on this that has the
Yes, can we please bring up that slide?
That shows the content of.
Can we have our backup slide number 8, please?
We'll bring up the slide. We just need to know the number you want.
Okay, number 8 backup slide, please.
Yeah, and so there you can see the content of the SHPC 18. I will note that this is from the SIGIT study, and as y'all are probably aware, the SIGIT study was done before MIGS devices were on the market, and so this content is from the 90s, and so it's prior to that.
Dr. Higginbotham?
I think we can bring the slide down. Thank you.
Yeah, thank you. I'm Dr. Higginbotham. There was a significant number of patients that exited early, 33%, which is pretty high. And do we know whether or not any of those patients exited after they tried the device, perhaps in the office and didn't like it? Or I know there was a consent question. There was some issue related to inclusion-exclusion criteria. I just was interested in that, the makeup of that 33% that decided not to go forward.
Carol, are you ready to answer this now? I know our slide mentioned that it was due to adherence, but I'm not sure if you're ready to give additional information at this time.
I can get back to you on a more granular breakdown of that after lunch. But just in general, those 33 subjects who dropped out, they were all randomized, meaning they had used a device.
And it was 33%, right? It wasn't 33 individuals. I think it was a higher number, if I recall.
It was 31 out of 93, as I recall.
Okay, I apologize, I misspoke.
Elijah, right?
It was 60 out of okay.
No, go on, Meldina, and yeah.
I believe it was 60 out of 164, but we can verify after lunch.
Yes, Madam Chair, Elijah Ray for industry representative. The issue of post-market studies that came up from the panel members, I think that's something we can discuss later on this afternoon. But I think the sponsor would like to get some recommendation from our fellow panel members as we discuss this issue this afternoon as well. Just want to point it out to the panel members. Thank you.
For FDA, it seemed to me that the more negative pressure, the more symptoms. Is that correct? The higher, the more likely the patient might not be able to tolerate it?
So I don't believe there was a direct correlation, but I'm gonna ask Carol to respond. Was a direct to your knowledge, was a direct correlation assessed?
No, but we do have some case narratives of individuals who experience adverse events, and in those narratives, how the negative pressure settings were adjusted were described. And I can provide more details about those after lunch, if interested.
We can, and Dr. Weiss, if you're interested, you can also ask the sponsor for to answer that question as well.
And as a follow-up with that, eyelid edema seemed to be a prominent effect as far as the AEs go. I assume if an individual got eyelid edema, they would continue getting eyelid edema. It wouldn't, that person, if they got it on one treatment, they'd get it on the other treatment, they'd get it for the entire year. So I wonder how many of these people ended up getting, or with long-term use, would some of these people get levator dehiscences or other damage to the lid? And I guess we don't know, but do we know if the eyelid edema in an individual would be consistent or would be a one-time thing, or we don't know?
Carol, is this something you want to answer after lunch, or are you ready to answer that now?
Based on the information that was provided to us, it appears that the lid edema persists while the device is being used and resolves after discontinuation of device use.
And I think we had 12 cases in 11 eyes, but 12 reports in 11 eyes.
But since the person was doing this on a nightly basis or 5 nights a week or whatever, am I correct in assuming if you're subject or more vulnerable to getting eyelid edema, this is not something that would have been reported on 2 occasions, but this is something that you would expect to get every single time you put this thing on? Or we don't know?
I would recommend, Dr. Weiss, I would recommend that you ask this from the sponsor, because I think there is some ambiguity on our end as far as when the discontinuation occurred after lid edema and the frequency of reporting on the same patient.
Dr. Schumann?
For the FDA, just as a comparator, I wonder if we can get a sense of the dropouts and non-adherence in the CPAP studies that led to approval.
So I can get to you that after lunch.
Great, thanks, Melvin.
The exact ones, but in general, we tend to. Well, I'll get back to his exact answer.
Okay, thank you.
Dr. Scooter?
Yes, so I'm just looking at the schedule for the rest of the day. when do we have a chance again to ask the sponsor questions? Is that during the public hearing?
I think that's 2:45, right? Panel deliberations.
Yeah, but I just wanted to clarify that after lunch, the chair, it's at the chair's discretion. If you call the sponsor back, I know they're listening. So if you say, if you phrase what you would like for them to address, it is at the chair's discretion if she wants to use that time to hear from the sponsors on your answers before you begin deliberations.
Okay, so after open public hearing.
After open public hearing, but before deliberation.
Okay, sure. Joel, did you have another? No, okay. Anyone? I don't see any hands raised. Melvina, since we have a little bit of time before lunch, would it be okay to get the sponsors' input now if they wanted to answer something?
I don't believe so.
No, okay. So you'd rather we would break for lunch a bit early?
Yes, because we need to make sure that we adhere to the timing of the open public hearing.
Okay. So seeing no other questions, I would like to thank the FDA speakers for their presentation. And we are going to now break for lunch. Panel members, do not discuss the meeting topic during lunch amongst yourselves or with any member of the audience, and we will reconvene at 1:45 p.m. Thank you. It is now 1:45 p.m. and I would like to resume this panel meeting. We will proceed with the open public hearing portion of the meeting. Public attendees are given an opportunity to address the panel to present data, information, or views relevant to the meeting agenda. Ekanole Awajopi will read the open public hearing disclosure process statement.
I will now read the OPA statement. Both the Food and Drug Administration, FDA, and the public believe in the transparent process for information gathering and decision making. To ensure such transparency at the open public hearing section of the advisory committee meeting, FDA believe that it is important to understand the context of an individual presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement, to advise the committee of any financial relationship that you may have with any company or group that may be affected by the topic of this meeting. For example, this financial information may include a company's or group's payment of your travel, lodging, or other expenses in connection with your attendance at the meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationship. If you choose not to address these issues of the financial relationships at the beginning of your statement, it will not preclude you from speaking. Thank you very much. I'll hand it over back to Dr. Wise.
Thank you, Dr. Awajopi. FDA has received 7 requests to speak prior to the final date published in the Federal Register. Speaker number 1, your audio is now connected. The first speaker is Michael Chaglassian, MD, and you may begin.
Hi, my name is Dr. Michael Chaglassian. I'm an optometrist and associate professor of optometry at the Illinois College of Optometry and the Illinois Eye Institute, where I see patients who have glaucoma. I'm pleased to share my experiences with the goggles for you here today. My experience with them goes back several years via my participation in 4 of the clinical trials that were led by the company to identify the safety and efficacy of the device. In these studies, I enrolled approximately 35 or a little bit more patients who had glaucoma and various different types of glaucoma to determine how well the goggles and device was working for them. Devices like this, I think, are really valuable for the patient population within glaucoma. Glaucoma can be a very challenging disease, and sometimes our treatments with medications and surgeries are not always so amenable to all of our patients. In my practice at the Illinois Eye Institute, I work alongside glaucoma surgeons and academic clinicians all the time, and my patient base is often looking for answers to their glaucoma disease that are not present in the current modalities of treatments that we offer currently. So the goggles studies offered them an opportunity to experience a safe device, in my opinion, and from the studies and results that I've seen, a safe device that was able to further treat their disease without surgical intervention nor with the addition of additional medications. We know that glaucoma is primarily an eye pressure disease, but not always alleviated by just lowering the eye pressure. And so a device like the goggles that works throughout the eye and helps to lower the pressure in the back of the eye is really a great option for many of my patients. Any of the adverse events that I saw with the goggles were very temporary and mostly just cosmetic, and they went away after the subject stopped wearing the goggles device. So it offers this additional treatment at a vulnerable time for our glaucoma patients, which is the nocturnal sleeping time period where their eye pressure is often highest, and many of our medications and procedures don't work well in this time period. So the patients who are facing further advancement of their disease and risk of further vision loss really welcome the device. And after a little bit of training and accommodation to the goggles device, the vast majority of them did quite well. So I think that the goggles can be an important adjunctive treatment option for many of our patients with glaucoma. I think it's a safe and well-tolerated device, and I think that it will do well for our patients overall. Thank you for your time today.
My name is Mitch Hill. I'm a 64-year-old married father of 5 living in Newport Beach, California. Professionally, I'm the CFO of a public medical device company named Inari Medical. My glaucoma journey is honestly a bit of a science experiment for vision problems. I believe most of my vision challenges are hereditary in nature. My father was a bomber pilot with excellent vision during World War II. His vision began to deteriorate in his 40s with early onset cataracts and later in life with glaucoma and macular degeneration. When he died at the age of 93, he was blind in one eye. In 2009, at the age of 50, I noticed my vision was becoming obstructed. I was diagnosed with early onset cataracts. I had my cataracts removed from both eyes on the same day. My natural lenses were replaced with monofocal lenses. One eye was corrected to have better distance vision, and the other eye was corrected to have better reading vision. I then sailed along until sometime in 2016, at which time I noticed a decline in my peripheral vision. I was diagnosed with low-tension glaucoma at Harvard Eye in Laguna Hills, California. Being a low-tension glaucoma patient is a very disconcerting experience. For example, at a typical Harvard Eye appointment, I would have my intraocular eye pressure checked upon arrival. My pressure was typically in the 11 to 13 range for each eye. I would then take my drops, wait a bit, and have my pressure taken again. Guess what? It was still 11 to 13. Despite my frequent eye care and religious adherence to drops, during the 2016 through 2023 timeframe, my peripheral vision in both eyes continued to deteriorate. I also lost the center vision in my left eye. If I could only rely on my left eye, I would no longer be able to drive. During my search for information and other glaucoma resources, I have spoken with Dr. Jay Katz, who's the Chief Medical Officer of Glaukos, Dr. John Berdahl, founder of Balance Ophthalmics and physician with Vance Thompson Vision, and various professionals from the Glaucoma Research Foundation. I have tried to learn and study any information about low-tension glaucoma that I can find. In mid-2023, I decided to switch my glaucoma care to Dr. Elena Resnick of the Glaucoma Care Center in Newport Beach, California. Dr. Resnick helped me think about my glaucoma care with a holistic approach to my health, which I appreciate. With the assistance of Dr. Resnick, I've switched my eye drops to Simbrinza 2 times a day and Lantanoprost at night. My intraocular pressure is often less than 10 when I visit her every 30 to 45 days, and she believes the deterioration in my vision is no longer progressing. I share this information with my fingers crossed. Low-tension patients are, to use an unfortunate word, a bit desperate to find ways of keeping intraocular eye pressure in the mid to high single digits. It's very difficult to achieve this type of eye pressure with eye drops alone. And some patients like me aren't good candidates for surgery. As Dr. Resnick tells me, you have one good eye, so I'm very reluctant to perform surgery on that eye should there be any kind of unexpected outcome. Like many physicians and patients in the glaucoma world, I'm hoping for stem cell therapy to regenerate optic nerves at some point in time. Until or unless that happens, people like me face an uncertain future. I'm hoping to preserve my ability to work and to drive. Many of the hobbies I enjoyed in the past, such as yoga, golf, and pickleball, are not recommended or are difficult to enjoy. I'm also rethinking the kinds of things I will be doing in my future retirement years. On behalf of myself and many other low-tension patients like me, I would appreciate your approval of the Balance Ophthalmics goggles. I believe the goggles would allow for a lowering and control of intraocular pressure during sleeping hours. Thank you for your consideration and for your time.
Hello, this is Nathan Radcliffe. I'm an associate clinical professor at Mount Sinai School of Medicine. I'm a cataract and glaucoma surgeon and specialist in New York City, and I practice in Queens and the Bronx, serving mostly patients with Medicaid. I'm enthusiastic about the potential availability of the Balance ocular pressure adjusting pump or goggles because I feel they could play an important adjunctive role, particularly with lowering intraocular pressure at night in glaucoma patients. Glaucoma patients need multifaceted approaches for their therapy. Currently, we will maybe combine a variety of treatments for our patients. Sometimes that will be a laser plus drops. Sometimes that will be several drops. And I think that because of its ability to lower pressure at night, where many drops cannot lower the pressure at night, the goggles could fill a valuable need for patients when it comes to patients who need a little bit more than just one therapy. We do know that when you start piling on eye drops, that the side effects and maybe perhaps toxicity, such as things like the preservatives, can be a little bit more on the exponential side. We know compliance becomes more difficult with the second drop in a nonlinear but rather more exponential way. And I think that just putting the goggles on at night for a patient to get a little bit of extra nocturnal pressure control could be a meaningful and very helpful, but also approachable and tolerable therapy for that patient. Perhaps if we can get better control earlier in the disease, we would be less likely to have to move on to the therapies that my patients really dread, which are some of the bigger laser therapies and some of the surgical therapies. And I see a lot of patients really trying to avoid those surgeries, but often not having perfect control while they're pushing off surgery and often getting worse. And I think that, adding this therapy earlier on in the paradigm to help patients avoid these higher morbidity surgeries could be very valuable. I have a number of patients where I'm not fully comfortable with their control. And currently, all I've got left to offer them, maybe they're on many eye drops, maybe they've had laser, is a surgery, and they're saying, no, I'll take my chances. I feel more comfortable if I could say, well, let me just do a little bit more for your pressure at night with the Balance goggles. For those patients, we're taking an extra step, but it's not a step that would scare the patient, make the patient fear of sudden vision loss. I think that, there's a legitimate fear that our patients have about going blind from glaucoma surgeries. Every surgeon has seen it happen. And the goggles offer a way to have some meaningful pressure reduction with an excellent safety profile where neither the doctor nor the patient need to be concerned about those very serious risks. I also think that the goggles would be convenient and practical for patients, whereas taking time off from work to have lasers performed or medical clearance procedures for surgical and then surgical recovery and multiple post-operative surgical visits, I really see a lot of patients losing vision because they just can't do that in their life. And here with the goggles, this is something patients could adopt rather quickly. And would actually work into their life in a more practical way than some of these more, involved procedures. Ultimately, we want patients to have a normal quality of life as possible, not to have to leave their families and not to have to take a lot of time at work, but just to get that better intraocular pressure control. So I think that, this is a nice therapy that has a wonderful safety profile that addresses an unmet need, which is lowering intraocular pressure at night. We know many of our therapies don't do that. And we also know patients are reluctant to try some of our other therapies. And that's why I think this one makes sense. Thank you so much for listening to me speak today.
Hello, my name is Manjul Shah. I'm an associate professor of ophthalmology and the head of the glaucoma fellowship program here in New York at NYU Langone Health. I've been in practice for about 8 years. I've been taking care of tertiary care glaucoma patients, the ones that are really in trouble, that really need a helping hand, the ones for whom our standard therapies may not be working. And I see a real need for us to think outside the box and find novel synergistic ways to control this tough disease. One of the challenges we face is that intraocular pressure increases at night in a lot of our glaucoma patients, even those with normal daytime pressures, and that nocturnal elevation can indeed be contributory to their vision loss. A lot of our conventional therapies don't have as much of an effect on those nocturnal pressures, and there are numerous pharmacology studies that demonstrate inadequate diurnal control. Even if the pressures can be controlled during the day, they often don't quite work at night. In fact, some of our therapies may actually make things worse by dropping blood flow and ocular perfusion at night. And so we may actually be putting the optic nerve at harm by ratcheting up some of our conventional therapies. Additionally, more studies than ever have demonstrated the value of not only good pressure control in terms of a numerical value, but consistency over time. In a recent study looking at a microstent compared to a control, there was a 50% reduction in field progression, but only 17% of that was explained by the pressure reduction from that stent. In fact, the thought is what's happening is we're dampening the pressure fluctuations. And numerous studies across disease types and severity of glaucoma have demonstrated the value add of more consistent control over 24 hours. And our conventional therapies may not quite do that. The goggles may indeed be a way for us to manually set that pressure and keep those fluctuations at bay, which may indeed prevent visual field progression. Normal tension glaucoma is a difficult disease to treat because our conventional therapies don't get pressure low enough. Hydrostatic forces just impede how low our conventional therapies can go. Multiple studies, however, demonstrated that getting those good low pressures is the way to control and treat these types of glaucomas. May represent over 30% of the population of glaucoma that we treat. But surgeries like trabeculectomy that have consistently been used to achieve those pressures carry significant short and long-term risks when trying to get that low. Applying non-invasive therapy to the eye offers the ability to use multiple minimally invasive procedures to synergistically get at what we really need, those low pressures and consistent numbers over time. And since the eye remains a closed system when using the goggles, we actually add a modicum of safety while being able to achieve the therapeutic endpoint. Lastly, the ability to have an adjunctive treatment beyond what we have conventionally is just an exciting prospect. We have drugs, we have laser, and we have surgery, and I love doing all of the above, and they work, but they don't work all of the time. Every day in my practice and every day in the operating room, I see patients for whom our standard triple threat of therapy here is just not enough. And patients want to take ownership of their disease when they know that they're losing vision. They've often seen family members and friends suffer from it as well. And I see that every day. And so being able to offer something that is safe, that is effective, that is able to control pressure in a way that's novel and synergistic to what we already have is really an exciting prospect. I thank you so much for your time and consideration.
Hello, I'm Dr. Robert Kirsten. I'm a professor of ophthalmology at the Moran Eye Center at the University of Utah. And I appreciate you taking the time to hear my thoughts on the device that's being considered to allow me to try and further lower my pressure, at least lower the pressure differential at night with my glaucoma. I've had glaucoma now for about 15 years' time. I have gone through multiple different laser procedures, surgical procedures, just about every drop known to mankind. I'm currently on 3 drops in each eye, one of them twice a day, the other 2 once a day. And I also have purchased a home pressure monitoring device, so I watch my pressures closely. And the problem I've run into is I have quite low pressures during the day. And in fact, if I get them any lower, I've had a couple of episodes where I get blood that reflexes back into my eye from the aqueous veins because the pressure in my eye gets lower than aqueous venous pressure. On the other hand, when I set my alarm and I wake myself up at between 2 and 3 in the morning, my pressures in my eye sitting upright are elevated. Elevated, all relatively speaking. I have normal tension glaucoma. I'm trying to keep my pressures in the range of 8 to 9 millimeters during the day. At night, they oftentimes get up to 14 or 15. In addition, I check my blood pressure. I'm on a antihypertensive, and my blood pressure is its lowest at night when my intraocular pressure is at its highest. So I've had progression of my visual field defect in my left eye to within 10 degrees of fixation. I don't have good peripheral vision for driving, have had to change my car so I can get a car that has side monitors, etc. And not a good candidate for additional surgery because I've had bilateral retinal detachments, have had vitrectomies and bilateral cataract surgery. So my conjunctiva is not very amenable to trying to do filtering surgery of any sort. So the device that you all are considering is something that seems particularly appealing to me. It's non-invasive. It's something I can purchase and I can wear at night. And if it improves my nocturnal differential between my intraocular pressure and my blood pressure, it may well preserve my vision. So I find it appealing to me. I don't really see any downside to it. And it's something that I would very much like to be able to access for my own situation. I appreciate you taking the time to listen to me here today.
Hello, my name is Wallace Allward. I am an emeritus professor of ophthalmology at the University of Iowa. I ran the glaucoma service at the University of Iowa for 33 years, from 1987 until 2020. I have a very strong interest in glaucoma, particularly normal tension glaucoma. And so I'm going to talk a little bit about the reasons that I think this technology is interesting to me. And let me just share my talk with you here. So my interest in this technology comes from my conviction that glaucoma damage to the optic nerve occurs during sleep, or a lot of it occurs during sleep. In 1993, our group published a study comparing patients with normal tension glaucoma who were well controlled, doing great. The pressures were normal, and they were stable. And we compared those to people whose pressures were excellent, but they continued to get worse. And what we found is people who continued to get worse often had a very profound drop in blood pressure during sleep. And this is a graph from that paper, just showing that both in normotensive and hypertensive patients, the blood pressure drops during sleep. And this can be quite profound in people who have progressing normal tension glaucoma. So this paper has been cited over 600 times. It's been replicated around the world and is a well-established part of our understanding of glaucoma. In my practice, if I saw somebody who was really well controlled and they were getting worse despite excellent pressures, I would often do a 24-hour blood pressure monitoring on them to make sure that they weren't having these big dips in blood pressure at night. A study by Dr. Weinreb's group at the University of California, San Diego showed basically showed that your eye pressure goes up during sleep. Up until then, I don't think we really knew. We just sort of assumed it was the same or went down during sleep. But Dr. Weinreb's group showed that clearly in patients with glaucoma and in normal patients, the eye pressure elevates during sleep. And if we put these two graphs on top of each other and align the sleep hours, we see that it's sort of a perfect storm for the optic nerve. Blood pressure is going down while the eye pressure is going up, so the perfusion pressure to the optic nerve is embarrassed, and this, I think, causes some part of glaucoma damage. Anecdotally, I've seen this in patients who have glaucoma that's progressing, say, at a pressure of 13 or 14 millimeters of mercury, and we do a trabeculectomy, a surgery to bypass the normal drainage system. And then years later, their pressures may be back at 13 or 14, but they're completely stable. And I think it's because we've eliminated this nighttime bump in intraocular pressure. So my interest in these goggles is they only really work when you're asleep for these 8 hours or so that people are asleep. But those 8 hours, I think, are critical in a lot of patients with glaucoma. And so to me, it's an interesting and exciting sort of a technology. Thank you for letting me weigh in on this topic.
Hello, my name's Hillary Golden, and I am a severe normal tension glaucoma patient. I have been in medical sales for over 20 years and am now have a venture called Glaucoma Coach, where I help patients and how to advocate for patients. I went in to see an OD in July of 2020 about a sty. And when the OD looked at my eye, she said, "I don't like the look of your nerve." And I said, "Well, I don't know if you know why I'm here, but I'm actually here about a sty." And she said, "Well, you might be here about a sty, but I'm more concerned about your nerve." At the time, I knew nothing about glaucoma. And I knew nothing about normal tension glaucoma. She said I needed to see a glaucoma specialist immediately. 2 days later, I was at the office of a glaucoma specialist where she confirmed that I did in fact have glaucoma. Normal tension glaucoma is currently treated the same way as high pressure glaucoma. The normal tension glaucoma studies show that there needed to be a 30% reduction in eye pressure to be neuroprotective. So we need our pressure to be even lower than a high pressure glaucoma patient. The impact as a normal tension glaucoma patient is we can do everything right. We can do our treatments, but we can still progress despite our treatment. You never know when your eyes are going to progress. The treatment for normal tension glaucoma is first usually drops, which have a myriad of side effects. Red eyes, irritated eyes, dizziness, tiredness, and the list goes on. There's also some other treatments and procedures, SLT, and surgical options. Bold ideas come from thinking outside the box. Dr. Bradal did just that in creating the goggles to help treat normal tension glaucoma. It's not a fix for normal tension glaucoma. It's an adjunct to the therapy you're already doing. I flew, at the time I was living in Denver, and I flew from Denver to see Dr. Bradal because I'd heard of his goggles. And I was hoping that it could be an option for me. Glaucoma affects each of us differently, and we all have our own battles to fight. Just as I'm sure each of you is fighting a battle that no one else knows anything about. I want you right now to think about what you're fighting, to close your eyes, and in that darkness, when you close your eyes, imagine a light. I want you to imagine that that light is hope. That light is the hope that can help you fight the battle you're fighting. Would you want access to that treatment? Would you want to have hope? Give that hope to normal tension glaucoma patients by approving the goggles for treatment for glaucoma patients. Give us a tool to control a disease that is not controllable. I used to think that going blind was an all or nothing. You either had sight or you were blind. Now I know that there's a lot of gray area in there. When you lose your vision, when you lose your sight, you lose pieces. Those pieces get bigger and bigger as you progress. Please help me save those pieces of sight that I have left. Please give me another tool to help fight the silent thief of sight, glaucoma. Thank you.
I now pronounce the open public hearing to be officially closed. We will now proceed with today's agenda, which will be the FDA panel deliberations. Although this portion is open to public observers, public attendees may not participate except at the specific request of the panel chair. Additionally, we request that all persons who are asked to speak identify themselves each time. I ask that each person remain muted until acknowledged by the chairperson. This helps the transcriptionist identify the speakers. During the next hour and 30 minutes, we will open up the floor to questions for both the sponsor and the FDA. And we'll start with the FDA and then the sponsor in terms of responding to the panel's questions that were posed this morning. So could I first call on the FDA as to answers that they have from this morning's questions?
Yes, Dr. Weiss, thank you very much. Can you hear me? I was just having some AV issues.
Yeah, we're good.
Okay, great. So let me first start out by answering a question somebody asked about the CPAP. So as far as the CPAP, for the FDA studies, we currently require just a 1 month clinical assessment. And in those studies, we see high 90s as far as adherence with wear. The most common reasons for dropout tend to be physical discomfort, anxiety, claustrophobia, psychological factors, and patient's age. However, my SMEs tell me that if you look at the literature for CPAP adherence, at about 1 year, it tends to be 50 to 60%. So that concludes information on the CPAP, and now I would like to ask Dr. Lin to take on the next question.
Regarding the question about the participants who dropped out early in the Artemis study, there were 31 randomized subjects who did not complete both the final sleep lab and the week 52 in-office visit. Therefore, a total of 62 subjects completed the study. 20 discontinued early by withdrawing consent. And there were several others who had various other reasons for dropping out, such as COVID or having an unrelated cancer diagnosis. 5 did have adverse events, and 5 were non-compliant with the device use. 25 of the 31 exited the study prior to week 26.
Does that conclude the questions that were left from this morning for
No.
FDA? Yes,
no,
it does not. Okay, thank you.
Go ahead, Carol.
So regarding the question about the temporal relationship of adverse event occurrence by the negative pressure application, specific information about adverse events stratified by MP application was not provided. The sponsor provided us information that's quoted here. The evaluation of temporal relationships between onset of device-related AEs and MP settings is complicated by the fact that many of the periorbital or lid edema and periorbital or eye pain events were patient-reported, transient, and intermittent, with no evidence of the event present during ophthalmic examination at the subject's clinic visit. Also, subjects were not always precise about onset, frequency, or duration of these events. We did receive information that 13 subjects had onset of periorbital or lid edema or periorbital or eye pain reported with the day 0 in clinic negative pressure setting. 11 additional subjects reported onset of these types of AEs after a subsequent MP adjustment based on a higher sleep lab supine mean IOP than previously referenced. The periorbital or lid edema and periorbital or eye pain AEs were reported with MP settings ranging from -6 to -19 millimeters of mercury. There was no difference in the number of subjects who received a downward adjustment in negative pressure in response to the AEs versus those who continued with the setting as programmed. 6 subjects who experienced these AEs withdrew from the study. I just want to add that we have case narratives from 39 participants who had adverse events reported. And case narratives are very difficult to summarize, but based on our preliminary review, there are participants who had AEs with increase in the MP adjustment, and there were also AEs reported when that did not happen. The temporal relationship is indeed unclear.
Hi, this is 2V1 with the FDA. And just related to what Dr. Lin just discussed, I also just wanted to remind the panelists of what Dr. Lin had presented earlier today for the confirmed study, which showed that IOP lowering based on the negative pressure application dose did vary between 35 to 78% at an applied pressure of negative 10 millimeters of mercury. And it varied between 22.5 and 53.5% when the applied pressure dose was negative 20 millimeters of mercury. And as just a last, you can go to the next slide. Just the last clarification we wanted to give, because it was based on some of the questions from the panelists this morning, was that when a device is granted through the de novo pathway, FDA will create a brand new regulation that encompasses all future devices that have the same shared intended use and technology as the subject device. So as part of creating the regulation, FDA would identify special controls that must be provided for any future device that would fit within this new regulation. And that could include specific bench testing, clinical testing, labeling, and as we previously discussed earlier today, post-market studies. And those are all the clarifications we have here at FDA. Thank you, Dr. Weiss.
I believe that concludes all of the outstanding questions.
And just for the panelists, after the sponsor answers the outstanding questions, then I will go around and ask each of you any questions that you have remaining for either sponsor or FDA. Everyone will get a chance to pose those questions. Can we have the sponsor turn on their, thank you. And you'll answer the remaining questions from this morning, please.
Yes, we will. Thank you again. So we have some additional data, I think, that will help the panelists on have some additional granularity to the questions that were asked. First, I'll ask Ross Ethier to come up, talk about pressure definitions and biomechanical strain. Dr. Samuelson will talk about lid edema and severity of AEs. Then I'll come back and answer some of the questions regarding cornea, and we can also answer that question about additional AEs in high amounts of negative pressure with more granularity. So with that, Dr. Ethier, please.
Hi, Ross Ethier. Yes, I'd like to offer just a few comments to the panel members related to pressure and the biomechanics of what's going on in the eye during the OPAP wear. And I think all of the panel members understand that pressure is always defined relative to some reference standard. In medicine, that's atmospheric pressure. And we've seen the confirmed data, and I'll just bring that slide back up again. And we actually just saw it in also in some of the FDA clarifications. And just to remind you, this is direct manometry right into the eye, which is absolutely the gold standard. And it is showing, in my mind, in my professional opinion, unequivocally that we have a lowering of intraocular pressure that's occurring during the OPAP wear. So the question perhaps is not, does OPAP lower intraocular pressure? The bigger question is, all right, well, we have this extra thing happening, which is there's also the intragoggle pressure, and what are the implications of that? And as was pointed out by some of the panel members this morning, you might expect that there would be some effects on the cornea. And in fact, in our modeling, we specifically looked at that. And there is a small amount of stretching or deformation of the cornea. But to put that into context, it's equivalent to an intraocular pressure rise of approximately 4 millimeters of mercury. And I'm not aware of any clinical effects, and the literature doesn't support clinical effects on the cornea due to those magnitudes of pressure rise. Perhaps most germane to the discussion today about glaucoma is what's happening at the back of the eye, what's happening in the posterior pole. And I showed you previously this slide this morning, but just to reinforce, we're lowering the blue zone pressure, the intraocular pressure. The retrobulbar pressure is constant, and also we have good reason to believe that the retrolaminar tissue pressure is constant. So the net out of that is that we're actually decreasing the transmural and the translaminar pressure difference across the back of the eye. And just from basic physics, that is going to reduce that harmful biomechanical strain, which is acting on those soft tissues in the optic nerve head. There was also a question raised about intraocular pressure fluctuations, and we've heard quite a lot about that today. And I just would reemphasize that we know that many glaucoma patients have intraocular pressure rises at night, and wearing the OPAP goggles at night will actually dampen those IOP rises. So it's actually not just lowering the average pressure during the day, but it's also lowering those diurnal variations in pressure, which from what we know would be predicted to be beneficial. So just to try to summarize there, are we lowering intraocular pressure? Absolutely and unequivocally. There's very modest effects on the cornea, do not believe to be clinically impactful. And I believe we are sparing those fragile tissues at the optic nerve head. Thank you.
Thank you, Tom Samuelson, Minneapolis. I just want to address the discussion about lid edema and what that was like for patients. And you can see on the slide that the vast majority of the lid edema was mild, a little bit moderate. It was likened to dependent lid edema. When people sleep on their side, they often get a little swelling on that side. We rarely saw it in clinic because it was gone by the time the patients came into clinic. We don't have any pictures of it because it was basically patient reported during early morning hours when they discontinued goggle wear. And as we consider the implications of the lid edema and the cosmetic effects that might have for an hour or two in the morning, we have to keep in mind that what we're doing here is we're using the goggles as adjunctive therapy. So if our adjunctive therapy on top of what we're already doing, causes that, then what's the alternative? Well, the alternative is much more invasive interventions. Trabeculectomy, other forms of glaucoma surgery. And when someone has a surgery, that's not reversible. If someone has LASIK, that's not reversible. If someone has cataract surgery, that's not reversible. Or any of these glaucoma operations are not reversible. These patients can stop goggle wear anytime they want. It's absolutely reversible. All these AEs resolved without sequelae. So that was one important thing. The other thing I wanted to just address briefly was the discontinuation rate, because we discussed that. And I wanted to point out that our discontinuation rate, you can see this is from the Apollo trial, our discontinuation rate in the Apollo trial, now admittedly only 3 months, was actually right in line and significantly better than many of the drug studies that are performed. In fact, I've often likened this treatment to what we do with Notarsadil. In my experience, about half the people I put on Notarsadil self-select and stop it. But the half that use it, it's vitally important. Notarsadil's been a great addition for our patients with bad glaucoma. But they self-select. Not everybody wants to take it because it causes redness. And as you can see here, Notarsadil and Rocklatan, which has Notarsadil in it, had a higher discontinuation at 3 months than we did in the Apollo trial. So these patients will self-select. It's not for everybody, but for those patients that know they're in trouble, they will welcome it with open arms. Thank you.
Thank you. And then to address the questions about dry eye, one of the things to note there is that, and again, I don't want to overstate this, but the goggles themselves could perhaps act as a moisture chamber. So when you look at the SHPC 18 study, there was a decrease in patients that were complaining about irritation and red eyes. In the irritation group, it decreased to 6.9% from 15.6% at the beginning of the study. And in the control eye, it went down from 15.6% down to 8.5%, about the same, so roughly cut in half. And it was in both the control eye and the negative pressure eye. So our thought is perhaps it could act as a conclusion trial, as a moisture chamber. But if you look at the Artemis study, and similar results were found in the Apollo study, if you look at those patients that had any SPK, looking at dryness, you find that the proportion of eyes that had 1+ SPK or more decreased from 16% to 10% in the study eye and 16% to 11% in the control eye. Similar findings from the Apollo study. For conj hyperemia, which oftentimes is a measurement of dryness, we also saw some improvement both in the Artemis study and in the Apollo study, going from patients that had 22% in both the study and control eye down to about 13% in both the study and control eye. I also wanted to point out that that patient that had bilateral guttata at week 52, that was present in both the study eye and the control eye. So both eyes had were guttata that was reported at week 52 that wasn't reported at the beginning of the study. And then there was a question on corneal thickness. Corneal thickness was measured as part of the baseline characteristics of starting the Artemis trial, but it was not measured at the end. However, we did do some anterior segment OCT work, and I'll show that to you here. This was with the Anterion OCT and performed down at UCSD. And what you'll see is that we were able to image the corneal thickness with the goggles on and with negative pressure. And there was basically no difference from 511.5 to 510.9 during negative pressure with 20 millimeters of mercury of vacuum. The axial length didn't change, and nor did the anterior chamber depth. As far as Dr. Higginbotham's excellent question about age, I'll put up this slide first. This is all of the patients in the study stratified by age. And you can see that there's a good proportion of patients that were over age 65, and you can see the treatment effect was robust as it would, because this included all of the patients from the study. But when you look and stratify, these patients by age that were greater than age 65, there were 40 patients over age 65 that were randomized. 15 of those did not complete the study. So a little bit more than the 1/3 that we saw as a dropout rate for the study as a whole. So 15 out of 45 compared to 1/3 in the study as a whole. 15 of those remaining 25 had device-related AEs, so a little bit higher than the rate that was found in the study as a whole. And lid edema, not surprisingly, was the most common of those. And again, almost all of the AEs in the study were mild, with some being moderate and only one being severe. And then when you look at the average IOP decrease in these patients, it was right around that 35%. Then to address the question about more negative pressure and more symptoms, if I can get the table pulled up that had those that had a pressure of greater than 17, I will say that the slide that I'm about to show hasn't been reviewed by the FDA, although it was a table in the study report. These are patients that had negative pressure settings between -17 and -20 for greater than 26 weeks. So and then if you look at that week 38 to week 52, you can see how long each one of those patients wore it. So I believe that there's 8 patients here that wore it at greater than 17 millimeters of mercury, and the average wear time was at average or better. 3 of those, at the extremes of wearing it a long time and a lot of negative pressure, had device-related AEs that were reported, and they were all mild. To also answer Dr. Higginbotham's question about blood pressures, blood pressure medications, specifically, I'll start with all medications and then I'll go directly to beta blockers. What you'll see here is that 32 patients were on antihypertensives. 10 didn't complete the study, so that's consistent with the 1/3 dropout rate that we saw in the study. 9 of the 22 did have some device-related AE, and those were consistent with what we saw in the study around lid edema, periorbital edema, etc. You can see the responder rate was good, and that the average IOP lowering was 36. And then when you look at patients that were on beta blockers, we had 15 patients that were enrolled that were on a beta blocker. 6 did not complete the study, just over that 33% dropout rate. 5 of those 9 had device-related AEs. They were, again, the AEs that we saw through the study, primarily related to lid edema, and the IOP lowering was effective. And I think that addresses any of the remaining questions that the sponsor had from the morning for us. Happy to take any more that you may have as you continue your deliberations. Dr. Herndon does have one more comment to add.
Sure.
Leon Herndon, Duke University. Thank you, Dr. Berdahl. So Dr. Berdahl shared a lot of numbers with you, but I kind of want to level set to take it back to the patient and why this is so important. I've been doing this for 30 years. And some weeks I do 10, 12 trabeculectomy surgeries because we don't have options. I have patients come to me who are getting worse despite their pressures being well controlled when they come to their visits. So I tell them that likely your pressures are going up at night. And the only option we have now is trabeculectomy surgery. And those trabeculectomy surgeons in the room know that trabecular surgery can go perfectly. But how many times do you have perfect results? Not often. And so we talked about patients who are monocular, and the open public comment patients talked about concerns about having trabeculectomy surgery in their only eye. And I've had patients like Jerry who unfortunately have lost their only eye because of what I've done to them. So I think it's good as we talk about patients getting older, older patients may have more comorbidities that you don't want to take back to the operating room. So to me, it's always about the patient and how can we give patients an option to have safer options for their glaucoma treatment. Thank you.
And
thank you very much.
I also thought that the patient rep may enjoy actually seeing what the goggles look like. They're not flattering. So this is the size of the pump. This is the goggles, and hopefully you can see through my eyes that it's clear and I can see through the goggles very well. So I thought that might be helpful for context. Thank you.
So I don't interrupt you. A sponsor completed at this point, at this moment in time, correct?
Yes, we really are this time.
Okay. So we're going to go around and give everyone an opportunity to ask FDA and sponsor any questions. We'll start with our glaucoma subspecialist, Dr. Higginbotham. Can you kick this off, please?
Yes, I'll be happy to. I lost my internet for the exact moment when the sponsor was sharing the information on antihypertensives. So do you mind repeating that, because I missed it as I was.
Yes, I guess I wasn't done. Yes, so antihypertensives, there were 32 patients that were on antihypertensives that enrolled in or that were randomized in the study. 10 didn't complete the study, so that's about the 1/3 dropout rate that we saw. 9 of the remaining 22 had device-related AEs that were similar to the device-related AE profile in the study, and the effectiveness was very similar to the study as a whole, with about a 35 or 37% decrease in mean IOP in either sleep lab or clinic. Then for the beta blocker question, there were 15 patients that were on a beta blocker that were randomized in the study. 6 did not complete the study, again, about that 33%. 5 of those remaining 9 did have device-related AEs, and those AEs were mild and similar to the rest of the study, and those patients as well had a mean IOP lowering that was consistent with the trial in general.
Okay, great. And just out of curiosity, were any of these patients also using CPAP or had a history of sleep apnea by chance?
Yeah, we had 4 patients in the study that did have a history of sleep apnea. We had, we don't know if they used their CPAP or not during the study. However, we have designed the goggles so they can be worn with patients that do use sleep apnea. It depends a little bit on what type of CPAP they're using, but for the majority of CPAP patients, they can wear the goggles with it.
Okay, thank you for repeating those answers. Thank you.
Dr. Schumann, any questions?
Thanks, Dr. Weiss. I have a couple of questions for Dr. Berdahl. One is, I understand that 3 of the 17 subjects, or 3 of 17 subjects, couldn't use the OPAP because of facial anatomy. And if that's correct, could you explain a little bit why that was?
Yes, I can. So right here is how we identify each other. And there's a lot of variability in brows, noses, pupillary distances, etc. And so we find that we get about 85–90% of patients with one of our goggles that we can get a good seal on, with a small, medium, or large goggle. And so we feel like that's pretty good, but we're going to continue to iterate the design of the goggles to see if we can get even more patients that could get a good and comfortable seal over time.
What aspects were preventing the seal from forming?
Typically, it's if the slope of the side of the face drops off too quickly, and we can't get that seal on the peripheral near the temples.
Great. And I had one more question about the use of negative pressure in the presence of a bleb. Have you thought about that? Would it be a problem, especially in an eye with a very thin bleb?
Yes, we have thought about that. We did not study it. It was not in either the Apollo study or in the Artemis study. My sense of it is that in patients that have a aggressive scarred down bleb that failed, that there's likely no to little risk there that's different than what we see in our studies. For a cystic bleb, I think that that's yet to be determined, but we have not studied that group, and we also pointed that out as a warning in the label that it had not been studied in patients that had had prior subconjunctival filtering surgery, whether tubes and or trabeculectomy.
Thanks, John.
Dr. Parrish?
Thank you, Richard Parrish. 2 questions. Number 1, regarding what might be your verbiage for labeling the term adjunct therapy or adjunctive therapy has been included. Could you operationally define what is meant by adjunctive therapy? I mean, to which would you instruct a physician that this should be added? In other words, what constitutes the therapy to which this is an adjunct?
Yeah, thank you. So anybody that's using a ocular antihypotensive or antihypertensive, so anybody using glaucoma drops, anybody that's had a prior IOP lowering procedure with the warning that we just talked about, excluding trabeculectomy, tube shunts, Zen. And although we didn't discuss this level of detail, I think that a question that we could have with FDA is whether or not patients that failed prior medication would qualify in that group or not. But what we think of it is additive for people whose current therapies haven't gotten them the IOP lowering that they need.
And secondly, although implicit in your statement, intraocular pressure less than or equal to 21, I think what I understand, it's not that their pressure is less than 21, but your thesis is the progressive injury is due to pressures that are elevated at night when patients are asleep. And I think it's probably accurate to say most ophthalmologists do not have the ability to determine if pressures are elevated at night. Would you anticipate in your labeling not only pressures less than 21, but some documentation of a pressure elevation at night before treatment is started? Or would that be worked into your instruction on how this device might be used in the appropriate patient who you think would be most likely to benefit from it?
Yeah, thank you. Good question. As you point out, it's difficult to measure intraocular pressure at night. So we don't anticipate that that would be something that would be a requirement of use. We would prefer to leave it at the discretion of the clinician to say this patient's pressure during the day is less than 21. And I think that they need additional IOP lowering at night when it's worn. And we think that that gives the clinician the freedom to take care of the patients the way that they need to be taken care of.
Thank you.
Dr. Scooter?
Thank you, Greg Scooter from Oklahoma City. So it sounds like there have been a number of discussions between the FDA and the sponsors of the last 6 or 7 years. And so we're a couple of times today, the FDA mentioned that with regard to the Apollo and Artemis studies, there weren't really formal safety endpoints. Was there a reason for that, or would you agree or disagree with that statement?
Yeah, so we had formal pre-submission meetings with the FDA prior to the Apollo study. And when we worked with the FDA, we came to alignment of about 50 patients for about 3 months. There was not a definition of formal safety endpoints from that study. Now, maybe one nuance that would be easy to miss is that the Artemis study was started prior to the denial from our Apollo. And we designed the Artemis study based on the input that we got for the Apollo study. We didn't think we were going to need it for approval, but it turns out that FDA understandably wanted 12-month data, not 12-year data, 12-month data. And so that's reasonable. Thankfully, we had that study already going. And, you know, I'm in the trenches like a lot of you taking care of these patients. And although I'm not the scientist that a lot of you guys are, I do care about trying to contribute to the literature and our understanding of the disease and taking better care of patients. And so because we're led that way, we had decided to do this big study that we think was important in a difficult to treat population, normal tension glaucoma, and do the quite big logistic lift to do sleep lab studies and measure eye pressure at the beginning and at the end at night. And so so it is true that there was not input, direct input, I think is the phrase that FDA used, and I agree with it. There was not direct input into the Artemis trial. We tried to take the information from the Apollo study, that from our interactions that we had formally with the FDA, and apply it to the Artemis study.
Thank you. The second question, either even for the sponsor or for the FDA, is in the 20 folks who withdrew consent out of the 31 who were considered dropouts, if you will, do we know why those 20 withdrew their consent? The various reasons?
I suspect that the FDA doesn't have additional granularity on that because we didn't provide it, but we anticipated that question. And so we did our best to try to find that out over the last few weeks. And so here's what we got. Of the 31 that dropped out, you know, like was described by the FDA, 5 were for noncompliance and 6 were for the miscellaneous reasons, including closure of sleep lab because of COVID, et cetera. Of the 20 that you mentioned, about half of them, when we talked to the study coordinators over the last few weeks, they said that about half of them were because they didn't like wearing it. Either it was intolerable, they didn't have a great fit, but the remainder were for kind of onesies and twosies, like 2 had COVID, 1 had time constraints, 1 had a family emergency, 1 had an underlying health condition, 1 had cosmetic concerns, and there were a few patients that the study coordinators just didn't have any information on. So we did our best, and it looks like that's the best answer that we can provide you, so we tried.
Thanks very much.
Dr. Budens?
Yes, one final question for the sponsor. Can you summarize any data that you have on the effect of the device on optic nerve blood flow? Admittedly, more difficult to measure than a lot of the other things that you've presented.
Yes, we can. So we went, so I'm going to just caveat this, that a lot of these small studies are just that, small. And because we were trying to make sure that the effect that we had on lowering IOP, the physiology in the eye, was similar to what we would see with lowering IOP, we looked at kind of those 4 things that we talked about before: laser speckle flowgraphy, that's this, I'll talk about it in a second. We did look at OCTA, and we saw an improvement in the percent area perfused and the capillary density, and then some other measures. And those were primarily to say, is the physiologic response that we would see consistent with what we would see if we were actually lowering IOP? So here's the laser speckle flowgraphy, which is one of the few technologies that can actually measure blood flow, not just, you know, how bright the line is in OCTA. And so there were 7 eyes here that had glaucoma, and there was an increase of 20 to 30% of blood flow in all 4 measured vascular beds. They looked at retinal arterioles, optic nerve tissue, the peripapillary choroid, and the watershed zone. And so we did see increased blood flow. This work was done at the University of Iowa with Randy Carden. And although it was over a brief period of time, like mentioned by the FDA, it did consistently show an increase in blood flow.
Thank you.
I think we now will go over to patient, consumer, and industry representatives. So Barbara, any questions?
My only questions would have to do with PROs and how you would approach that in a aftermarket study. I'm fairly convinced that this is a good thing based on everything I've heard, and it is something necessary. You know, I'm going to be 70 next week, and I'm talking to a lot of people now who have been diagnosed with glaucoma where I live, and they're not doing well because they have this particular kind. And it's very sad to talk to them and see what they've lost. So I'm advocating on their behalf. I do not have glaucoma, thankfully. I have a million other things that happened, but not that. And I would like to think that hearing from other patients, you know, the PROs are important so that these people have some measure of confidence that it's going to work.
Yes, thank you. And we did touch on a couple of the PROs that we did, and I suppose discontinuation could be considered as a de facto PRO. And we do know that there was 1 out of 3 patients that decided to quit the study for some reason. We're willing and happy to work with FDA to talk about, you know, acquiring post-surveillance data to understand the usage of patients. And, you know, the other thing that I'd say is that, you know, as a doctor, I'm talking to my patients all the time on how are you tolerating that drop? How are you tolerating the goggles? And one advantage that we touched on but didn't mention is that doctors will actually know if their patients are using it. So instead of asking my patient, hey, how are you doing with your drop? And they may want to make me happy and say they're doing a good job. And so I'm scratching my head about why they're getting worse. We'll actually know how patients are doing and can help encourage them with compliance or find a different treatment that's better suited for them.
Dr. Lofsfring?
I don't have glaucoma, but I'm just listening to this. The study's only been 1 year. How do we know if there's any deleterious effects after 1 year? And maybe I'm missing something in it because I'm not an ophthalmologist, or what the long-term effects are, if they're negative, positive.
Let me have Dr. Samuelson come up and talk about why we believe that 1 year is adequate to characterize the long-term safety.
Tom Samuelson, Minneapolis. And so a couple questions. I thought maybe I discerned a question about what happens after 1 year from an earlier question you had. And, you know, these patients will continue to wear the goggles as long as it's tolerated well and safe and effective in helping to keep their glaucoma at bay. They may move on to more invasive interventions, but, you know, you'll continue your ongoing surveillance and continue to be a doctor and continue to be a patient. You'll have interaction. How are you doing? How's your test? Here's how it looks from my perspective. How does it look from yours? And you'll just do like we always do with glaucoma. We step up therapy and then we monitor and continue to assess the condition. With regard to a study that's 1 year and feeling like we can be confident about that being an adequate measure of safety, several people on the panel were at this open forum and consensus meeting that the FDA held in Washington, D.C. Leanne Herndon was there. I was there. We talked about what was necessary for some of these new technologies. We're lucky enough to have new technologies come around, and this being one of them. And the consensus was that 1 year should be adequate to show safety. You continue to monitor for sure, but for a study duration, 1 year should be adequate to demonstrate safety. So we complied with that recommendation, even though this was for class 3 implantable devices, surgically implantable devices, whereas this is a removable, reversible class 2 device. We felt the 1 year was a good landmark for that.
Thank you.
Mr. Ray?
Yeah, thank you, Dr. West. This is Elijah Ray from industry. I just want to share two things with the panel members. The first issue I would like to talk about is the appropriate standard, and then the second topic is the one we just talked about, the post-approval study that we'll discuss later on this afternoon when we go to talk about the product. So let me talk about the post-approval study first before I talk about the appropriate standard. And I'm speaking not as a clinician, but based on my experience working with the FDA on several products ranging from class 1 devices to class 3 products. So I think from a post-approval standpoint, when you look at this product overall, as my colleague said from industry, there doesn't seem to be a need for a post-approval study, because why? This is a low-risk product, device where the safety through, as the doctor said, 12 months has been clearly demonstrated when my sponsor presented to the FDA and to the panel members. And also, if there's a need for additional data, I think the sponsor need to be thoughtful that NMPS study doesn't present undue burden and can lead to collection of useful and data as well. So I think the issue of PSA, post-approval study, typically for class 3 products, and FDA knows this, and not for this type of product that we are talking about today. So we're talking about class 3 product is where you see FDA ask for post-approval study. And then talking about the other issue about the appropriate standard, that kind of tied back in to this product. The OPAP is considered a very, very low risk product, and FDA knows this very well. It's a low risk device. It's not high risk. There is no concern to the patient. It's not a PMA product, which is an implant. It's a low risk device. So I think the question on the floor is that with this information, it is important that we be very careful not to hold the OPAP to the same standard that we look at for class 3 product at FDA review from a PMA standpoint. It requires clinical testing and more information, and also post-market approval study in a larger sample size for class 3 products. So those two important points I want to bring it up to the panel members so they can know that this is a low risk product, and post-approval study may not be required for low risk devices from an FDA standpoint. Thank you.
Dr. Weiss.
Dr. Bowman?
I think the FDA may want to respond to what was just said. I'll ask my question after that.
Thank you very much, Dr. Bowman. I appreciate it. So I just wanted to, there seems to be a little bit of confusion. All of the medical devices are classified into 3 classes. Class 1 is the lowest classification for risk. This is a class 2, so it is not class 3, so it is smack in the middle. So I just wanted to make sure that this is clear. And actually, I was going to tell Dr. Weiss that Dr. Bowman has been raising her hand for a long time, so I'll stop.
Obviously, I'm
Go
still,
ahead, Dr.
but what I was trying to do in this portion is actually just go around, give everyone a chance, and then we go to raising hands. But in any case, so is the point of it?
Wait, I didn't get to ask a question. That's why I had my hand raised.
but I would like to clarify something. So if we wanted a post-market study, would that be inappropriate in a device of this level? Or the floor is open for whatever is recommended?
So let me try to summarize again what I asked Tuvi to clarify. Yes, you can recommend a post-approval study. What Tuvi was trying to clarify is that if we do that, that would become part of our special controls, which means that all future devices that fall within this regulation will be required to do post-market studies as well. So we want to make sure that you consider your recommendation in those terms, in that this is a little bit different than recommending a post-market study for PMA, which would be then applicable to just that one device.
Thank you very much for clarifying. And Dr. Ballman, you have the floor.
Thank you, Carla Ballman. I have a question for the sponsor, and maybe I just didn't understand the studies correctly, so forgive me if that's the case. My question is regarding dosing. Do you have data on dosing that was just done, not knowing the supine IOP within a sleep lab? It sounds like on the trial that when individuals found what the IOP was in the sleep lab, that they could then modify the dose. But in real life, that probably is not going to be the case, that people are going to have that information. So I am curious whether you have data on what the outcomes are without having that information to do the dosing.
Yes, we do have that data. And if I can ask you to pull up the Apollo trial with the less than 21 and greater than 21 slides, please. Very astute question. And so the Apollo trial, as you'll recall, did not measure nighttime IOP. And so, and we have it stratified here based on those that were higher than 21 and less than 21 within our indication. And so in the Apollo trial, the IOP lowering was based on that 17, whatever was measured in clinic. And that negative pressure application did lead to a consistent and meaningful and statistically significant decrease in IOP. So yes, we do have that data. It is true that at night, if eye pressure goes up further, then in the Artemis trial, we added some negative pressure. But then also keep in mind that if we get the, can I get the in-clinic do we have in-clinic data at day 0? Probably the slide that was in the core that had the per protocol data across all 5 time points. Yes, thank you. So keep in mind that at day 0 here, that was prior to the sleep lab in the Artemis study. And so that was also based on the clinic IOP -6. And so you see that there's a dramatic treatment effect still at the day 0 time point that was based on in-clinic IOP. And then lastly, can you bring up the slide that shows the consistency relative to negative pressure? There have been some questions also around dosing on how consistent is the negative pressure or the decrease in IOP in response to negative pressure. And so the ETHIR model prior to the Artemis study, the Apollo study, or the confirmed study. So Ross is pretty good at math here. And so his model predicted that there would be a 54% of the negative pressure would get translated into a decreased IOP. So what does that mean? If we dial in -10, we would expect -5.4. In the Artemis trial, we saw 58% of the negative pressure applied translated into decreased IOP. In Apollo, we saw 56%, and in Confirm, we also saw 56% on average. There is a standard deviation around those, and there is variability in IOP measurements, and there's variability in IOP moment to moment. But I think that this helps address how consistent are these IOP lowering responses. And it's also probably a feather in Ross's hat that he was able to predict that before our 3 masked pivotal trials. I confirm wasn't masked, but Artemis and Apollo were. Thank you.
Dr. Repka?
Great, thank you. Michael Repka from Baltimore. I have a couple questions. Dr. Berdahl was really slick at putting those goggles on earlier in this session. But a couple questions about those goggles, and it really comes back to mine this morning when FDA was on. And that's, how safe is it for an elderly person to walk around their house with them on? And they will be fumbling with the tubes and the pressure control gadgetry as well. And I'm going to look for what you recognized in your trial, but I'm also trying to generalize it to actual practice as opposed to a clinical trial patient. I presume the people that both were recruited and signed up are probably slightly healthier, slightly younger than to whom this might get applied for in the future when it's available.
So we didn't record any events where a patient got up at night and fell or had a problem with that. We didn't have any reports of that. The average age in the study was, I think, right around 60 or 61. We did show that the AE rate and that there were significant numbers of patients that were older than that. We did not try to select for healthier patients in any way or anything like that. So, and we tried to preserve the randomization of the trial with one eye compared to the other. So I don't know that I have an entirely satisfactory answer to your question. I will say that, you know, that the pump is small enough that you can kind of hold it in your hand. So you can see it's maybe about the size of an iPhone Max, but thicker. You can slide it into your pocket. And the lenses that we used are the standard A8 polycarbonate lens that's oftentimes used in glasses. And so people can see well out of them. In fact, one of our thoughts around that was so that patients could lay in bed at night before they went to bed or fell asleep and read, etc. So we have not heard a patient complaint that I can think of in anything, including our human factors, that would lead us to believe that that would be a concern.
Okay, and then the next question is sort of along the same lines. Do you expect, or did you observe, many of the patients requiring help positioning the goggles so that they obtained a seal that was adequate and to operate the control panel the control box that you've created or developed?
Yeah, so we did human factors on those things, and the FDA found that the human factors testing was adequate to ensure that patients were able to know how to use the device and put it on. Patients were instructed on how to use the device and put it on, and were sized for the goggles with either their doctor or a member of the clinical study team to help ensure that they were able to get a proper seal and proper fit. And that would be part of the post of the labeling instructions, and we would also do the appropriate teaching to ensure that patients knew how to use it and how to get a good seal.
Okay, and then a third question is regarding who is this really for in your mind? I'm trying to look across the spectrum of glaucoma, and you've got a fairly broad 30 or 40% of patients in the US with glaucoma. And I can't yet put my finger on exactly who this is best given to, because it's going to require long-term care. It's not one and done, if you will. And we could be modeling years of this approach to nocturnal intraocular pressure elevation. And it doesn't seem ideal for some people over the, certainly at the older end of the glaucoma spectrum.
Yeah, so again, when we looked at the patients that were older in our study, they did well in the study. And so, I think that they actually can do quite well with this device. I'll answer from my perspective on who I think that I would use it on in my clinical practice. I'll ask Tom and Leon to do the same, and you can make a judgment from there.
Yeah, can you just include what stage of glaucomatous disease in that discussion, at least one of the factors?
Yeah, I got it. So when I think about glaucoma, it's two things. One, are they getting worse, or do I think that they might be at risk for getting worse based on, what I know about the patient and what their intraocular pressure is and what their history has been? So two reasons. One, they're getting worse, or two, they're at risk for getting worse. Keep in mind, of course, as I think we all know, the damage from glaucoma is irreversible. So the name of the game is prevention and preventing it from getting worse. So in my practice, we have really good answers for patients whose pressure is 24 and we need it to be 20, and we can do an SLT, we can do drops, we can do a stent. We've got good options for them. Where I get nervous is when someone comes in and their pressure is 18 and they're still getting worse, or I know that they're at risk for getting worse. What are my good options for those patients? Because the current therapies don't work that well. So we're looking at a much riskier surgery, like a tube or a trabeculectomy or a Zen. So in my practice, it's going to be for those patients that I think that are at a high risk of getting worse, or they're getting worse and we're trying to avoid a more aggressive surgery. So that's how I think it'll be used in my practice. We'll go with Tom and then Leon.
Yeah, Tom Samuelson, Minneapolis. Terrific questions, and it underscores some of the limitations of most of our glaucoma therapeutics. Taking the wrapper off an eye drop bottle is difficult for many of my patients that are arthritic or those that have a tremor hitting their eyeball. Your colleague in Baltimore, Alan Robin, famously had the video showing individuals trying to put eye drops in and struggling. So, and frankly, we know the adverse effects eye drops often have on the ocular surface. Not to say this is to replace eye drops, it's not. It's adjunctive therapy, but many patients find the second, third, or fourth class of medications that they put on the surface of their eye are intolerable, and they may welcome something that's not coming in contact with their ocular surface. And there will be people that don't have the dexterity to put them on, but the vast majority will. And sometimes those that can't do it are infirm, and their help their night nurse or aide can help them put it on. So there will be a role, but it won't be for everybody, and they'll self-select, as I mentioned earlier. And I love the fact that this lowers pressure at night. I think the interface between the inside of the eye and the retrolaminar space is understudied and not well treated these days. And so if we can lower intraocular pressure at night and favorably influence that retrolaminar pressure ratio, as Ross mentioned, I think it's a very good thing and a new option that we might have.
Dr. Lofstring, if you have a question directly related to what the sponsor said, I would have you ask it. If not, I'm going to call on Dr. Levy-Clark first to have those who haven't spoken have a chance to ask their questions first.
I can wait, and I'll ask.
Okay, thank you. Dr. Levy-Clark.
Thank you. So I did have a comment similar to Dr. Repka, in that for the next generation, if it did become approved, we'd have to look at patients who have more specific arthritic disability and just their ability to use the device. The other question I had for the sponsor is, and I don't know if this is something I missed, was there any direct contraindication for patients who have ongoing intraocular treatment, like intravitreal therapy?
We had an exclusion in the study protocol for those that had active or history of retinal degeneration, an exclusion for those that had a prior penetrating keratoplasty, an exclusion for prior subconjunctival filtering surgery, and I believe an exclusion for anyone that had an ongoing risk because of something that they were undergoing at the moment. And I didn't get the language quite right, but I think you get the gist.
Dr. Wong.
Thank you. Andrew Huang from St. Louis. I have two questions for the sponsor and maybe some comments. I know that you mentioned that this study was designed to demonstrate the effectiveness and the safety of the OPAP, but in Dr. Lin's presentation, she indicated that the visual field, the University of Iowa, the visual field reading center, they indicate, 79% of the study group and 72% of the control group patient did show, sufficient information to demonstrate the glaucoma progression. I think you mentioned that, this study was not designed to study the glaucoma progression. But now, given you the reading center give you about 80% of the patient can, even though it's a small number, but can demonstrate the glaucoma progression. Would that be possible to, or do you have any analysis suggesting if such a device have any role in preventing the glaucoma progression?
Yes, if I could get some of the information about that pulled up, I will. And specifically, I'd like to get the table that had, I think it's the end of the, end of the safety deck, very close to the end of the safety deck that has the table. Yeah, great. I think that this will address, actually, let's see. I think that there's another version of that table at the end of the safety deck. Do you guys have that? If not, I can pull that up. Yeah, thank you. Yeah, so this is the patients that had 2.5 decibels of loss at week 52. And so you can see that there were 4 patients that had 2.5 decibels of loss at week 52, some in the treatment eye, some in the control eye. And what I would draw your attention to is the VF alone column in the middle. And you can see that there are 2 treatment eyes where they say no. There was no visual field progression based on visual field alone. So that's 2 of the 4 that didn't have visual field progression from the reading center based on visual field alone. When you look at the far right, where you look at the progression relative to the contralateral eye, that's comparing it to the contralateral control eye. So if the contralateral control eye was not interpretable, these couldn't be interpretable. So that leaves only 2 patients that could potentially have had visual field progression that were worse than 2.5 decibels as measured in the study. Now, when adding OCT to that, so what do we do in clinical practice when we get a visual field that doesn't make sense? Is that we repeat it and we correlate it with OCT. And the Visual Field Reading Center went through its standard protocol that it does for all studies, albeit in this one retrospectively. And they found that none of those eyes had confirmed visual field progression with OCT. And then lastly, down on the bottom, they did identify one patient, the treatment and the control eye of the same eye, that didn't progress more than 2.5 decibels, but did look like it had progression on visual field, and the OCT did not confirm that. And so that's kind of the granularity behind the Visual Field Reading Center. And their conclusion was that this doesn't appear to have risk for making glaucoma worse. There was a question earlier about what happened to those that had progression at week 26, and were they did they still have progression at week 52? I can address that. And there, every patient that showed 2.5 decibels of progression at week 26 finished the study. So we have week 52 data on all of those. There was 1 patient that had progression at week 52 and at week 26. But again, that was not confirmed progression, and the visual field afterwards that was done with the same study strategy at the beginning did not show progression.
Thank you. Just a hypothetical question. Those are individual, the 5 individuals you just mentioned, but there are 49 patients, that in the study group and 42 in the control group. If you lump them together, collectively, do you think, that you will be able to achieve some, conclusion about whether there's any, glaucoma progression or anything? Because, so far, I have not seen any sustained effect of the treatment, even though every time, you show reproducibility, every time after the application of the OPAP, there will be a reduction of the various from 60% to a reduction of the intraocular pressure. But without using them, the pressure did not go down. So that means, the patient probably will have to use a lifelong commitment,
So there was, so if I think that there are a couple of questions in there. I think the first one would be, if you looked at the visual fields as a whole, was there any poolability to the data and any conclusions that we could draw? I think that the answer is probably not. That's difficult to do with visual fields. We have better visual field gurus than me on this panel. But what the average mean deviation was actually a bit improved at week 52 compared to to day 0 in both the study and the control eye. And then the second part of the question, I think, was a little bit, why didn't the control eye get worse? And we didn't see worsening of the control eye. I don't, as a doctor, we never want to see worsening of anything. But the answer to that question is probably that these patients were treated. And if you go back and if you could pull up the collaborative normal tension glaucoma study waterfall, one of the challenges with glaucoma studies and why that consensus data showed that 1 year is probably adequate is because it takes a long time for visual fields to actually get worse. So, do your best to kind of line up that 1 year time in the collaborative normal tension glaucoma study, and you see that there is not much separation. Oh, I'm sorry, thank you. Here's the slide. Now do your best to line up the 1 year time point with the separation between the treated and the control group. And you'll see that there's not very much difference between them at 1 year. Also keep in mind that all the patients that we're trying to take care of here are treated. And so we're doing this as additional therapy for those that need additional IOP lowering. And there really aren't therapies that do a great job at providing additional IOP lowering. So I think that that's the best answer I can give you for why we didn't see progression in the control group at 1 year.
I have one final comment. Sorry about that. Yeah. I do think this is the first of its kind, the device, and this is de novo. And even though that most of the post-market study is done in the PMA studies, and even though this is a de novo, and as various panelists mentioned, that we don't know beyond 1 year. So I still think there is a value of post-market study, because we don't know first how this device is going to impact the patient's quality of life, impact the long-term outcome. Just like Dr. Berto just mentioned, we don't really know the long-term. And I do agree, that even in the old study, it shows, that those people with elevated pressure, the progression only shows in not even 10% of the patient after many years of follow-up. So it's going to be very difficult to know the long-term effectiveness on the patient. So I think our post-market survey or study would be important. And second is, I kind of directed towards the sponsor and also to the panelists, is that we don't really know how clean this device is going to remain over a course of 1 year. And so far, I have not heard anything about the maintenance or the cleaning or how you keep the safety. And then what if it's going to be easily broken to cut the patient's eye, cut the patient's skin, it's going to cause any infection. So I do think, there's certain, safety precautions should be placed, such as post-market survey. Thank you.
I can address both of those. From the sponsor standpoint, we're happy to work with the FDA to design whatever controls are appropriate for post-market surveillance to determine whatever is necessary for additional reassurance of safety. As far as cleaning the goggles, you're right, it wasn't mentioned. It is in the patient IFU and in the doctor IFU that the goggles are replaced every month. That's how we replaced them during the study. And there are also cleaning instructions, and it can be cleaned with an alcohol wipe or soap and water.
Thank you.
I'm just going to address that. Why do you need to replace them every month? That
Well,
seems like an awful lot.
yeah.
And you're suggesting that when it is released in market, that someone would have to replace this on a monthly basis?
So the reason why it's a month is because we want to ensure that the integrity of the seal is maintained and the seal itself doesn't wear out. And so that's how the preclinical testing was done to ensure that it was at a month. And, you know, think about it perhaps like a CPAP. A lot of times there's the durable medical equipment component of it, that's the pump. And then there's the supply component, which would be the mask for a CPAP, or in our case, the goggles. And so there's kind of a well-worn path on how to do that. And then over time, perhaps we're able to make them last longer.
Dr. Glasser, thank you.
Thank you, David Glasser, Baltimore. I have just two quick follow-up questions to those asked earlier in the session. The first, Dr. Berdahl, when you did your laser speckle flow measurements, what was the timing between when those images were done and when the goggles were last on?
They were done while the goggles were on.
With the goggles on, okay.
Right.
And then the second question was related to Dr. Repka's question and about getting up at night. Were patients given any instructions as to whether to leave them on or take them off, or what to do if they had to get up to go to the bathroom or something like that?
I don't believe that they were given any instructions on what to do or not do. In the middle of the night, they were asked to wear it for 5 days a week and about 6 hours a night. And indeed, that's what they did. But again, we didn't hear any concerns from patients about worries about going to the bathroom. And in this age of patient population, you know, especially amongst the men, I expect there were a lot that were going to the bathroom at night.
And you knew how long they were on each night because the device reported that back to you. Did it
Correct.
also report back to you whether there were interruptions in treatment for several minutes at a time? Or
Yes, it does. It did. And I don't think that we have that exact data, but yes, it does have the ability to know if there's a suction break or an interruption in treatment.
Thank you.
Dr. Edelman?
Yes, hi. Couple of points. Just going back a few minutes, I wanted to provide clarification because in light of the comments I heard, I think there's still some confusion. There is currently no medical product legally on the market in the United States that has an indication for use for treatment of glaucoma. Every single one that's legally marketed is for reduction of IOP in patients with glaucoma. And that goes back to what I think we were trying to clarify this morning, but clearly we didn't do a good job. So, you know, when we evaluate a device like this, where the definition of IOP is sort of subject of a lot of confusion, let me say, or needs a lot of discussion, then its impact on glaucoma progression, visual field, and OCT. This is the reason that we want a lot of your input here, because ultimately the labeling says reduction of IOP, but we want to make sure we clearly communicate what exactly we're doing and what's the impact on the patients. And second, there was some reference again to CPAP masks, and just for clarity, the FDA's recommendation is to get a new mask every 3 months for CPAP machines. And last but certainly not least, I believe Dr. Higginbotham had her hand up for a while, and for some reason, Dr. Weiss can, I think, missed that again. Sorry, Dr. Higginbotham.
Well, that's fine. Thank you for that. My brief and thanks for that clarification. My brief question was, I am not surprised, and I'm sure Rich would also agree to this, that we didn't see any change in visual field in a year. So that certainly I think we can put aside. But it also reaffirms the importance of patient-centered outcomes. And I just wonder, were patients asked if their vision was worse or better, particularly in the treated eye? Because some of my patients with advanced glaucoma, they will tell me if they're progressing before I can actually pick it up on a 10-2 visual field. So I will ask my patients who I'm following with the 10-2 to actually tell me subjectively what they're finding.
Dr. Higginbotham, I do the same thing in the most advanced glaucoma patients. We did not systematically ask that question in this study. We do have the best corrected vision from this study, however, and I'll show that to you. So if you look over here, those that had a baseline of 20/25 or better and 20/40 or better in the study in control eye, and then at week 52, there's actually a slight improvement in the vision of 20/25 or better, and a slight improvement in 20/40 or better. So not exactly what you were asking, but the best that we have. And then in the Apollo study where we did do the SHPC 18, there was questions about vision and visual function. That was our 3-month study. And all of the visual function patient-reported outcomes from the 3-month Apollo study, those were stable over time. So we have something, not exactly what you would want or quite as long as you would want, but we do have something.
Thank you.
Mr. Ray?
Yeah, it's Elijah Ray from industry. I just want to talk about, I know I talked about it, but I want to really echo the issue about post approval studies on the sponsor. The sponsor is not against post approval study, but it's a burden over here, and I want to bring this to the panel member attention that as we give the sponsor recommendation on post approval study, we should not hold them to the same standard as we do for class 3 products, and the FDA knows this very well. So I just want to re-echo that. If we gave them recommendation, it should not be the same standard for a class 3 product, which is high-risk device. Thank you.
Dr. Edelman?
Yeah, I was just going to ask Dr. Fraser-Bursell to comment about the PROs and what was just discussed. Fraser?
Yeah, so Fraser-Bursell, psychometrician. There was mention of the SPHC or HHPC on visual function, and I would agree with the sponsor that overall there didn't seem to be a change in that. There was a little bit of improvement, a little bit of worsening, but one thing to keep in mind with that data is that data is not per eye. So because this was patients serving as their own control, it's going to be difficult to determine exactly what's going on there. Thank you.
I have a few questions for the sponsor. One is the patients were advised to wear the device for 8 hours, but the average was 5 hours. So why is that? Is there a certain level of discomfort that's associated with wearing this? So you can do it a certain amount, but beyond that, you probably won't.
Yeah, thank you. The patients were actually advised to wear it for at least 6 hours and could wear it up to 8 hours. And the group at Johns Hopkins published a really good study looking at sleep patterns in glaucoma patients amongst a number of other things. And what we learned in that study is that the average glaucoma patient sleeps 7 hours. And so on average, we got 5.5 of those 7 hours. However, I would also point out that the median wear time, not the mean, but the median wear time was 5.3 hours of the 7 hours that a glaucoma patient typically sleeps.
But they're not wearing it the whole amount that they're sleeping is what I'm getting at. So is there a reason? Is it that once they get up, they, no reason to put it back on, or they're not doing it their entire amount of sleep?
Yeah. I think that probably what is happening, but we don't know for sure, is that there are some times that you half wake up and take it off, or that you get up to go to the bathroom and you decide to take it off and you crawl back into bed and say, I'm not going to put it back on. That's our best guess, but we don't know for sure. But we are pleased that they were wearing it, 87 or something like that percent, 78.5% of nights at the end of the study, and on average 5.6 hours per night. We felt that that's pretty good. And where we got some of this initial design ideas was around the CPAP literature, which had lower wear thresholds than that.
Okay, thank you. And I don't know if these were exclusionary criteria, or would you recommend, if they weren't, they be in terms of various cornea things? If someone has a keratoconus or an ectatic cornea, or they've had prior refractive surgery, LASIK, RK, or they have endothelial cell loss, since we don't know, do you think they should be exclusionary criteria? If they're not, do you think that's irrelevant, doesn't make a difference?
It's a good question, and since you're asking my opinion, I think that they should be warnings that they weren't studied. Now, I will say that we did have a few patients that did have LASIK in the study, and they still achieved the IOP lowering threshold and had similar AE rates. So I don't think that would necessarily need to get a warning, although the numbers were small. But things like RK and keratoconus, I think it's fair to say that, and I think patients and doctors should know that it wasn't studied in those patients.
Fair. And 58% of folks met the primary endpoint, 63.4% met the secondary endpoint. Now, in those whom didn't meet those endpoints, around 40%, could you determine who was destined to be more successful candidate and who was destined to be a less successful candidate, or the numbers weren't such, or the analysis wasn't such to give the information?
So, good question. The numbers that you referenced were the MITT population.
Mm-hmm.
So that was driven primarily by those 31 patients that dropped out. So if we could predict who was going to drop out, then we'd be able to predict, who would do well in that analysis. However, when you look at the per protocol, and that's the patients that completed the study and were actually using it, the responder rate was very high. And then further, if you look at the patients that, and I'll just take a second to walk you through this slide, what you see the blue dots are, those are the 7 patients at the end of the study that did not meet the primary endpoint, that didn't meet the 20%. The black dots below them are those same patients, those same 7 patients at night in the sleep lab. And every one of them met the nighttime endpoint. And so what I think that this really speaks to here is measurement variability. And so I guess my point is that there were two things probably driving the non-responder rate in the MITT population. By far and away, those that dropped out because we couldn't measure them and we counted them as failures. And then the other thing would be measurement variability. The last thing that I'll say, maybe primarily for the statistician on the call, is that if you do a tipping point analysis of this data, and here it is, and what a tipping point analysis does is it takes every single control eye that dropped out and says they were a success. And you take every single study eye that dropped out and call them a failure. We still met the primary endpoint. So even in this worst possible case scenario, we would still meet the primary efficacy endpoint.
Thank you. And
Dr. Samuelson had one additional comment in response
please.
to your question.
Tom Samuelson, Minneapolis. Dr. Weiss, you bring up a really good point in that the overwhelming non-responders was those that dropped out and they were counted as failures. So basically, as a clinician, are you wearing the device? If yes, and if you're getting a good seal, you're getting pressure reduction. We don't really have any other therapy where we can predict the efficacy that way. There's always non-responders to eye drops. We don't know which ones they are. We might try to do one-eyed trials, but those aren't very good. And with this technology, if they're wearing it and they're getting a seal, because of the physics-based mechanism of action, they're getting pressure reduction. And our data really reflects that. Every single treated eye that used the device, the per protocol analysis, had some pressure reduction. And we really don't have any other treatment modality that's that consistent.
For any of the adverse effects, would you recommend in labeling that the patient stop using the device, or that there were none of them that you would recommend that it change how the device is used?
I'm trying to think if there's an AE that we saw that they were almost all mild in nature. There were a couple moderate. There was one severe lid edema, and that patient got better with reducing the negative pressure a little bit, but ultimately discontinued the trial. And so, and keep in mind that lid edema was self-limited. It would last an hour or two in the morning. So I don't think that I'd want to put doctors at risk of saying you need to stop this therapy if the patient is willing to deal with some eyelid edema in the morning and keep their, potentially devastating disease of glaucoma at bay. I think that that'll be a conversation like it is with eye drops. Notarsadil, for example. Golly, doc, my eye is really red and sore. I can't tolerate it. I need to do something else. Okay, let's find you something else. And I think that that's what we would do with the goggles too.
And I had asked the question whether more negative pressure caused more issues. And I know there's not a lot of numbers here, but I vaguely recall that about 17% had eyelid edema, but it was quoted for the higher pressures, 3 out of 8 or 37% had eyelid edema, which is like double. So maybe you can't say a whole bunch about it, but should anything be in the labeling that if you, or is it going to be recommended everyone's at the same sort of amount of eye pressure so it won't relate?
Yeah, so just a quick clarification. The AE rate that I was talking about was in those patients that had higher than 17. I'll just bring it back up. Here, the number of eyes that had AEs that were wearing it, for a good amount of time of the night for greater than 26 weeks from 17 to 20 is pretty high. And that's 3 of 8. So I think that that's 37.5% of eyes had an AE. The overall rate of AEs in the study, all AEs, and this includes all AEs, was 34%. So that's the comparison, not just to the lid edema. You're right, I think that there was about 17% lid edema, but we were comparing overall AE rate in this population to overall AE rate in the study. Did that help address your question?
So I want to understand, in overall in the study, of all comers, there was less edema, but then if you just took out the number of people who had a higher negative pressure, did a higher percentage of the people with a higher negative pressure, or did a higher, I think my words have to be, did you have a higher chance of having lid edema, or did more of the people with lid edema have a higher negative pressure applied?
Maybe I can try and state it as the way that I understand it, is that 37.5%, 3 out of 8 eyes with pressure greater than 17 and who wore it for at least 26 weeks, that kind of hardcore cohort, had an 87.5 eyes. The AE rate in the study was 34% of eyes. And so pretty comparable.
But one is comparing lid edema to all AEs.
Lid edema. I'm sorry, go ahead.
Yeah, so I'm just apples to apples, comparing lid edema to lid edema, not lid edema to all AEs, comparing people who have the higher negative pressure to either all comers or people who are on the lower pressure, the percentage of people in either of those groups who had lid edema.
Very good. In this group, there was actually this patients that were exposed to the highest amount of pressure. None of them actually had lid edema. There were all 3 had periorbital edema.
Okay, so let's talk periorbital. So so the other ones had lid edema, and there weren't a lot of. So maybe periorbital edema went up if you had high negative.
Looks like perhaps that it did, because it was 13% in the overall group, and it was 37.5% in the negative pressure group. And sorry if I made that clunky on
Sure.
you.
Should that be a cautionary thing in labeling so a doc knows, or is it just going to be recommended? I guess it goes to the second question. What's going to be, you're going to not recommend that the doc changes the settings? There's going to be one setting that it's a one size fits all. What's going to be recommended in the settings for the labeling?
It's hard for me to know what conclusion should be drawn from those 8 patients that had a similar overall AE rate to the prior group, but you're right, the periorbital AE rate was higher. In the labeling, we will have we will have the AE tables and everything for the patients to understand and for the doctors to understand. And then we believe that the doctor and the patient together will decide, hey, am I tolerating this well enough? Do I need to lower the pressure a little bit, et cetera? So I don't know that it needs to be called out more than that. We're willing to work with FDA and negotiate on if there's a better way to educate our patients properly.
So I'm going to go on and ask Barbara to ask her questions, but I would also defer to my glaucoma colleagues in terms of, would you want any guidance in the labeling to the physician of how you use this product? I don't know if it's self-evident or not in terms of the doc's control over it. Barbara? You unmute yourself, please.
Going back
Still
to
muted. Yeah.
Am I on?
Oh, you're good. You're good.
Going back to something that you asked about as far as corneal issues. What, if any, are your thoughts on minimum corneal thickness for using this after LASIK? I have less than 200 microns under the flap.
That's thin.
Yeah,
and,
it is.
And so, I think that the bigger concern I would have, I think that thinness is something, and we may be able to stratify in our study, and we don't have that data at hand, what the corneal thicknesses were within the study. As the glaucoma specialists know, normal tension glaucoma patients have a tendency to have thinner corneas in general. So I suspect that a fair amount in this group had thinner corneas. The average thickness was 511 in this study. The average thickness in the general population is about 545. So already we had a thinner patient population that was in this study. I would say that the earlier question about keratoconus, ectasia, prior RK, I think that those things should be in a warning. I do think that that makes sense. And then we can look at our data based on who entered the study and what their corneal thickness were and decide if that should be a warning too.
All right. My question, though, has more to do with labeling for people who've had corneal refractive surgery and have had poor outcomes, like I did, where we lost so much. I would be very hesitant to try something that has not been tested. If you know what I mean. There have been other occasions where they've claimed that this is safe for people with previous corneal refractive surgery, and it has not been.
Yeah, and I wouldn't make that claim. I would say that we have a small cohort that have had prior refractive surgery. They weren't excluded from the study, and I think that it is very fair to have a warning that says, if you've had prior refractive study, it's only been studied in this many patients with this outcome.
Okay. Thank you.
Dr. Weiss, you are muted.
Thank you. Dr. Parrish.
Yes, reference has been made to the collaborative normal tension glaucoma study, and it's pretty clear that not all normal tension glaucoma patients are the same or are created equal. To get into the study, you had to have a definition of pressure that was not elevated and some visual field defect, but not everybody who ended up getting in the study ultimately had pressure lowering surgery. As a matter of fact, I think about 20% did not. Conversely, of those, and it was just shown in the graph, that had a 30% pressure reduction, there was still progression in about another 20%. So reference has been made to a consistency of pressure lowering as being the beneficial effect of this device. And so I'm wondering if there should be some further discussion, both for the physician and the patient, as to who would most likely benefit from this. To end up getting surgery, that is trabeculectomy, in the collaborative normal tension glaucoma study, you need to have documented evidence of visual field loss before a decision was made for surgery. So I'm just wondering if, to further focus who might benefit from this, there should be some consideration to establishing the rate of change before the device is used, very much the same way we would consider the rate of change before we entered into incisional glaucoma surgery.
Yeah, let me ask Dr. Herndon to comment on that a bit, but I guess I'll reiterate my clinician point of view is that if I have a patient that I believe is in need of additional IOP lowering, because they're at risk of progression, I think that we want to be able to have the ability to take care of that patient, especially given the safe profile of this disease. And I'm also not aware of another glaucoma device or drug that has a requirement that they have to show visual field progression before you can apply the treatment. And so with that, I'll ask Dr. Herndon.
Leon Herndon, Duke University. Thank you, Dr. Parrish. I think with any treatment option that we recommend for our patients, we will want to either see progression or understand that the patient's pressure where it is likely too high and will likely lead to progression. So taking that into account, we'll still, as we've talked about before, continue to monitor patients. This is adjunctive therapy. Continue to monitor patients and go to more invasive surgery or procedure if we feel that they're not stable 3 months, 6 months or so with this additional option.
Thank you. I want to thank the panel.
Yeah,
yeah, please.
Thank you. Tom Samus, Minneapolis. Just want to address Dr. Parrish's question as well. Of course, if we have a patient that we suspect may be progressing, but in the rigor of a study like the normal tension glaucoma study, you have to document that it is real and before you take maybe the next step. But in the real world, it's very nice to have an option that may be therapeutically beneficial, but very low risk while you're trying to sort things out. So for me, at least, to say, I have a patient who I think might be getting worse, therefore I'm going to do a trabeculectomy, versus I have a patient I think might be getting worse, therefore I might use a reversible goggle therapeutic. To me, that's a much easier decision. But the point is well taken. You don't always know who's progressing, but therefore it's nice to have an option that doesn't put the patient in harm's way if you're wrong.
And I would have a less pragmatic comment if you're okay with me interrupting you, Jane.
I want to keep your comment brief. I will then call on Dr. Higginbotham, and the panel will only have about 20 minutes for discussion. So if you can keep it short.
I can be brief, I promise.
Yeah, please.
One of the pragmatics too is what happens after, if we're so fortunate as the panel approves the device or recommends granting of the de novo. And that is that as a lot of the glaucoma specialists know, the last year and a half has been fighting for access from payers for glaucoma treatments. And the payers are more and more following exactly what the label says, which is understandable. And so if there was a prohibition on using the device prior to progression, the irreversible loss by definition would then have to be done before a patient could get access to it through their insurance. And I think that that's an important pragmatic consideration. Giving doctors and patients the ability to engage in their care is important. I hope that was brief enough.
Thank you. Dr. Higginbotham.
Yeah, and this will be a quick question because I too worry about guidelines on for whom this device should be prescribed, and whether or not we can put some guardrails around who gets it. And I wonder, are there patients that you would not recommend? Because usually low tension glaucoma patients will lose field closer to central fixation. And we often get really nervous if there's any manipulation around those eyes. And in the old days, we used to talk about people snuffing out, essentially, as one potential. Are there patients within the spectrum or of advanced disease that you would not actually recommend this mechanical device, if you will, to allow patients to use unsupervised at home?
Yeah, so the treatment for those patients that have that worse glaucoma and the stuff that's scares us and threatening fixation is to lower the IOP further. And that's what this does with arguably the best safety profile. And I'd further point out that for those patients that had advanced visual fields in our study, we did not see patients that did progress in their visual field or did snuff out in our patient, indicating that there may be more risk to those patients. Indicating that there would not be more risk to those patients, albeit small numbers.
Okay, thank you very much. So I want to then have I want to thank the sponsor and the FDA, and now the panelists will use the remaining 20 minutes for discussion on the major points that are presented in this study. Please, again, raise your hand, and if you're lucky, I might see you, and if you're not, I won't, but someone will hopefully clue me off that you're there. So one of the first issues, of course, is do people feel comfortable in terms of saying that this device is indicated as a therapy, an adjunctive therapy for reduction of IOP at night for lower than 21 millimeters? We don't have to go into this in great detail, but if there are any particular issues, because the FDA will be posing these questions in a little bit to us. Anyone have any particular issues or thoughts, or Dr. Schumann?
Thanks, Jane. I think that it's important that that the company did the gold standard study of doing manometry during treatment. And so we know that the device lowers intraocular pressure when the negative pressure is in place. And we've talked a lot about the risks or relative risks of the treatment. So to me, it's pretty clear that the device is effective for what it's claiming, and I think that again, to me, the relative risk associated with the devices is fairly low, but that's something that I think that we'll discuss as a panel. But the most important thing that I wanted to bring up is that that the device is effective in achieving its goal of lowering pressure.
Thanks very much for kicking that off. And I would actually like to go around to the glaucoma specialists here and see if folks are in agreement, or if they would want any additional assessments to confirm that the pressure lowering by excursion tonometry is what the company said that it was. So Dr. Parrish, are you equally comfortable with what's been presented?
I am. I understand it lowers the pressure when the device is applied to the eye, and shortly after removal, it returns to its pre-treatment level. I have no comment on long-term pressure lowering effects other than those that were presented.
Okay, thank you. Dr. Higginbotham?
So Jane, is the focus here the way that the measure was done, the measurement of the pressure using excursion tonometry, and if we feel that adequately assesses the IOP reduction, or is it?
It's both, actually. It's both, or either, whatever you would like to address. I think Dr. Schumann was, pretty comfortable with what he saw, but he did bring up the manometry and how the pressure was checked. And one of the things the FDA is going to be asking us is specifically the comfort of the panel with the excursion tonometry and data from other data that was presented, whether the panel wants any additional assessments. So I'm just sort of widening the question that I asked Joel.
Okay, that's it. So it's really two parts. Yeah, certainly I think the methodology was tested on two cadaver eyes, at least the examination of the
manometry.
Yeah, of the tonometry. So, and the FDA raised some very good questions about the technique. But assuming that there is comfort with, I guess, the non-clinical methodological experimentation, I mean, I think two cadaver eyes isn't a lot. And maybe I might be mixing up the experiments here. And Joel is shaking his head that I am. So, assuming that the FDA concerns are adequately addressed regarding excursion tonometry, yes, I would agree that this does reduce intraocular pressure, compared to clinical versus, or the treated versus the controls. We see that very nicely in the data.
Okay. Dr. Scudder?
Yeah, I agree with what's been said. I think that the primary and secondary endpoints were met, and I think that I think the metametric data are particularly important, as Joel said a little while ago. And that was, again, that was a pre-cataract surgery population of patients, as I recall. So,
Joel, is that what you wanted? You raised your hand for a moment. Is that what you wanted to?
It is. It was 17 pre-cataract surgery patients that the manometry was done in. So it was in vivo.
Right.
Thank you, Joel.
Dr. Parrish? Are you in agreement so far? Any other thoughts on this particular issue, checking of the pressure, as well as whether the sponsor has shown to your well, mostly checking of the way they're checking the pressure? Are you satisfied with that?
Yes, this is Dr. Parrish. I had commented, I agree with
the excursion tonometry.
Yeah.
Okay. Dr. Boudens?
Yes, I think they've demonstrated that the measuring methodology is strong, and with the in vivo cataract studies with manometry, which is the gold standard, I don't think there's any question.
And not to discriminate against my anterior segment colleagues or anyone else here, but does if you have a particular thought on any of these particular questions, please raise your hand. And Dr. Repka.
Yeah, so sorry to jump in, Michael Repka. I think that it's different here. They clearly lowers the pressure while it's being used, but that's unlike any of our other treatments in glaucoma, which, albeit go up and down over the course of the day, this is limited to the period of application. And that, I think, is going to need a lot of nuance in both its professional messaging and patient messaging.
And that would be up to the panel in terms of recommendations as far as labeling goes. Initially, I was thinking temporary, but ultimately everything is temporary. But you're right, this is only at the moment you're using it. So, so that I think could get taken care of in labeling. Melvina, am I correct as far as that goes?
Yes.
Yeah. Any other comments on this aspect so far?
I believe Dr. Levy-Clark has a hand up.
Ah, Dr. Levy-Clark.
So I wanted to reiterate what Dr. Repka says. We're looking at adjunctive therapy that's intermittent for chronic disease that's continuous. So I think the messaging to patient will be very critical.
And it was asked of the sponsor, but would we have to clarify what we mean by adjunctive? I mean, clearly, if they're on drops or they've had surgery, it's adjunctive. But then if they had unsuccessful surgery and they're no longer on any drops, is that adjunctive or not? No one does anyone have an answer, or is that something?
Please, there is a question.
Andrew?
There's a question.
It's a question. Yeah.
Dr. Glazer. Dr. Glazer has a question.
Dr. Glazer.
Yeah, hi, Jane. David Glasser, Baltimore.
Yeah, David.
Yeah, I think there needs to be a broad definition of adjunctive. You know, it's for folks who need something else, whether they're currently on something or not. I also echo those who have said that the pressure measurements are well supported, and this is the pressure that counts, not the transcorneal pressure. As to it being temporary or only while you're applying it, you know, other than surgery, drops are temporary. They're only good for so many hours after you put them in. And I understand there's a difference there, but not quite as much of a difference in my mind as has been described by others.
What about the safety short term, namely the first year versus long term, which of course we don't have the data? Are people comfortable with the short term, and are they what do they think about the long term? Anyone who would like to provide their opinion on that? Greg?
Well, I mean, I think what's unclear is what will be the long-term patient acceptance here. I mean, we saw 35 or 33% dropout rate over 1 year. So I think it'll be important to understand that some people have the lid edema and so forth. Some may not tolerate it long term. But I think to address your question, I think part of what is shared will include the fact we don't have really data beyond 1 year.
So would you recommend something be put in labeling saying there is no information as far as anything past a year, or in terms of long-term safety?
Well, I'm not sure what the routine is, Malvina, but is that unusual, or is that common, or somewhere in between?
We can certainly take, if that is the panel's recommendation, we can certainly take that into consideration. It has been done in the past, where in the labeling we indicate the extent of long-term knowledge about the particular device before it goes on the market.
Dr. Ballman, and then Dr. Repka, and then Dr. Glasser.
Thank you, Carla Ballman. I guess I'm not completely comfortable even with the short term, the 1 year, because I think the biggest sort of risk is glioma sort of progression and it worsening it. And my understanding is that the study wasn't designed to test that rigorously. There was a lot of variability in the measurements that were done. There were a lot of insufficient quality scans. And so I don't know what the answer is to that particular question. And it was only on 60-some patients. So if you think about this, and it's out there in the market and it's affecting, you know, it's making it much worse than 1 in 100, this study may not have seen that. And is that an acceptable level? So I'm not comfortable with that aspect per se. So.
Dr. Repka?
Michael Repka, Baltimore. I'm concerned about putting a limit on the labeling, even though the study did not go that far, because there's no reason to believe here that this won't keep doing what it's been doing over a year. And I think a label just based on the single pivotal trial, to me, is insufficient reason to restrict its use beyond 1 year. I hope I wasn't too circular, but I believe that unless we were seeing a decay or a reason to believe that it wouldn't work beyond the treatment, I would argue against putting a finite timeline on it.
So if I can jump in, Dr. Weiss.
Yes, please.
So Dr. Repka, I think there are two different aspects that are getting confused here. One is a warning saying we have no long-term data. That does not preclude physicians using a device from using it for however long they want to use it. But I think what you're describing is something that we would put in IFU, which would be, for example, changing the actual language in IFU, saying it can be used as an adjunct therapy for blah, blah, blah for 1 year. So those are two very different regulatory realms.
Thank you for the clarification. I would argue against the 1 year in the IFU based on what we've seen.
Okay. Dr. Glasser.
David Glasser, Baltimore. I will echo what Dr. Repka said. I would also argue against putting condition based on the 1 year data. I feel fairly comfortable with the safety, absent any theoretical reason to suspect that lowering intraocular pressure will increase progression of glaucoma. I understand the discomfort with a new technique to lower pressure, but I fail to see any real risk there.
Dr. Bowman?
Yeah, I guess this is Carla Baumann. I guess I'm just conservative coming from the cancer world where we really have to look at sort of AEs, even though we're saving lives in that respect. Another thing I'm uncomfortable with is the range down to 20. There are only 8 patients, 17 to 20, that we saw the AEs on, and you know, who knows like what it might be, you know, in older patients. And older, I don't know if 65 really means that's older. I was thinking older being like in the 70, upper 70s, and we didn't see data on that as well. And then also, yeah, using it for 8 hours. There were very few patients that actually had that amount too. So it's still a question as to what the AE profile might be in those patients as well.
Does the panel believe that the available data support the proposed range of programmable negative pressure and the programmable range of wear time? And if not, what do folks recommend? Any comments on that? Dr. Schumann?
Yeah, I think the range of pressure is probably going to be determined mostly by the patient, actually, and so it'll be determined by patient comfort. We already know that some patients couldn't tolerate the level of pressure that their docs had pumped them up to, or that the protocol asked for. So I'm less concerned about people having too negative pressure because of discomfort. I think that'll limit it. The question is, you know, will they have enough negative pressure to have an effect? And that I think is part of the range that's being recommended. So I'm pretty comfortable with that.
Dr. Parrish, and I'm also going to give you this question, Dr. Parrish. In addition, does their proposed statement use the appropriate nomenclature and language to accurately describe the function of the device with regard to pressure? And if not, should it be rephrased?
Yes, I believe that a statement of how it works is appropriate. It's understandable.
Okay.
You know, I don't have any issue.
And you raise your hand, so in terms of what you wanted to contribute.
It must not have been terribly important. I can't remember.
Well, here's in the remaining 2 minutes. The bottom line here for this meeting, of course, is do the probable benefits of the OPAP device outweigh the probable risk for use in patients? Dr. Higginbotham, your hand is up. I need you to change the color of that hand because I need much better contrast sensitivity than I have to pick it up. But that's I'm going to let you answer.
Well, yeah, it matches me, so there you go.
But I need the contrast sensitivity because you have black, you have it right in front of a different background. But in any case.
No, I was going to comment briefly on the range. I mean, since most of the patients in this small cohort were 5.4 to 5.6 hours, the 8 hours is a little bit of a concern for me in terms of safety, since there were so few in that area. But I would say the benefits outweigh the risks.
Okay, perfect. Dr. Parrish.
Back again. You know, and like CPAP, if you have CPAP, you can then measure someone and determine if their PO2 has changed or has improved. And you would change the parameters of the pressure delivered depending on your effect. my question here is presumably the device will be placed on. And then the question I would have to the sponsor is, how would you know whether you've achieved a desirable pressure lowering as a result of the negative pressure that you've started? In other words, is there something analogous to how we modify CPAP delivery that could be applicable here?
I didn't hear, I think I asked that, and I don't know how we tell the physician to change the device settings. Dr. Wong? And then Dr. Boudens. I guess, Melvina, can we run over a minute or two or no?
It is at your discretion.
I'm going to run over. Dr.
Well,
Wong, and then Dr. Boudens.
I know we are short of time, so just a brief comment.
And this is, the sponsor is not sort of participating in this portion. Yes, Dr. Wong, please.
I think the study is underpowered. However, I'm remaining enthusiastic and maybe optimistic about this device. But the problem is I'm against that. Put an IFU with certain restrictions. Say you can only use for 8 hours. You can only use up to 1 year, or you can use whatever. Because this is a device. I think the physician and the patient should have the freedom or the discretion to use whatever they think is appropriate, as long as they don't harm themselves. Thank you.
Thank you. Was there, I'm okay going a little bit over and going into our break. I do want to give everyone a chance to speak who has a comment on these. Dr. Boudens.
I'm just going to weigh in that I do think the effectiveness that they presented outweighs the risks. And I personally would like to see them do a proper study in primary open angle glaucoma patients who have achieved lower pressures but continue to progress, because that's another unmet need. And I believe that's related to nighttime IOP. And so I think this has a much broader use than the labeled indication. And I would encourage the sponsor to forge ahead.
Dr. Glasser.
And David Glasser, Baltimore. I agree that the benefit outweighs the risk. My biggest concern is with the 1/3 who just can't keep doing it. But if you think about it, if you can take 2/3 of the people who are progressing and lower their pressure for 5 or 6 hours at night, that's got to be a good thing. And whether they were at 4 hours or 5 hours or 8 hours, when you consider that, the worst adverse effects were some skin irritation or periorbital edema, I think the potential benefit here is significantly greater than the risk.
And do any of the panel members have any differing thoughts on whether this has demonstrated reasonable safety and efficacy? And do any of the panel, Michael?
Michael Repka, I almost hesitate to ask this, but it still seems that their sample in the longer duration times is still small, and I'm concerned about whether to extend that 6 to 8 hour group, which I think we're only the sample was pretty small in Artemis, and I honestly, it was less than 10, I think, that were in that pressure range, but somebody will fix that thought at some point. But that would be my concern about going up to 8 hours with the amount of data available.
Dr. Ballman?
Yeah, you asked the question, and I'm still a little uncomfortable with the risk benefit. I just don't think there's enough information on 60 patients that actually finished in terms of, what the impact might be on glaucoma progression, because that wasn't rigorously measured, as well as AEs in the patient population this probably will be applied to. I mean, it will be applied to younger patients, but the older patients and then the patients that are going to get the 17 to 20% negative pressure, of which there were only 8 in the study.
Does anyone else have similar concerns that the number of patients in this study did not necessarily prove safety and efficacy? Does anyone have any additional concerns about safety that have not been mentioned to this point? Dr. Lofgren?
It's just from a consumer point. When he put the goggles on and said you can see through them, a lot of the patients are older, so they would need corrective lenses. I guess they can take this thing off and put it back on then, I assume. You know, he could see through them, but if you're older, you're going to have some kind of corrective lens you need to see at night.
That question wasn't asked. My assumption is you can't put those on with the goggles, but
Right. No, my point is, I guess you can take them off and then put them back on, I assume, at night. And
that was my assumption. Any of the glaucoma people correct my assumption, or is that what everyone's thinking? That you could put them on and take them off? Dr. Schumann is agreeing that you could put it on and take it off. I want to make sure that I've heard from everyone at this portion of the session. Dr. Levy-Clark, any thoughts, any disagreements or agreements with what's been heard so far?
I think the theoretical concept is sound. I feel that in clinical research, we're always wanting to have more data, but I think I'm okay with it.
Okay. And Barbara, I don't recall if I heard from you in this session or not, but if there's anything that you wanted to add. You're muted.
Trying not to be. Because I don't have the clinical background, I don't really feel confident speaking to some of those things. But I do think from everything everybody else has said, what I gather is that it's one of those, because it is not an implant and you can stop it, it's reversible. I'm not as concerned about long-term stuff, because it's going to show up if it is. If there are issues long-term, people will tell the doctors that they're having these issues long-term, and adjustments can be made. That's one of the reasons I think it's critical to have the patient-reported outcomes, so that doctors do know if there are things, you know, that should be adjusted.
And Elijah?
Yes, it's Elijah Ray from industry. Well, I'm not a ophthalmologist, but you know, I heard the very expert in different areas. What I would like to say to my fellow panel members is that you heard the testimonies of the patients who use this product. I think the question on today, there is an unmet need for this particular device, you know, for patients and end user. So I'm going to lean in on the expert to provide the FDA recommendation on this de novo. But again, it's a low risk product. It's not a class 3 device that is PMA. So as we make recommendation, keep in mind that it's a low risk medical device. Thank you.
Dr. Edelman, is this to your satisfaction, or would you like something more?
Dr. Weiss, this session has to be to your satisfaction only. Whenever you're ready to proceed to questions, I'll be happy to comment on adequacy of the answers.
Okay, so that I would ask you a question, because we are already late for the break. When the FDA poses each of their questions in detail, not every member has had the opportunity to answer every single subpart of the question. Will any panel members have the opportunity to answer or ask anything at that point, or it will only be a summary from this part of the meeting?
So as we proceed to the questions, it is usually for you to ask each part of the question of every member. And if there is some discussion between panel members, it is at your discretion how you want to proceed.
So that we can proceed that in the next session.
Yes.
Okay, perfect. Consequently, you have a 6-minute break. Can I make that a little bit longer? That can be to my discretion as well.
Yes.
Okay, I'll be generous and make it a 10-minute break. And then we will reconvene. Thank you. At this time, let's focus our discussion on the FDA questions. Panel members, electronic copies of the questions have been emailed to you and are posted on the FDA website. I'd ask that each panel member identify him or herself each time he or she speaks to facilitate transcription. And please show the first question.
We see your slides.
Mira, you muted.
The sponsor proposes the following indications for use. The FSYX Ocular Pressure Adjusting Pump, or FSYX OPAP, is indicated as adjunctive therapy for the reduction of intraocular pressure during nightly use in adult patients with open-angle glaucoma and intraocular pressure less than or equal to 21 millimeters of mercury.
So that is the first question. And Dr. Edelman, as I'm going around to the panel, I am including all members of the panel, including from industry, consumer, patient representative. Is that correct?
Yes, but I don't believe Mira actually read the question yet.
I see.
The conventional IOP measurement is defined by the pressure difference between the inside of the anterior segment of the eye and the environment immediately outside of the eye, as measured by applanating the cornea. Conventionally, this immediate outside environment is atmospheric pressure. However, when applying negative pressure using the FSYX OPAP device, this environment is below atmospheric pressure. An alternative IOP parameter was devised by Balance Ophthalmics to measure IOP while the device is in use, that is, with negative pressure on, as the Goldman applanator cannot be used while a patient is wearing the goggles. This parameter was found to be lowered only while the device is in use, that is, with negative pressure on, and the reduction ended once the device was turned off. However, Balance Ophthalmics defines this alternative parameter as TCPD relative to atmospheric pressure without accounting for the negative pressure microenvironment. Although the data demonstrated that this alternative IOP is lower temporarily when the device is in use, Balance Ophthalmics acknowledges that conventional IOP actually increases by 21.7% to 26.9% with device use. Hence, IOP defined in one way increases while IOP defined in another way decreases. So the first question is, do you believe that there is clinical benefit to the lowering of this alternative IOP parameter and increasing of TCPD on a daily basis for several hours?
So I'm going to go around panel and ask you your thoughts on this, and as well as if there are any concerns you have or any additions you have. It doesn't have to be just a yes or a no, because the FDA wants to assemble all the information. So we'll start with Dr. Repka.
Yes, I think that there's a clinical benefit. I'd love to know what the clinical benefit was based upon the dose if I was going to do future work in this area, both the dose in terms of hours of benefit and the dose in terms of the relative reduction in intraocular pressure measured with the excursion tonometer.
Dr. Grace Levy-Clark.
Yes, excuse me. Yes, this is Grace Levy-Clark. I believe that there is clinical benefit. If there were post-marketing studies, I would want to be able to see data on what we normally collect as monitoring for glaucoma, so more visual field and RNFL data.
Dr. Wang?
Sorry, this is Andrew Huang from St. Louis. I do agree there is a clinical benefit to lowering the intraocular pressure. However, I'm not comfortable about the restrictive description of the indication in the IFU, because there are people that actually when I talked to John Liu before this application that those kind of IOP spikes during at night is actually during sleep. So if people have a different circadian rhythm, such as people that have a night shift, that actually their IOP spikes is during the day when they are sleeping. So, if we just arbitrarily say, that this is only to be used for the night, I think it's a little bit contraindicating in those patients. And then second is that, I think why not just to say, it's the normal tension glaucoma rather than, because when I first read this application, I thought, they meant the open angle glaucoma treatment, that after the pressure reduced to 21, and then you use the OPAP, So I thought, that it's a little bit confusing at least for me, that, probably in adults with open angle glaucoma and with normal tension glaucoma. Thank you.
Thank you. Dr. Glasser?
David Glasser, Baltimore. I do believe there is clinical benefit to lowering the alternative IOP parameter, which is the pressure measured with the excursion goggles, and which I believe is the relevant IOP parameter, as opposed to the transcorneal pressure differential, which is, I don't think, a relevant parameter here.
Thank you. Dr. Boudens?
Yes, I agree that there's clinical benefit with the caveats that Dr. Repka shared about amount and duration, as well as Dr. Wong's question about the group of patients it's indicated in, both of which I think need clarification.
Dr. Skuda?
I'm not particularly fond of the wording of this question based on what David Glasser just said, but I do believe there's clinical benefit in lowering the intraocular pressure as measured by, I guess, excursion tonometry and on a daily basis for several hours. And I would just echo the questions that Michael and others asked.
Dr. Parrish?
Yeah, I might be the odd man out. I have difficulty understanding what, quote, clinical, quote, benefit is. We've assiduously not discussed any therapeutic effect of lowering pressure, which would be my definition of clinical benefit. If this were rewritten, do you believe there is lowering of alternative IOP parameter increasing TCPD on a daily basis for several hours? Yes, it does lower the pressure. My conclusion is if clinical benefit means treatment of glaucoma, that is unproven.
Dr. Schumann?
I believe that this device lowers intraocular pressure. That's the best that I can say. And I agree with Rich.
Dr. Higginbotham?
I agree with Joel and Rich. Certainly it lowers intraocular pressure. However, I would add my concern about several hours. Certainly going as long as 8 hours, I have concerns, but certainly 5 to 6, and I know we're going to talk about that later, but the duration is a concern.
Dr. Bowman?
Yeah, I agree with the people that are much more knowledgeable than I, but I also would say that I believe it lowers IOP rather than how it's worded.
Barbara Burney?
I have to defer to the experts, but I do have one slight comment to make. I don't know anybody who sleeps 8 hours.
Dr. Lofspring?
I can see that it lowers IOP, but I have to defer to the experts like Dr. Parrish. I agree with his thoughts and others likewise.
Dr. Ray?
Thank you. Elijah Ray from industry. I'm not an expert, so I would defer to the expert on this question. Thank you.
So, Dr. Edelman, regarding question 1, it appears the panel generally believes that the wording here was changed from clinical benefit to that it's there's a lowering of the IOP. Most of the panel agrees with that. Some of the panel agrees with the present wording. The panel does have some concerns about that there's an unknown dose-related benefit in terms of the number of hours one should be wearing this and the amount of IOP reduction, as well as some concerns about not having or would like wanting to have post studies about the RNFL and the visual field. And also there's some concern about what the indications for the device are, in what groups of patients can this be used besides normal tension glaucoma with pressure less than 21. But what I heard from the panel, there is a concern on saying there's a clinical benefit, as the progression of glaucoma long-term has not really been studied with this. Dr. Edelman, is that adequate for you?
Almost.
Almost. What else can we do to make you happier?
So I guess the essence of this question, and this is something we've been alluding to earlier, that all of the current medical products on the market are for IOP decrease in glaucoma patients based on the many clinical trials that show IOP lowering has an impact on glaucoma progression. So I guess the clinical benefit wording in this question tried to get at the point of whether assessment of the pressure, lowering of the pressure that was demonstrated in this clinical study, would that, in panel's opinion, be equivalent to lowering of IOP in glaucoma patients that have been demonstrated, the impact of which has been demonstrated in many studies?
Maybe I can start again with my glaucoma colleagues. Dr. Parrish, having brought up that changing the wording, would you be comfortable in saying that we could use the clinical benefit because it lowers IOP, and as Dr. Edelman says, that's the gold standard for other things, or is that something where you would not feel comfortable with that?
I am aware of any other device or drug whose efficacy is measured in a term of 4 to 6 hours. My understanding of drugs, when used properly in surgery, when successfully executed, would result in sustained IOP lowering, therefore the clinical benefit. And at this point, I think the effect of 4 to 6 hours being equivalent to a constant pressure lowering, quote, clinical benefit is unknown.
So to paraphrase, could I say that you, at this point in time, you don't know if there's a clinical benefit?
That would be accurate.
Okay. Dr. Schumann, same question.
Right. So the question is worded as to whether we believe. And I would say that I believe that there's likely to be a clinical benefit. That's really the best that we can say. The clinical benefit wasn't tested. It hasn't been tested in this setting. We have tested the clinical benefit of pressure lowering, and we know that pressure lowering is protective, but it hasn't been tested in a study with this device in the way that it needs to be tested to determine whether or not there's a clinical benefit. On the other hand, we do know that there's pressure lowering over a period of time each evening with this device. So I would say likely yes.
Okay, and Dr. Higginbotham?
I would agree with my colleagues that specifically this is related to IOP reduction. And yes, based on previous clinical trials, IOP reduction does actually translate to a clinical benefit in glaucoma patients. But specifically in this case, I think it's primarily the IOP reduction. But what is unknown, as was stated, is this long duration that is required to get to that point. So I suppose I'm on both sides of the track here.
So would I put you in Dr. Parrish's camp, which is this is unknown, or would I put you in Dr. Schumann's camp where this is likely?
I would say
Do you have a
that
different cap?
Yeah, I would say it's, I'm closer to Rich Parish.
It's unknown. Okay. And Dr. Scooter, Dr. Boudens, Dr. Scooter, and then Dr. Boudens, in terms of, do you believe there's a clinical benefit? Is it, or if you do not, or you're not sure, is it unknown or is it likely, or some other terminology? Dr. Scooter?
I mean, I guess that I believe there's a clinical benefit in the lowering or by the lowering of intraocular pressure as a general concept. Is that good enough, or?
I'm going to defer to Dr. Edelman on that. Is that good enough?
No, I think we all know that that's the reason that everything is approved for IOP lowering. I think we're trying to take that concept and translate it to the data at hand.
I believe there's clinical benefit in lowering the intraocular pressure on a daily basis for, again, the 4 to 6 hours that's been mentioned. So I'm willing to say clinical benefit based on prior data.
That's fair.
To support the concept.
Dr. Boudens?
I get the nuances here, but I'm willing to say that given our past experience.
And we appreciate your willingness to commit, Dr. Scooter. Thank you. Dr. Boudens?
And I think we can infer a clinical benefit from the demonstrated IOP lowering with this device.
Okay. And I believe Dr. Glasserwong, Levy-Clark, and Repka had all previously said they thought there was a clinical benefit. Correct me if I'm wrong. If I'm not wrong, if you've changed your minds, then please let me know. Or if you think there's a clinical benefit, then I'll just summarize this for Dr. Edelman.
Dr. Levy-Clark here. So if we're saying it's going to have adjunctive, if it's therapy, it's going to have clinical benefit, because then we're going to be conflicting.
Okay. So Dr. Edelman, is this adequate? We have a mixture of opinions on the panel. It seems that maybe approximately half of people or a little bit more think there's a clinical benefit, but a strong minority are either unsure or they think there's likely a clinical benefit.
It is adequate for me. I'm not sure if Dr. Scooter still has his hand up or not.
Dr. Scooter, please. You're muted, I think, Greg.
Does that phrase about increasing of TCPD have to stay?
So the question currently reads, do you believe there's a clinical benefit to the lowering of the alternative IOP parameter and increasing of TPCD on a daily basis for several hours? That is the question, and the question's being posed to FDA. Could one get rid of the TCPD part and answer the question, or you want both, the fact that the TCPD goes up and the alternative IOP parameter goes down?
My understanding was that the panel was answering the question in light of both parts presented. Dr. Scooter, the question doesn't get translated into labeling, if that's the confusion. This is merely a question to get your input on the answers.
All right, thank you. But I agree with David Glasser's point a while ago.
Are you satisfied at this point, Dr. Edelman? Okay,
yes,
great.
Thank you. Thank you for going around twice. I appreciate it.
We aim to serve. FDA question number 2.
In support of the demonstration of effectiveness, the sponsor has submitted data from the CP19 pivotal study and 21 additional studies. See Section 8, Report of Prior Investigations and FDA's Executive Summary. In the CP19 pivotal study, the pre-specified primary and secondary effectiveness endpoints were met. 58.1% of study eyes and 1.1% of control eyes demonstrated a 20% or greater reduction of IOP by excursion tonometry at the week 52 clinic visit. 63.4% of study eyes and 3.2% of control eyes demonstrated a 20% or greater reduction of IOP by excursion tonometry at the week 52 sleep lab visit. Measurements by Goldman applanation tonometry show that after cessation of device use, the IOP reverts closely to the IOP measured before device use. Do you believe the IOP lowering as measured by excursion tonometry during use of the device observed in the CP19 pivotal trial in combination with data from other supportive additional studies demonstrates a reasonable assurance of effectiveness as an adjunctive therapy for the reduction of intraocular pressure during use in adult patients with open-angle glaucoma and IOP less than or equal to 21 millimeters of mercury? If not, what additional assessments do you recommend?
Yeah, I'm going to go around again, and I should clarify, you can give me an opinion. Also, you have the opportunity to say you abstain from answering the question. So that is totally your choice. I'm going to start with Elijah Ray.
Again, it's Elijah Ray from industry. I do believe that the IOP lowering as measured by excursion, this question I do agree, but again, I'm going to lean in heavily on the expert recommendation, but I do agree with question number 2. Thank you.
Dr. Lofspring?
I agree exactly with what Elijah said. I agree with the first part, and I'm going to have to defer to the experts for the second part.
Barbara Burney?
I concur with the other two preceding me.
Dr. Ballman?
Yeah, I concur with what's been said so far.
Dr. Higginbotham?
Yes, I do believe this is effective in lowering intraocular pressure in opening of glaucoma patients with IOP less than 21. Additional assessments I would like to see would be ongoing monitoring of visual fields as well as OCT or optic nerve imaging, but also clear assessment of patient-centered outcomes that would determine whether or not there was some outcome that was not anticipated related to quality of life, as well as any visual changes.
Dr. Schumann?
I agree with Eve.
Dr. Parrish?
I agree with Eve, and it's clear that the statement that we're looking at in this question 2 only relates to IOP lowering as measured by excursion tonometry during the use of the device, not at any other time. I agree with this, the statement, yes.
Dr. Skuda?
Yes, with during the use of the device. And I think Dr. Higginbotham made many good suggestions.
Dr. Boudens?
Yes, I agree with the statement. I don't think there's any additional assessments needed to support the statement, but would like to suggest phase 4 studies of longer outcomes of visual field and OCT progression, as Dr. Higginbotham suggests.
Dr. Glasser?
David Glasser, Baltimore. I also agree with the statement. Dr. Parrish's excellent point about 4 or 5 hours versus sustained pressure relief, I think is important, yet I still believe that the 4 or 5 hours does offer a reasonable assurance of effectiveness. I also agree with Dr. Higginbotham's recommendation for follow-up visual field and OCT.
Dr. Wong? Unmute, Andrew.
I agree with Dr. Higginbotham, with the statement as well as the long-term follow-up. Thank you.
Dr. Levy-Clark?
Dr. Levy-Clark, yes, I agree with the statement.
Dr. Repka?
Michael Repka, Baltimore. The statement, I agree with the statement. I'd like longer-term safety data in a chronic user.
And I want to just confirm that I did speak with everyone, and seeing no one chime in that I did not. I will summarize question 2 for Dr. Edelman. Regarding question 2, the panel uniformly agrees with the statement, but the panel also has some concerns on wanting to have longer term outcomes and ongoing visual fields and OCTs, as well as patient reported centered outcomes such as quality of life. And there is some emphasis that this applies to while the device is being used, but not when the device is not used. Dr. Edelman, is this adequate?
I just have one clarification.
Yes.
Dr. Higginbotham, thank you for your recommendation. I wasn't clear if you were suggesting that these additional testing be obtained before the device goes on the market, or were you suggesting a post-market study? Those are two different routes for us.
I understand. It was the latter, post-market study.
And was that the consensus of the panel, Dr. Weiss? Everybody consensus was for
Well, let me go around again. Dr. Repka, did you want a post-market study? Yes, no, or anything in between?
No, I thought a post-market study was the route here.
Dr. Levy-Clark?
Yes, post-marketing studies.
Dr. Wong?
Yes.
Dr. Glasser?
Post-market study.
Dr. Budens?
Post-market study.
Dr. Skuda, I just actually, anyone who wants a post-market study, why don't we do this? It might be more efficient. Why don't you just raise your hand? So, Dr. Edelman, you can read the group, correct?
Yes, but why don't you summarize it for the record?
So for the record, it appears unanimous that the panel would like a post-market study.
Thank you, Dr. Weiss. Mira, question number 3, please.
In the CP19 pivotal trial, the following were the key safety findings at 1 year. Ocular adverse events, most frequently reported. Eyelid edema, 11.8%. Signs and symptoms of dry eye, 5.4%. Conjunctival hyperemia, 4.3%. Eye pain, 3.2%. Eyelid erythema, 2.2%. Loss of best corrected distance visual acuity at 10 letters or greater from baseline, 2.2%, and posterior vitreous detachment, 2.2%. Periorbital adverse events, periorbital edema, 12.9%, periorbital contact dermatitis, 4.3%, and periorbital pain, 2.2%. The post-hoc analysis of visual field conducted by a third-party reading center revealed mean deviation worsening of greater than or equal to 2.5 decibels in 4 study eyes, or 6.5% at week 26, and 3 study eyes, or 4.8% at week 52. Optical coherence tomography, or OCT, examinations were collected from 62 participants at the week 26 and week 52 visit and evaluated post-hoc by a third-party reading center. No formal quantitative analysis of OCT data had been planned or was conducted. For the first subpart, do you believe the available data demonstrates reasonable assurance of safety at 1 year? If not, what additional data do you recommend?
So for the panel, we're going to go around for each part of question 3. So I'm going to go around for this part of question 3. And Dr. Repka, your thoughts?
So Michael Repka, Baltimore, question 3A. I do believe the data at 1 year are reasonable assurance of safety. It would have been nicer to have more data there, and I hope that will be possible in the future.
Dr. Levy-Clark?
I believe for the 1 year is reasonable. And it would have been stronger data if we had had built-in OCT or visual field as part of the safety analysis.
Dr. Wong? Andrew, I think you just have to unmute.
Sorry.
No worry.
Sorry about that. Yeah, I do believe the available data, to demonstrate reasonable assurance at 1 year. However, I do think the study is a little bit underpowered.
Dr. Glasser?
Yeah, I do believe the data demonstrates reasonable assurance of safety at 1 year.
Dr. Boudens?
Yes, I believe statement A.
Dr. Skuda?
I also believe statement A.
Dr. Parrish?
Yes, I agree with statement A.
Dr. Schumann?
I agree with statement A.
Dr. Higginbotham?
Yes.
Dr. Ballman?
Yes, I believe there's reasonable assurance of safety at 1 year.
Barbara Burney?
Yes, I agree.
Dr. Lofspring?
I agree with statement A.
Dr. Ray? Elijah, sorry, I'm giving you an MD or PhD as a matter of attending our panel meeting, so.
Yeah, I appreciate that. The compliment, I'll take that. Yes, I do agree with statement A. Thank you, Doc.
Okay, you're welcome. So Dr. Edelman, regarding question 3A, there's a consensus that the panel agrees that the available data demonstrates reasonable assurance of safety at 1 year. The concerns were that there was a bit of a wish list, that it would have been nice if there were more patients, and it would have been nice if the OCT and the visual fields, there were more of those. But that doesn't negate that the answer from the panel is a resounding yes for question 3A.
Thank you.
Is that adequate?
Yes, Mira,
Okay.
please go to part B.
Do you believe the available data demonstrates reasonable assurance of long-term safety? If not, what additional data do you recommend?
So you want us to handle B and C together, correct?
Yes, please.
Okay, so Dr. Repka?
Michael Repka, Baltimore. I don't believe that the long-term safety has been demonstrated beyond 1 year, particularly with those measures, visual field and OCT, and I think that that would be helpful. I think with respect to the device fitting and the patient able to use it, I think that's reasonable. I would also suggest collecting data on injuries or other adverse events that might occur with ambulation. I still am worried about this population, particularly a post-market population that I project will be older and having more systemic disease using the gadgetry.
So just so I understand, Michael, you want data on injuries and ambulation. You also want extra data on proper fitting of the device?
Essentially, yes. Are they able to use the device in practice with the population that actually gets it in clinical practice? And hence, that would be useful. And with respect to the visual fields in OCT, obviously, the longer you use it, you may be able to pick up more subtle abnormalities in it, in those outcome measures.
Okay, thank you. Dr. Levy-Clark?
I don't think it will give us any long-term safety data at this point, but the post-marketing studies can be constructed to do just that.
So do you believe the available data demonstrates reasonable assurance of long-term safety, or you do not?
No, I think we need more data for long-term safety.
Okay, thank you. Dr. Wong?
All right, yeah. I do not believe the available data, demonstrate reasonable assurance of long-term safety. I would recommend, in addition to the visual field OCT and also, maybe corneal as corneal topography.
So glad you added the topography. Dr. Glasser?
I agree with the prior speakers. I don't believe the data is there for reasonable assurance of long-term safety. I think additional data, including visual field and OCT, would be useful.
Dr. Boudens?
Agree with the summary that Dr. Glasser just gave. I don't believe the available data demonstrates reasonable assurance of long-term safety and would like to see post-marketing studies, including OCT and visual fields.
Dr. Parrish?
I agree with Dr. Glasser and Dr. Boudens. We need more long-term data, and we cannot reasonably understand long-term safety on the basis of what the information we currently have.
Dr. Schumann?
I agree with Dr. Parrish and those who came before him.
Dr. Higginbotham?
My answer to 3B is no. And regarding additional data, in addition to what's been stated, I more specifically would like to see more patients in that 6 to 8 hour duration range, as well as more patient-centered outcomes in the 65 plus and the 75 plus range, because of the dominance of patients with quote unquote low tension glaucoma in the 65 plus age range and the paucity of data that we currently have.
Dr. Bowman?
Yeah, my answer to B is no, and I agree with what Dr. Higginbotham just proposed.
Barbara Burney?
Barbara Burney, yeah, I agree too with Dr. Higginbotham.
Dr. Lofspring?
I agree with Dr. Parrish and others of the same view.
Elijah Ray?
Well, again, Elijah Ray from industry. I'm not too worried about question 3B. As I stated before, this device is a low-risk product. So I think I agree with question 3B. My answer is, I do believe. Answer is yes.
So, Dr. Edelman, regarding question 3B and C, the panel generally believes that the long-term assurance of safety has not been proven, with industry representative Elijah Ray having a dissenting opinion. As far as additional data, the additional data that the majority of the panel had suggested is visual fields and OCTs, in addition to more patients to be assessed who are using this for 6 to 8 hours, and also in the older age group, 65 up and 75 up, as well as some corneal studies, including pachymetry and corneal topography, as well as also looking at the device fitting and collecting data on patients who've used this as concerns any injuries that may be occurring when they ambulate, and any difficulties in use. Dr. Edelman, is that sufficient?
So thank you very much. That's a great amount of feedback. I just have one additional request.
Sure.
Can we poll? I would appreciate if you poll the panel about how long they envision this long-term safety study for post-market be for, the duration. What is long-term assessment?
So in other words, after post-market study, is this something you would want for 1 year, for 3 years, for 5 years? Is that what we're looking for?
Yes. How long would this post-market assessment study be in order to address the questions that Dr. Parrish, Dr. Higginbotham, and others have raised?
Okay. So Dr. Repka, what would your number be?
Michael Repka, Baltimore. I wish I knew for sure, but I will suggest 2 additional years.
Dr. Levy-Clark?
Well, I'm sorry to interject, Dr. Weiss, but
yeah.
When Dr. Repka says 2 additional years, I assume, I just want to clarify, since a lot of the testing that was suggested wasn't done on the cohort in the clinical study at hand, it would have to be a new study that starts from scratch. So I don't want us to talk about additional years. I want everybody to understand that this is going to be a new study designed to assess all of these outcomes. So how long would you suggest that study be from the beginning to the end? Sorry, Dr. Weiss, but I want to
No,
make sure.
please, I appreciate it.
So shall I respond?
Yes, please.
Then I'll posit a 3-year study.
So we're starting out with one suggestion of a 3-year study from start to finish to look at these long-term issues. Dr. Levy-Clark?
Grace Levy-Clark. Yeah, I would say at least 3 years based on previous studies that were done in this space.
Dr. Wang?
3 years.
Dr. Glasser?
I would be okay with 2 years.
With 3 years, you said, correct?
I would be okay with 2
With
years.
2 years, okay. Dr. Budens?
3 years.
Dr. Skuda?
Yeah, I'm a no on B. I'm not sure if I got called a while ago or not, but yes, I would say additional data for 3 years. I just want to clarify, Jane, earlier when I talked about this, I just want to clarify, I wasn't suggesting that the use be limited to 1 year. It's just collecting more data beyond 1 year.
And if Greg, if there's anything you wanted to add on B or C, feel free to add it now. This is all fluid.
Yeah, the only thing I would add, really, I guess, I just want to make sure that the data collected includes something about patient tolerance and longevity of use.
Okay. So, Dr. Adelman, that's another thing that should be added to C from Dr. Skuda. Dr. Parrish?
I agree, 3 years.
Dr. Schumann?
3 years.
Dr. Higginbotham?
My answer is also 3 years, and my rationale is it all depends upon how frequently they do visual fields in the testing, because it may take as many as 5 to 7 visual fields to see change, depending on, and it gets more difficult in an older age group. So with that as a footnote, I would say 3 years.
Dr. Ballman?
I'm 2 to 3 years, and I think the most thing I want out of this additional thing is assurance that it's not worsening the glaucoma, which we don't even have data, really reliable data at 1 year. And so if the experts feel like it should be 3 years, I'll go with that.
And I will give the patient rep, the consumer rep, the industry rep an opportunity to comment, but if you have no comment, that's okay too. So feel free to join in or feel free to abstain on this one.
Yeah, it's Elijah Wright from industry. I know a lot of the panel members, they are recommending 3 years. I didn't hear their rationale for that 3 years period. Keep in mind, post approval study for class 3 product and not this step of device that is a low risk medical device. So my recommendation based on the FDA guidance document and FDA CFR, I would recommend maybe 2 years. To me, sounds reasonable. Thank you.
I would say 3 years with the addendums that a couple other ones mentioned to the 3 years.
And Barbara, I see.
I would agree 3 years. If something's going to show up, it'll show up in 3 years.
So Dr. Adelman, the majority of the panel recommends 3 years. The minority of the panel recommends 2 years.
Thank you very much. I appreciate this.
You're
Mira,
welcome.
we can go to question 4.
The currently proposed device labeling recommends 1, range of programmable negative pressure between -5 to -20 millimeters of mercury, and 2, range of wear time between 1 to 8 hours. The following data is available for range of programmable negative pressure. For the CP19 trial, 93 participants with a range of mean negative pressure between -10 millimeters of mercury to -12.1 millimeters of mercury. 8 participants who used the device with negative pressure between -17 millimeters of mercury to -20 millimeters of mercury for at least 26 weeks during the trial. Of these 8, 3 experienced ocular and/or periorbital AEs. 53 participants used devices programmed greater than -12 millimeters of mercury at some point during the trial. 38 of these 53 completed the trial, while 15 discontinued early. Of these 38, 18 were reported with a device-related adverse event. For the CP10 trial, 64 participants with a range of mean negative pressure between -10.59 millimeters of mercury to -11.46 millimeters of mercury. The following data is available for a range of wear time. For the CP19 trial, 93 participants with average daily wear time ranging from 5.44 to 5.63 hours, 61 participants with average wear time at the week 52 sleep lab visit of 2.9 plus or minus 0.3 hours from 11 p.m. to 2 a.m. and 2.6 plus or minus 0.5 hours from the hours of 2 a.m. to 5 a.m. For the CP10 trial, 64 participants with average daily wear time ranging from 3.74 to 4.38 hours with an average of 4.4. So for the first subpart, do you believe the available data supports the proposed range of programmable negative pressure? If not, what do you recommend?
So Dr. Weiss, the goal is to answer A with C simultaneously, and then we'll do B with C.
Thank you very much. You could see the confusion even from miles away on my face, so I appreciate that. Dr. Repka, so we're answering A and C. Do you believe the available data supports the proposed range of programmable negative pressure? And if not, what do you recommend?
Michael Repka, Baltimore. I don't think that there is adequate data for the higher negative pressure ranges, as I mentioned much earlier today, and I still think that's the case. My recommendation would be to go somewhere above 12, perhaps 15, but I don't think with just a sample of 8 patients between 17 and 20, there are sufficient data.
Dr. Levy-Clark?
Were you answering A and C or B?
A and C. So Dr. Repka didn't believe the available data supported the proposed range, and consequently, he was suggesting a lower range. So if you believe it supports the current range, then you don't have to answer C. If you don't, then we ask you to answer C.
So the range, I think, since it's a range, I think it's reasonable because the clinicians would have the option to titrate it based on the patient's response. It's a range.
But they won't know the patient's response is the problem, because we don't know what it's lowering the pressure to.
But it's a range you're given, so they could use anywhere from -5 to -20. So it's
you're okay with the current range?
I'm okay with the range.
You're okay.
Yep.
Okay. Dr. Wang?
Agree. First, I do not think the data supports do support the current range, 5 to 20.
Okay. Dr. Glasser?
Yeah, I'm okay with the range of 5 to 20.
Dr. Boudins?
I'm okay with the range, with clinicians deciding the exact amount.
Dr. Scudder?
Yes on A.
Dr. Parrish?
I agree with Dr. Repka, and I don't believe it supports the range into that higher level between 17 and 18 based on the 8 patients reported.
Dr. Schumann?
Yes on A.
Dr. Higginbotham?
I do not believe that it reports that full range. I agree with Dr. Repka that there should be a limitation and future studies on the higher range because there is the potential that providers will not pay attention.
So where would you make the upper limit?
17.
So you'd say you'd go up to 17 would be the max?
Yes, yeah.
Dr. Bowman?
I do not believe that the available data supports the proposed range, especially when it goes out into the general public and people can, I mean, not general public, but general use. It's not clear what people are going to do because there's not really solid guidelines on the dosing. I am comfortable with a cap of 15, and I propose if, potentially it can go up to 20, but it needs further data, and that could be sort of the post-market study having data in that range.
Barbara Burney and Dr. Lofspring and Elijah Ray, do you have any opinion on this?
I would agree with what Dr. Volman just said.
And then I just would like to clarify for Dr. Parrish and Dr. Repka. Dr. Parrish, what would your upper limit be?
17.
17 would be your cap. And Dr. Repka, what would your cap be?
15 inclusive.
15. Okay. So Dr. Edelman, regarding this question 4A, the panel, I think, is divided in terms of some panel members answering yes, and we've got actually 5 panel members answering no. The 5 panel members who answered no, 3 wanted a cap of a 15 pressure, and 2 wanted a cap of a pressure of 17.
Thank you very much. That's sufficient.
That's sufficient. Okay.
Mira, please read B.
It looks like we have a hand raised.
So, okay, so the next question would be 4B. Do you believe the available data supports the proposed range of wear time? And if it does not, what do you recommend? Dr. Repka?
Michael Repka, Baltimore. I don't believe that the available data support the longer durations of treatment proposed in this label.
Is there, similar to the other part of the question, what would you propose would be the upper limit?
My proposal, based upon the data that have been reported, was that 6 hours would be a very adequate cap, or a cap consistent with the data presented.
Thank you. Dr. Levy-Clark?
I would disagree that the excuse me, going up to 8 hours, and I would agree with capping it at 6 hours.
So you think the data supports the proposed?
Does not.
I'm sorry, you believe it supports the amount of wear time?
It does not support that range.
It does not. Okay,
And
it
the
does not, and you
recommendation
have a
would
6-hour limit as well.
Yep.
Thank you. Dr. Wong?
No, answer is no to B, and then 6 hours.
6, okay. Dr. Glasser?
Same answer here, no to 4B, recommend a cap of 6 hours.
Dr. Budens?
I say yes to 4B. More hours of pressure lowering during sleep is better. So I agree with B.
B. Thank you. Dr. Skuda?
So I would recommend a wear time between 4 and 6 hours and no more than 8 hours.
So do you think that do you think the available data supports the proposed range up to 8 hours?
I'll say no. Because it says 1 to 8 right now.
I'm sorry, of wear time, excuse me. The proposed range of wear time, you
Currently
don't.
says 1 to 8.
So you don't think it supports it, but you would be recommending instead
4 to 6, 5 to 6, but no more than 8.
But you would recommend, I guess I want to clarify,
Okay.
you would feel comfortable with them going up to 8?
In selected patients, yes.
So the difference is you're, for majority of patients, you're suggesting less hours, but there would be some in which you would be comfortable with more hours.
I'm being difficult, but yes, I mean, I think that most people are going to go much beyond 6. But
Okay.
I think that for selected patients, I wouldn't force them to stop at 6.
Okay.
But that didn't help you very much, did it?
Dr. Edelman, are you good on the answer?
Did you get everybody's comment?
No, we did not. We'll keep on going. Dr.
Please.
Parrish?
4B, no, cap 6 hours.
Okay. Dr. Schumann?
Yes on B.
Dr. Higginbotham?
I agree with Rich Parrish.
No. Correct?
No, and
No and 6.
Yeah, 4 to 6 hours. Need more data to suggest higher, longer wear times.
Got it. Dr. Ballman?
Yes, 4 to 6 hours, 6 hours cap, so no to B. And again, need additional data to increase it to any higher.
Dr. Burney, Barbara Burney, Dr. Lofspring, and Elijah Ray, any opinions on this segment?
I do. I agree that 4 to 6 hours and more data to suggest that it would be safe longer is probably a good idea.
I agree with Dr. Ballman, Dr. Parrish, more data in 4 to 6 hours.
Elijah, any thoughts on this one? I think you may be muted.
Hello, can you hear me?
Yeah, we can hear you now.
Okay, sorry, I have my pen up. Yeah, I wasn't asked on question 4B. My response to question 4B, I'm sorry, 4A and B. My answer is yes to those 2 questions.
So you're comfortable with what they have at the current time?
Yes,
so, Dr. Edelman, regarding question 4B and C, the panel generally has answered no, that they don't feel that the available data supports the proposed range of wear time. The panel generally recommends at a maximum 6 hours, and some have recommended up to 4 to 6 hours. And Dr. Skuda, although he doesn't feel that the available data supports the proposed range of wear time, he is comfortable for selected patients on going up to 8 hours.
Thank you very much for that terrific summary. We're ready for the next question.
And Boudin said 8 also, right?
Dr. Boudin, did you say?
Yes,
he thought it was all good. So he answered yes, in which case it goes up to 8. I will say you were the only one who answered no, but you were willing to go up to 8 in some select cases.
Sorry
okay.
to be called, yeah.
That's all right. We love you anyway, Craig. We're good. Okay, question 5.
The sponsor proposed the following IFU. The FSYX Ocular Pressure Adjusting Pump, or FSYX OPAP, is indicated as adjunctive therapy for the reduction of intraocular pressure during use in adult patients with open-angle glaucoma and an IOP less than or equal to 21 millimeters of mercury. In the CP19 pivotal trial, IOP was measured via pneumotonometry with excursion goggles before and during negative pressure application during in-clinic visits. The proportion of study eyes with at least 20% IOP reduction relative to atmospheric pressure was 58.1% at week 52, and the mean IOP changed from 18 millimeters of mercury to 11.4 millimeters of mercury. The mean transcorneal pressure difference, or TCPD, increase, meaning relative to the microenvironment surrounding the eye that is created by the goggles, in the study eye was 23.4 millimeters of mercury. So the question is, does the proposed IFU statement use the appropriate nomenclature and language to accurately describe the function of the device with regard to IOP? If not, how should the IFU statement describe the function of the device?
And perhaps we can go back to the IFU as people are answering it. Perhaps, yeah.
Okay, thank you. So we're looking at this statement in terms of what the company has said the indications are, and the question is whether you agree with that statement or do you think it should have any alterations in it?
So Jane,
use the right nomenclature. Yes,
Jane, this is Greg. So actually, the original statement has the word nightly use. This didn't say nightly.
This is the current indication for use. So as you saw from our presentation, the IFU changed a number of times. This is the IFU currently proposed. So this is the IFU in the submission that we want you to comment on. And we also, Dr. Weiss, I am just trying to clarify that we want the panel to comment on how best to communicate this, what this device does to the end user.
So Dr. Edelman, I know this at this point, we don't call on the sponsor, but if there is a question on it, obviously this is your purview, not mine, in terms of is there any extra input that we should get at this point on what the indications are, or do we just forge ahead and because this is what we have?
We would like your opinion on the question at hand.
Okay, so sponsor, Dr. Berdahl, I guess these things will be discussed later, but at this point, the panel forges ahead. So Dr. Repka, your thoughts on this?
Michael Repka, Baltimore.
I'm sorry.
Dr. Schumann, you had a comment?
Yeah, a question. Are we considering, is the IFU just the first paragraph or is it both paragraphs?
Should be just the first paragraph.
It's just the first.
So hold on one second. I just want to make sure, Mira, can we go back to the IFU in your presentation? I want to make sure that I want to make sure that there is no typo in the IFU and that the IFU that we're presenting to the panel is exactly as the IFU currently proposed by the sponsor.
The IFU in question 1 is different than the IFU in question 5.
Yeah, I think that was a wrong version of the slide. So Mira, can you please project the slide that has the IFU that is currently proposed by the sponsor?
Elijah, while they're getting that, you have a comment?
So that's what we think is a problem.
It's the IFU that was sharing. It was not correct, but I think I'm good now. Thank you.
You're right.
And this one, I think, has a typo. There's 2 uses in there. This was Carla.
But it does say nightly use here, which I think is what we saw in their presentation.
Right, this is Carla Baum, but it says during use, nightly use, which
Right.
doesn't really make sense.
So this is the correct IFU. We're very sorry for the confusion.
But drop the first use.
This is what?
Yes, it should read during nightly use.
Correct.
So I can go back to question number 5 and
it's just this one sentence. The IFU is just the one sentence.
yes.
Okay, thank you.
So
We're sorry about the confusion. Apparently the wrong slide went up.
So for question 5, just sort of to reiterate, don't we want to get rid of, I would rather just go back to the other slide, which has the correct. Yeah, I'd rather not look at, yeah.
Yeah. So let me paraphrase. This is correct IFU that the sponsor is proposing in this particular submission. And we're trying to ask that all of your expert input on whether that is clearly communicating to the end user what the device does and what it is intended to do, or if there is some language, especially around the reduction of intraocular pressure or any modifiers that you recommend.
Thank you. And I thank the panel for pointing out where there was a discrepancy. I appreciate your dutifully paying attention to the presentation and reading everything in advance. Dr. Repka.
Michael Repka, Baltimore. I just wanted to clarify once again from Dr. Edelman, is there a regulatory definition of adjunctive?
not a consistent definition. No.
Thank you. Then I don't, I think that in general, this is fine. I don't see the reason for including as adjunctive therapy here. Basically, this lowers the intraocular pressure in such patients. And I don't think that half their patients were not on any current therapy. And so I think it's somewhat misleading to include that phrase and unnecessary.
Dr. Levy-Clark?
So I'm wondering if there's complete transparency in the way the intraocular reduction of intraocular pressure, that phrase, simply because we know that there was a difference between the actual reduction relative to atmospheric pressure versus the TCPD. I'm just unsure at this point if this is the right place for that transparency. So I'm unsure. I can't.
So the question is, perhaps maybe the words reduction of IOP be changed, but that's a question.
Yeah.
Dr. Wang?
I would like to suggest, to delete the adjunct therapy and add, for the temporary reduction of the intraocular pressure during sleep rather than night use.
Okay. Dr. Glasser?
I agree with Dr. Repka and others who have recommended striking adjunctive and getting rid of the extra use. It's just a typo. I'm okay with the rest of the language. And I don't know if this was the right place to bring it up, but there are a number of exclusions in the study that should be added as limitations. The retinal detachment patients, the patients with full thickness glaucoma surgery. Where do and when do we talk about that?
Dr. Edelman? Where would we, if there were the folks who were excluded in the study, where does that, do we just say that it is not indicated for these groups of people in the labeling?
So the indication for use usually talks about who it is indicated for. And then in the description of the study, in the warnings and precautions, we address who it is not for.
So it's somewhere in the labeling.
Thank you.
Usually there's a contraindication in the labeling.
Well, it can either be a contraindication or warning depending on the severity of the significance of the data and the information.
Dr. Boudens?
The reason I brought it up was I just didn't see a question specific to that. So I would suggest that the FDA look at those exclusions and consider those as contraindications.
Dr. Boudens?
I actually think it's important to leave the word adjunctive therapy, the phrase adjunctive therapy in there, because I don't want patients or providers to think that this is some kind of standalone therapy and you can just put this device on at night without using medications or having SLT for something during the day. I mean, I like the temporary concept, but I also like the clear message that this is adjunctive to whatever the patient's using, because there has to be some sort of adjunctive therapy. And I also like the wording towards the end, adult patients with open angle glaucoma and intraocular pressure less than or equal to 21, because it doesn't limit its use to normal tension glaucoma patients. It can include the broader use of POAG patients who have had adequate pressure lowering, have had pressure lowering, but need more for progression in the normal range. So I actually like the way this is phrased.
Thank you. Dr. Skuda?
I was going to make some of the same points that Don made about adjunctive therapy here. As I recall, Dr. Berdahl mentioned, I think that was added, I thought, on FDA recommendations, number one. Number two, I think most people with normal tension glaucoma are going to be on, in the real world anyway, are going to be an additional therapy. So I would keep adjunctive. I approve it as it is. was just the fixing the typo, the double use there.
Dr. Scudder?
That was
I'm
Scudder.
sorry, Dr. Parrish?
Yeah, Rich Parrish from Miami. I think about 4 or 5 hours ago, I brought up the question, what is adjunctive therapy? And we didn't have a satisfactory answer. I would strike it so that it would read the is indicated for the reduction of intraocular pressure, the temporary reduction of intraocular pressure during sleep in adult patients with open angle glaucoma and pressures less than 21. Dr. Wong made the point that not everyone sleeps at night. Some people sleep during the day. And I think the consistency is the fact people are asleep, not whether it's at night. And it is a temporary reduction. It is not for the permanent reduction, but only during its use.
Dr. Schumann?
Yeah, I agree with Dr. Wong as well. And I would keep adjunctive. I think that is an important thing, but temporary is key, and also sleep is key. The idea that you would use it, when you're not recumbent, hasn't been tested. And so we're talking about, people who are lying down, sleeping, using this device.
Dr. Higginbotham?
I would keep it adjunctive, and I would actually add more words and be specific, because I am concerned that, as stated earlier, that some providers will consider this as perhaps even a primary treatment and believe that they're treating their patients. So I would say is indicated in individuals suspected of nocturnal increases in intraocular pressure and in need of adjunctive therapy. I think the insertion of those words, suspected of nocturnal increases in intraocular pressure, at least in my view, really reaffirms the adjunctive nature of this treatment.
And Eve, can you just state again, you said nocturnal intraocular pressure and in need of?
So the pump is indicated in individuals suspected of nocturnal increases in intraocular pressure and therefore in need of adjunctive therapy.
So the question I would have is, could not someone think this is the adjunctive therapy? Might someone not think this is the only therapy you need?
Well, in addition to,
that's the question. The
additional adjunctive therapy. I don't want to
additional adjunctive therapy,
but the thrust of my comment is to be specific. As indicated by the studies, these are patients who were suspected of having nocturnal increases, and just to reaffirm the importance of adjunctive therapy. I'll leave the wordsmithing to others.
Dr. Ballman?
I like having adjunctive there, and I also agree with from changing nightly to use in sleep.
So you wanted the adjunctive there, or you did not?
Yeah, I do want it there.
Okay. Barbara Burney?
I agree with leaving adjunctive therapy, and I certainly would change it to during sleep use, because we don't all sleep at night.
Dr. Lofspring?
I agree with exactly what Barbara just said.
Elijah Ray?
Yes, Elijah Ray from industry. I would keep the adjunctive therapy in the general use statement. One thing I want to point out, though, for the panel members, that the sponsor recommend adult patient only. So this is critical because the FDA classified patient population in 4 categories. So adult patient is from age 21 and up. Okay, so I think we should be very clear on that age range within the statement over here. What age are we talking about? Is it age 21 and up? I think we should clarify that in our statement sharing on here. And FDA can comment on that as well. Thank you.
And actually, I will add a question to FDA or the panel on this. This wasn't studied in 21-year-olds or 30-year-olds, to the best of my knowledge. I don't remember what the age category was, but do we need to indicate what the lowest age this was actually studied in? And I'll defer to you, Melvina, whether I should even be asking that question.
So I think the question you're asking is a little bit different than the one you intend to ask. I think, so right now it states in adult patients, and I think what you're trying to say is, should the IFU be modified to say in patients greater or equal to a particular age or not? Because what the device was studied on is going to be communicated in the labeling. Are you suggesting that that it is limited to a particular age? Because right now it is intended for all adults.
So I would defer to my glaucoma colleagues on that, just in the terms of the cornea field or the refractive surgery field from former panel member meetings. We often did not indicate it as in the labeling as an indication for a group that it wasn't studied in. On the other hand, if my glaucoma colleagues feel comfortable enough with the safety and efficacy, they might not care that it wasn't studied in a 22-year-old and might want to leave a broader range. Whether or not we discuss that, I'll leave to you, Melvina, if that has any importance or not, or you want me to just keep on going along.
Well, now that you've raised it.
This is Greg, I would leave adults. I mean, I think Apollo was age 22, and I think I think Artemis was age 40. I would just leave adults.
Is there anyone who's not okay leaving it as adults? Okay, if not, that has been asked and answered. I believe I've gotten everyone's opinion. If I have not, please chime in now.
Jane, I'd like to modify.
Yes, please.
I would like to say I agree with those who have suggested adding temporary to the reduction and switching nightly to while asleep. I'm still in favor of getting rid of adjunctive, though.
And Michael Repke would be exactly the same comment. I strongly urge not putting adjunctive in it. It creates all kinds of post-approval problems in physician use when many of the patients might not actually be on another glaucoma drop or treatment, and it presumes that treatment is primary and this is secondary to that treatment.
So, Dr. Edelman, regarding question 5, the panel generally believes that the proposed indications for use or the wording of this statement should change. The minority felt that the statement was adequate as it is. The concerns were, 1, removing the word adjunctive because of concerns of what that might imply. 2, instead of saying this should be used at night, to say it should be used during sleep, because not everyone's sleeping at night. 3, to indicate that this is a temporary reduction of pressure, and the wording in terms of whether it's nocturnal, whether there's an indication of this specifically for people who are suspected of having a nocturnal elevation of IOP was also mentioned. Is this adequate for you, Dr. Edelman?
Yes, thank you very much. We can proceed.
Okay, so the FDA will present to us the last question. I think the FDA is going to present to us the last question.
Yeah, just give us a minute. Apparently there's AV glitch. Mira?
Okay, got it.
Hi, this is Tuvi. Mira's audio, she's having some audio issues, so I'll read the last one. Question number 6 is, due to the probable risk of the FSYX OPAP device outweigh the probable risk for use in patients who meet the criteria specified in the proposed IFU?
Okay. So we'll start with the industry representative, Elijah Ray. Do probable benefits outweigh probable risks?
It's Elijah Ray again, from industry. I do believe yes.
Yes.
This question.
Okay.
Thank you.
And Dr. Lofspring?
I would say yes also.
Barbara Burney?
I would say yes.
Carla Ballman?
Yes.
Eve Higginbotham?
Yes.
Joel Schuman?
Yes.
Richard Parrish?
Yes.
Greg Skuda?
Yes.
Donald Budens?
Yes.
David Glasser?
Yes.
Andrew Wong?
Yes.
Grace Levy-Clark?
Yes.
Michael Repka?
Yes.
So Dr. Edelman, regarding question 6, the panel has a consensus that the probable benefits of FSYX OPAP device outweigh the probable risk for use in patients who met the criteria proposed above. No concerns were expressed. Is this adequate?
Yes, thank you very much.
Okay. If so, we are ready for the next question. That's what's in my script.
There is no next question.
I'm not sure what the next question is after question
The next,
6.
I'm sorry, I believe the next question was for you to go around and ask the panels if they have any other concluding thoughts. I'm sorry, there's a typo.
Okay, and that is what I'm about to do. So, Dr. Repka, any concluding thoughts, any comments, and anything that you would like to mention?
Michael Repka, no, I have no additional comments.
Dr. Levy-Clark?
I have no additional comments.
Dr. Wong?
No additional comments. Thank you.
You're welcome. Dr. Glasser?
No additional comments.
Dr. Budens?
No additional comments.
Dr. Skuda?
We're good.
Dr. Parrish?
No additional comments.
Dr. Schuman?
Nope.
Dr. Higginbotham?
I'll just say that I appreciate the analysis of the FDA on this application and the discussion. No additional comment.
Dr. Paulman?
No additional comments.
Barbara Burney? Barbara, we're not hearing you.
Half the time it works and half the time it
That's
doesn't.
fair, as long as it works half the time.
Must be my MacBook.
Yeah.
No additional comments.
Thank you. Dr. Lofspring?
No additional comments.
And Elijah said he had to step out for a little bit. So if he comes back, we'll ask him. If not, we will not. So then we will go to the panel will hear summation, comments, or clarifications from the FDA. And they will have 10 minutes.
Well, I will only take 2. I just wanted to extend my sincere gratitude to all of the panel members for very, very thoughtful deliberations today, and for all of the time that you clearly put in reviewing the voluminous materials that you have received prior to this meeting. I also wanted to take this opportunity to express my gratitude to an incredible FDA team that has spent a lot of hours preparing for this meeting. And also wanted to say thank you to the sponsor for their collaborative and transparent approach in preparation to this panel. And that concludes our remarks.
Thank you. And then at this time, the panel will hear summation, comments, or clarification from the sponsor.
I just want to say thank you to the FDA and thank you for the panelists. It is a arduous job, and we're grateful for all of you and all of your extraordinary efforts. Have a good evening.
Thank you. So unless there's anything else I need to add, I would like to thank the panel, the FDA, the sponsor, and all of the open public hearing speakers for their contributions to today's panel meeting. Dr. Edelman, do you have any final remarks?
Thank you very much for an amazing job chairing this meeting.
Thank you very much. This meeting of the Ophthalmic Devices panel is now adjourned. Have a great evening.
Thank you.
Thank you.
Good night,
Thanks all.
everyone.
Good night.
You.
Thank you.